Good morning, everyone. So I think we'll be starting our first session, but I think we are waiting for the speakers. In the meantime, I thought let's introduce ourselves to each other. So myself, Dr. myself, Dr. Prafulla Maharana. I'm an associate professor at RP Center. My field is cornea cataract refractive.
I am Dr. Sameer Verma. I am there. My hospital is in Haldwani. It's by the name of Vedanta Netralaya. I am doing. It's a comprehensive eye care surgery center.
Myself, Dr. Sushil Ojha, Associate Professor Ophthalmology, Government Doon Medical College, Dehradun.
डॉक्टर पंक्ति आ जाओ.
Right. Myself is Dr. Mayank, and I am based at Handwani. I have a hospital in Kondrishti at Handwani from past 2004. Thank you.
Thank you very much, Dr. Prapul, Dr. Sameer, Dr. Ojha, and Dr. Mayank Pankti. So all of us are panelists and moderators for this session. So I think we'll be starting this session in another 10 minutes. ठीक है, Prapul?
Fine, sir. Then I think I would request audience delegates, please introduce yourself. Let's have a closed group meeting now.
है? हाँ, speaker तो है हमारे पास. So good morning and welcome to this beautiful UK SOS conference here in Jim Corbett, and which is always looked after by the delegates so that you have a beautiful scientific program as well as the Jim Corbett tours and all, seeing the tigers, which is the most interesting part of this conference. So I'm Dr. Rajendra Prasad, and I have with me our moderator, Dr. Mayank Pankti, and our panelist, Dr. Prafulla, Dr. Sameer, and Dr. Ojha here. And we have the list of speakers, all great speakers. And the first speaker, what I could see here is Dr. Inder Rastogi. Dr. Shashi Patnaik is not here. Dr. Ankit Agarwal is not here. So the next is Dr. Inder Mohan Rastogi. Are you ready, Dr. Inder Mohan? Yes. So Dr. Inder Mohan Rastogi will give a talk on SICS and arrow must and quiver. Dr. Inder Rastogi. Dr. Inder Rastogi is a well-known cataract and cataract surgeon. He's practicing in Gurgaon, and he's very active in most of the conferences, especially the Haryana Ophthalmic Society. He's president. He has been president, secretary, and many posts he has held in the Haryana Ophthalmic Society as well as in North Zone Ophthalmic Society. So let us see, Dr. Inder Mohan, please start your talk.
Good morning, all. Good morning, sir. Thank you for my introduction. Well, the topic is SICS, small incision cataract surgery, an arrow must be in your quiver, that you should be aware of this surgery, you should know it. Whenever you are in trouble, it can be a saver for you. So when we plan cataract surgery, we have to ensure that rock hard cataract, though the rock hard cataract man is sitting over here, but sometimes not for all the surgeons, not everybody is like Dr. RP. It can put you on the most dangerous road of the world. So surgical techniques, there are various techniques. One is ECC or ICC or but the modern machines, techniques, the safer viscose, phacoemulsification, they are safe. But SICS, need a special mention over here. It is a saver for you, sometimes in hard situations. Each technique has its own advantage, disadvantage. Which one is better depends on the type of the cataract, the surgeon's comfort, availability of the setup in the instruments and setup, and of course the full team, especially the vitreoretinal surgeon if there. So if all these things are not available, or sometimes you are in trouble or in periphery, so this is the surgical strategy you have to minimize the risk associated, and you ensure that the patient must have an outcome which is good or successful. So MSES serves as a stepping stone for performing good phaco for a majority of the surgeons, except the two steps are different, that is trenching and emulsification in phaco. So that is why this arrow should be there with you in your hard times. So it is a good alternative, as well as for if the case you are planning for ECC or something like that. So how the SICS is successful or good? That is, it is a low-cost surgery, less than 100 rupees, small incision. It gives phaco comparable results at the long-term follow-up, and in comparison to ECC, shorter operative time, less need for the technology, the good wound stability, less post-operative inflammation. Of course, with ECC, the patient requires less post-operative visits, and of course the endothelium is of course saved also. So there are few reasons why the rock hard cataracts, they are challenging, like in small eyes or granular problems or subluxation, or especially the strong capsulocortical adhesions in hard cataract. And of course these are the few comorbidities which the surgeon must know or must keep in mind while planning the surgery, especially the pseudo-exfoliation or non-dilating pupils or high myopes or phacomorphic glaucoma. So in such cases, standard of care may not be available each at every center. So that is why the things are there. So hard brown cataract is non-risk factor for PCR, vitreous loss. Not in all cases, but with when you are not planned or something untoward happens. So especially the lens capsule is thin, more fragile, and of course these cataracts, they occupy a large volume, and the beginner surgeon have less space to work in the usual place. So that is though you should have the supreme art of the war is to subdue the enemy without fighting. We don't want to fight in the anterior chamber or in the eye. So we should have a strategy plan. And of course, these hard cataracts, they require longer phaco times, higher energy levels, wound burns, and post-operative inflammation high is there. So the learning curve, on the other side, learning curve of the SICS for the most of us is easy and can be performed in all settings, less steeper and less expensive than phaco. So for such cases, we have to deal calmly, effectively, and of course without much drama. For hard cataract, phacoemulsification, yes, is challenging sometimes. That is why you should be aware and you should know the SICS art. So it offers a promising avenue for increasing surgical coverage in high volumes centers and training centers without sacrificing clinical outcomes. So it may be the preferred setting where surgical volume is high. So this is a small video that see the condition of the cataract. Yes, leaving aside the experienced surgeons, for the beginner, the technique or the phacoemulsification may be difficult in such cases. Capsule is very fragile. There is a lot of adhesions also. In such cases, yes, we should be ready to perform SICS if you don't want to compromise the outcome. Very hard cataract. If you do phaco in such cases, the corneal bun may be there. See the condition of the nucleus also. To save the cornea and to give the better outcome, the surgery can be done with SICS. Thank you very much.
Thank you, Dr. Idan Mohan, for the wonderful presentation on SICS and beautiful video. One important thing which comes in our mind, because whenever we talk about the SICS, is what about, the first thing is, when do you select your cases not to go for the phaco and take the cases for the SICS? Or you do SICS in each and every case of yours? Or
No, sir. We don't. I don't do SICS in each and every case. If the cataract is very hard, or patient condition is not good, or I think that I may be in trouble with such cases, I can convert to the SICS.
And say like you have a very hard cataract and that patient wants to go in for the premium IL implantation. So what is your take? Like, you go ahead with the premium IL in these cases also, and how do you get the results in these cases?
No. Of course, if the patient demands that only and only phaco is to be done, of course, I will do. But if the cornea is compromised, or I think that the outcome will be difficult, of course, we can always do SICS with premium IL.
Yes, Dr. Gaurav. Yeah.
So I think brilliant talk, because SICS is really, of course, India has led the pack on this. So there's no doubt about it. Even in my practice, now if I have a black-brown cataract, I know I can do a phaco on it, but I immediately refer it to my, SICS surgeon, who does a great job, and I tell patients that he'll do a better job than me. So there's no doubt about that. There are certain situations which demand. My only submission is that, when we talk about the cost of cataract surgery, so we, in our minds, of course, it says that, we have no expense, you can do it free of cost, right? What happens is that, this same thing can be that 100 rupee thing. We are three things that can go wrong with this. We are belittling our efforts. We are not taking into account that the surgeon has a huge role. I think we should assign at least 5,000-10,000 rupees just to the surgeon's cost. Why should a surgeon be working free of cost, right?
No.
And then even if we look at, I'm just kind of, this is in good humor only. I'm just saying, I'm not criticizing, or I'm not kind of trying to find fault. It's just that, for our own professions, this thing, the government, somebody, your talk is being streamlined, is being, sent on video streaming everywhere. Now somebody will pick this up and say, oh, the cost of SICS is just 100, insurance, CGHS, ECHS. They will fix the cost of SICS as maybe 500 rupees, saying that inki cost to 100 hi aati hai, let's pay them 500 rupees for the surgery, right? So whenever we say this, we know that, we have to be careful in wording, because, BSS will go into it, viscoelastic, disposables, NEBA standard, OTs, maybe 50 lakh microscope you'll still need. So I think in just that, in your next talk, you can say that while, the cost may be very small, but the results are tremendous. And, in fact, we should say that the cost of surgery with SICS should be almost the same as phaco. We should not differentiate the cost at all, and that should not be the factor of, talking about the procedure.
I missed it. It should be in government setup. Yeah, I can write down.
Even for that 100 rupees, you can't do it. Make it information.
Yes, definitely, sir.
Take it around 500. That's will be little nice.
Definitely, sir.
No, I just like to add one thing. आप देखिए even surgical branches में कौन से surgeons हैं जो millimeter में काम कर रहे हैं. In fact, if you realize, हमारा ब्रह्मांड, हमारा पूरा ग्लोब 2 से 4 मिलीमीटर है. हमारी total space, आप just go to the depth of it. We are the only specialty in whole medical fraternity where the whole world, the universe, the galaxy is 4, 5, 6 millimeters.
Yes.
So just skill required by an ophthalmic surgeon is anyway different than I think a cut above the cardiac or your maybe neuro comes a little bit nearby, but so we should charge super premium for what we do.
Definitely.
Another thing I feel, just one more point to what Gaurav added. When we talk of cost, it's not only the cost of the material. There's electricity, there is water, there is staff, there is air conditioning, there's so many things in it. So that's a beta. So whenever you calculate that, if you say if I'm earning 10,000, my cost is 1,000, it's never like that. So I feel that never, as rightly said by Gaurav, never mention a cost because somebody will calculate.
Definitely, sir. I'll take care.
True. It's not the material cost, it's the surgeon's cost, which is very important because whether you do SICS, you do phaco or whichever surgery, the surgeon is more important. If he's expert in SICS, he should charge his surgeons people. So there should not be any compromise in the cost.
People
Dr.
are
Praful,
charging.
you want to
People
make
are
any
charging
comment?
for that also.
So I'm not going into this cost aspect, but we did a study along with Ministry of Health at RP Center, and you won't believe 80% of surgery in India, cataract surgery is SICS or ECC. Only 20% have phaco. So SICS is as important as phaco to learn. And premium IOL, I have seen, I was at LVP Hyderabad for a short period of time. They used to do all sorts of multifocal, all IOL with SICS, so that's not an issue. So it's unfair to say I'll prefer phaco only if I have a choice. If you are a good SICS surgeon, you can continue with that. No need to learn phaco unless it gives that wow factor with the patient. So SICS is as good as phaco. Even studies have proven that if nuclear cells is grade 3, above than grade 3, SICS, the endothelial cell count loss is quite less compared to phaco.
True,
so
true.
Cost shouldn't be a factor at all. SICS and phaco, that cost should be equal.
So surgeon should learn all the types of the technique. Yes. So our next, thank you very much.
Sir,
thank you, Dr. Indra.
Sir, how to counsel a patient if he wants premium IOL and he has NS5, NS6 cataract? So
that is what the discussion is going on. Like because when it comes to the patient, so you have your counseling of the patient. Whether if you are expert, if you can give the good result with SICS, you can definitely go ahead with the SICS. But if you think that you cannot give good result with the premium IOL with the SICS, then go in for the phaco.
Yes.
So it's your surgeon's choice and surgeons how you counsel your patient.
I have one disclaimer. So Dr. RP is doing maximum multifocals in Delhi, so he should give the tip. Please. So I've seen so many patients, he's doing multifocal from last 10, 15 years.
Yeah.
Maximum number of cases of multifocal trifocals.
In my practice, almost now 80 to 90%.
Yeah. So how you
multifocals.
counsel patient? Patient don't fight in post-operative periods?
Thank you very much. Thank you, Bhupesh. I think we'll go ahead with the next speaker now, Dr. Kamal. In the meantime, Dr. Kamal, are you ready? Yes. Dr. Kamal Kapoor is going to give us a keynote address, and Dr. Kamal Kapoor, you know very well. I don't need to introduce him. He's a well-known person, and he's going to talk on.
The topic would be a cut above the rest: the science and art of incision making. It's a keynote address today, and the first keynote address for the day. Welcome, Dr. Kamal.
Good morning, everybody.
And our next speaker should be ready on that side. Next speaker is Dr. Ritu Arora. Yeah, Dr. Ritu, you be ready on that side, okay?
Thank you. A very good morning. I'm sorry I have a bad throat. I think a lot of chilled alcohol down my throat last night and a late night. So I must thank the Uttarakhand Ophthalmic Society for calling me over to this beautiful, amazing place, and it's always a pleasure to come here and meet old friends and share learnings and cross-learn from each other. So my talk is going to be restricted to, of course, phacoemulsification, especially after a little heated debate on SICS. So I'll be talking more of on phacoemulsification. But yes, the same rule probably applies there too. And answering your question was that, when a patient does insist on a premium IOL and he's weighted to grade 5, let me tell you, he's not a guy who has huge expectations, number one. So case rest assured, vision recovery thoda delayed hai jaise hai. Anybody who can wait for a hypermature or a grade 4 cataract, grade 4 cataract, 5 cataract, I train my colleagues that, you know, this is a patient who's quite laid back. Otherwise, he wouldn't be sitting here. You need to fear patients who are 6'6" or 6'9" and coming to you say, I can't drive, I can't do this. These are the patients to watch out for, number one. Number two, what I tell them normally is that you have to go to the destination. मैंने आपको ताजमहल में पहुंचाना है. फेको फेरारी है और वो मर्सिडीज है. Comfortably दोनों पहुंचाएंगे. वो थोड़ा जल्दी पहुंचा देगा शायद. That's it. So you don't underrate SICs in my organization also. We never say it's a Toyota. We say it's an S-class Mercedes and that's a Ferrari. वो थोड़ा speed है, बस that's it. But दोनों में आप बहुत comfortably, बहुत बड़े अपने destination में पहुंचेंगे. And yes, we are doing premium lenses even with SICs. Now coming to my topic. I'll be talking about the art and science of incision making. This is a topic a lot of time, you know, it's missed. We talk about technologies, but this is one place, if you take the flax out or the femto out, this is where your surgical skill, technique, knowledge actually plays through. So I have no financial interest in anything I'll be talking about. Now, what does a bad wound do? What does a bad wound do? It gives you probably a bad wound, stretch wound, wound tear, increases your astigmatism, enhances your astigmatism. You have early post-operative folds which are astigmatic in nature. So the first 5-7 days of the patient's recovery, patient is not happy. He is not having clear vision. So the wow factor goes. So even if you've taken a huge amount of charges for your surgery, but just a bad wound gives him a bad experience. Leaky wound would lead to infections, PC rents during surgery, stress, a lot of stress to the surgeon during the surgery, of course, frequent iris prolapse and iris sharpening. Now, incisions can be divided on size, site, type. Usually it's said 2.8 and below are astigmatic neutral. You could have a clear corneal, limbal, temporal, corneal, axial. Axial means on the axis of steep axis. You need to know what should be the tunnel length which you're using for what kind of astigmatism. Suppose you're having a superior placement of incision, do not go in for a long tunnel because it induces a lot of corneal folds. What would a temporal incision do for us? So we'll just breeze through all of them with a lot of videos. So what is an ideal incision for me? It should allow an easy access. You could make the best incision possible if during the surgery you're struggling, it doesn't give you good access. That's not a good incision. It should, you know, give a good chamber stability during the surgery. So even during the surgery, you shouldn't be worried or focused more about the wound or management of the wound. And it should heal as fast as possible with as comfort and least astigmatic induction. So these would be the things which I would say a good incision is. The goal is always to achieve a good uncorrected visual acuity and minimize surgical induced astigmatism and if possible reduce the pre-operative astigmatism. So let us understand when we do incisions, what could be the potential placement. So you could have a surgical limbus which is approximately 1.5 to 1.75 millimeter. You could have an anterior limbus, mid limbus, outer limbus. I prefer mid limbus. I do all my surgeries on the mid limbus. Me and Gaurav were discussing yesterday. Even if there's a little ooze from the conjunctival side, I love it. I welcome it because it heals my wound faster. I have a faster epithelialization. The moment I start moving towards the anterior limbal line, my incisions are delayed. I have more corneal folds and they do look ugly on the slit lamp. So posterior limbal line, mid limbal line, anterior limbal line. We all know usually the horizontal corneal diameter is longer. So by default, making a temporal incision induces lesser astigmatism because it's away from the optical axis. So these could be the different sites where could you plan your incisions. So what are the prerequisites? Always have a little tight globe. Having a little hypertonic globe with the best of blades will not give you a good incision. The blade should be sharp. There should be proper direction, the vectors. You should always try and have a counter force when you're making with a keratome, something to stop your eye from rotating, otherwise you'll have a jagged incision. Preferably a good idea to use a blade which is anti-glare. And ergonomics, I prefer the angle between anything between 20 to 45 degrees because it keeps my wrist free. The moment I go 180 degree, my wrist is locked, and if I need to rotate my wrist during the surgery, it blocks me. So it's like playing a good game of golf, how you need to keep your left and right hand and shoulders free. So what are the kinds of incision you can have? You could actually have a limbus parallel incision. You could have a straight incision, and I'm talking about the entry point of the incision, or an anti-frown. Ideally, the best incision would be number 2 for me. Number 3 causes more astigmatism. Number 1 looks good, but it is slightly leaky. So number 2 would be a good incision. Now, advantages of a temporal incision. Why I prefer temporal incision would be they are more astigmatic stable. there is lesser of obstruction. If you're operating superiorly, the eye tends to roll down. When it rolls down in the fornix, there's pooling of blood, pooling of BSS. That causes a back glare. Number 3, you lose the red glare because you're not coming from 0 degree axis because their roll down movement is very hard. Number 4, the orbit stops your phaco tip and the hub, and it doesn't let you kind of go straight. So you need to roll the eye down to work there. And number 4, there less chances of bleeding on the temporal side. Ideal length of temporal incision is 1.75 for me. Anything between 1.5 to 1.75 I play, and it does a great job. Different kinds of incisions. You could use a uniplanar incision. It causes lesser irritation, but yes, the outer flap is thinner. You could have a biplanar incision. I usually do this. Biplanar incision is thicker outer flap. It does feel, you do have a foreign body sensation for first 2-3 days, and then you have a triplanar incision, and then you have a hinged incision. The hinged incision technically is supposed to be most safe, resistant to pressure. So when you are operating mentally challenged patients, where patients you don't know, very old patients who will not kind of withdraw from rubbing their eyes, children, all these patients, it's a good idea to go in for a hinge incision. This is rock solid. Once you hydrate it, it never leaks even if you press it. So as we've discussed this, now these are the few complications you could have if you had a bad incision. Descent detachment is one of them. Now DMD is often, yes, seen in patients who are more prone to it. They have endothelial disorders, Fuchs dystrophy, bad corneas, but yes, bad incision is one of the biggest causes of DMDs, and followed by used phaco sleeves. Used phaco sleeves with bad compliance are second most common cause of DMDs. Now this is how a bad wound while moving, can look like on slit lamp. Looks very ugly. While just before the entry, probably the patient has moved or something wrong with the surgeon. So on your left, you see the chevron incision. It causes more astigmatism. So this patient sometimes may come to you with dysphotopsias, especially if this tunnel was slightly longer, you'll see it casts shadow onto the pupil from the side. You can see the shadow going right across the optical zone. So these patients could probably report with dysphotopsias to you. So it's not a good idea to have longer tunnels with bad flates, and especially if you've made a clear corneal incision. So if you have a clear corneal incision, make the tunnel short. But if you have an outer limbus or a limbal incision, you can have a long tunnel. Now these are again situations where the RK, so DMD, classical ideal incision, chevron, I'll just go to some videos. Now placement of 2 ports ideally should be anything between 60 to 90 degrees. Do not take the ports much away, because that takes away your ergonomics. You need to lift your shoulder to operate. You'll tire if you're doing 20-30 surgeries a day. You'll tire because your shoulders are unsupported. And if they're very near, they'll be entangling with each other. So peripheral to the limbus. Now this would what be a beautiful incision should look like with a good blade. These are the ergonomics. When you're making the side port, make sure there's a counter pressure from the opposite side. You could use a cotton bud. You'll always get a cleaner wound. The angle, as I said, is 2 to 2.5 clock hours away between 2 incisions. Now this is what a good blade should do. This is what a good blade should do for you. No pressure, just see. Just a good tight globe, and there you are. That's what a good incision should be. Clean, smooth, sweet incision, no bleeding. Now I'll just jump videos again. There. No pressure, good blade, you go through straight. Now this is a blunt blade. Most of us sometimes will be seen doing this. We do this serpentine movements. A lot of times I tell my people who join organization coming from other institutions, they are so used to this. तो मैं बोलता हूँ कि सांप क्यों चला रहे हो wound के अंदर? They go like this. Even if the blade is very good, that's a bad habit. That cuts the fibers in different directions. You have far more induced astigmatism. And see the chevron. See the chevron. You can see the pointed part inside. Most of us, when we move the blade from side to side, create a chevron. Because we do not have one plane, we've created many planes. Iris prolapse would be a result of a very short tunnel, and it will keep troubling you all through. Side port, I'm not showing these videos. Side ports, descent detachment is one of the most common and most ignored. DMDs on the side port are up to the tune of 80 to 82% if your placement is not right and you're not conscious of how you're introducing the instrument from your side port. Blunt blade, this is one video where, one entry has been attempted and didn't go. Patient moved, second attempt, and now you see there are 2 flaps in the wound. Now this wound will not seal properly. So this can happen, so it's always a good idea to use a good quality blade. Now angle of entry is bad. See, this is what I mean by a bad compliance sleeve. Entry at a wrong angle. Recipe for descent detachment. See, it's a used sleeve, very bad contour of the sleeve. So this causes descent detachment. So we will see the DMD now. There, can you see that? Can you see the descents moving there? So this is a bad sleeve. So we all think ki sleeve purani hai, chalti rahegi. Nahin. Bad sleeves will cause compliance problems and they will cause a lot of issues for her. Now this is a thick blade, shallow entry. See what it does to the patient. It's a very thick blade. So thick blades will give you a very shallow and a short tunnel. So see, now we will see what this case does for us. We'll go to the next one. There, see, now the same case, thick blade, and see, the iris will keep coming out, it will keep coming into the wound. There, it's tending to come out, so it will keep bothering you. And another thing, see the side port. The iris is also going to the side port. So when I talk about incisions, I'm also talking about the side port incisions. They can, if you have a iris coming to the side port again, they'll cause the pupil to go smaller. I think I'll just skip.
Kamal, you'll have to now.
Yeah, okay. So, thank you.
Thank you. Thank you very much, Kamal, for the wonderful presentation. And this is, I think, one of the most important steps when you're starting the phaco-cataract surgery. If your incision is perfect, the surgery goes very well. And if you have any problem,
can we have the next speaker, please?
Incision and
next speaker.
Ragged incision. Dr. Ritu, please. So next speaker is Dr. Ritu Arora, and Dr. Ritu is going to talk on.
Dr. Kamal, so what is your take on trapezoid incision, where they make the inner lip slightly bigger? So is there any advantage, or is it just?
I think when you're anticipating a lot of movement, when you're doing black-brown cataracts, it definitely helps. Definitely helps because it gives you more space to work inside. Yeah. Definitely, that's a plus point there.
Thank you.
Actually, I wanted to discuss 6 more types of incisions, but with videos.
Thank you, Dr. Kamal. Welcome, Dr. Ritu Arora, and she would be talking on managing post-op refractive surprises. Please.
Thank you very much, and a very good morning to everyone. At the outset, I'd like to thank the organizers of Uttara Eyecon, Dr. Gaurav Luthra and Dr. Saurabh, for giving me this opportunity and the wonderful hospitality. So after a wonderful talk, it's always difficult to follow up after Kamal. He's so much full of energy. And I'll be talking about managing post-op refractive surprises. As we know, refractive cataract surgery is now what we are all aiming to. And we have patients whose expectations are really sky high. We are promising them spectacle-free vision. We are, now moved largely to doing premium IOLs. And even in spite of all the technology, the IOLs and machines, and having such a good understanding and assessment of the biometry, we still fall short. 85% of our patients are within plus minus 1 diopter and 55% within 0.5. But these kind of results which were satisfactory maybe a decade back no longer hold true. And what we need to do is to hit the bullseye and to have majority of our patients within 0.5 diopters. Whether we can reach 100% is still, I think, a dream and maybe not possible right now. So what is a refractive surprise? It is when we are not able to achieve the intended post-op refractive target. And there's a difference between what we are planning pre-op and what the post-op result is. Having any kind of error more than 1 diopter is really not desirable. And there may be just a gap between what the patient's expectations are and what the result is. For example, if you have a myopic patient who may be 6'6", you think you've done a great job. The patient is really unhappy next day because he's no longer able to read, which he was able to do prior to surgery without glasses. And even with multifocal IOLs, we think we've done great, but they are very, very sensitive to even small errors. So how do we manage these refractive surprises? I'll be just running you through a few of my own ways of doing it. And proper counseling is extremely important. Whether you do it yourself or you have a counselor, you should never ever promise spectacle-free vision. Always say that the dependency on glasses is going to be minimum, and it also depends on what the machine measurements are and the individual healing. So that way you take the pressure off your own surgery. And no eye ever has a 0 power. You may be 6/6, but you don't have a refraction of 0. So you always say that fine-tuning may be required with glasses, and it's important to get this on your consent form also, especially where you're doing premium surgery. So how do you manage? There are certain eyes which are at greater risk, and we need to identify these eyes, whether they are hyperopes, myopes, whether the patient has dry eye. You must manage it very well before surgery. Whether there is a history of refractive surgery, if there's any kind of corneal dystrophy. And, you know, I'm with a retina surgeon, so I often handle patients who are post-vitrectomized with silicone oil. These cases are definitely at risk for having a refractive surprise. Long-term contact lens users and any patient who has any abnormality in their K reading, very high, you know, steep, flat case, because that kind of affects your effective lens position. And, you know, it's, ELP is still one of those barriers to getting a perfect result. And of course, cases with subluxated or pseudo-exfoliation, again, there you may have a refractive result, surprise. So how do you avoid it is, of course, having your biometry really spot on. It should be done before you do any kind of manipulation to the eye. Ideally, we should all be shifting towards optical biometers. I think we have a wide variety available. They're all very good. But if not, you can easily do an immersion scan that is equally good. I think contact eye scan is something that we should now gradually phase out of our practice. I mean, unless, you know, you have one operator who is looking at each scan very carefully and deleting the ones which are not ideal. Make sure you don't do any compression or off-axis measurement. There are certain red flags, certain when to repeat your biometry whenever you have any extremes of axial length, extremes of K, or you have an astigmatism of more 2 diopters, or if you have any difference between the two eyes. So even if your patient is pseudophakic, always measure both eyes. Because, you know, the information that you get from the other eye will guide you as to whether your biometry is correct or not. And of course, cases of dry eye and refractive surgery, those are again cases where you need to repeat your biometry. You may do it on 2 different methods, or you may call the patient again and do it again. So Holiday had given certain red flags, and he says that any case where the binocular predicted IOL power is of more than 1 diopter difference between the 2 eyes, or an axial length of more than 0.1 mm difference, or a K reading of more than 0.5 diopter difference between 2 eyes. Such cases can be at risk of having a refractive surprise. And in optical biometry, we must look at the K reading and see whether your, you know, standard deviation should not be more than 0.2 diopters, and the axial length signal to noise ratio should be more than 15 to 20. So if you look at these things, we can better predict how accurate we are going to be. It's important to track your outcomes. It's something in a busy practice we forget, and we should try to personalize our less constants. And not only what you're following, but the important thing is to train your staff. You must guide your staff to follow all the protocols, because after all, you're not doing your biometries and K readings yourself. So it's important from time to time to, you know, sort of refresh them. So how do you select the lens? Now, again, using the right biometry formula is important, and we have excellent options available today, and we should use the one which is correct for the kind of patient that we are doing. And my go-to has always been the Barrett suite. I think it gives me a lot of peace of mind along with the RBF. And you need to also select what kind of refractive target you're aiming for. Do you want emmetropia, or are you aiming for slight myopia? And depending on what kind of lens you go for, you may choose the closest minus or the closest plus option. Of course, there is a problem that the current IOL powers, you know, come only in 0.5 diopter steps. And I think the industry needs to now move to 0.25, because that's a major limitation with the kind of refractive surgery we want to do today. So have a surgical safety checklist. With NABH, we've all learned to have a timeout to confirm the patient, the eye, the IOL. Always have your toric IOL sheet easily available. And the pre-op, you know, whether you're going, what kind of incision you want to make, that also needs to be defined beforehand. So you can always make a little note at the time of surgery. You have a pterygium, or you have something that you want to avoid. So make a note, because you've seen the patient on the slit lamp. You must start your planning at that point itself. So surgical perfection, we all know we need to do that. We need to analyze the problem, wait for a little bit of time. Can I have another minute or two? Yeah. Okay, check the patient's records and see whether there's any error. Discuss with the patient if he's unhappy, but if he's not complaining, you should manage conservatively. And always do a dilated refraction to see for the IOL position whether, there's any capsular distension syndrome, is there any slight nebulocorneal opacity you may have missed out, or check for the OCT to see if you've missed out something pre-op. So analyze the problem, be kind to the patient. You need to have a little more chair time in such patients. Reassure them that you can provide a solution. It's just the timing and cost that needs to be discussed. So how to manage the various methods to do it, but you must know the magnitude of the error, the attitude of the patient. Is there the status of the other eye? Can you, cover your error in the other eye? And also, do a good refraction, because you may have a new optometrist who may have done a wrong refraction, and repeat the biometry. So it depends on whether you want to go for a cornea-based management. That's very good if you have small errors, and safer in eyes which have already been yagged. And of course, there are disadvantages of cost and other things. Or you may go for a lens-based management, where you may go for an IOL exchange or a piggyback. Again, it depends on the kind of error, what is possible. If you have a large error, then you have to go for an IOL exchange. But you can plan it out at an early stage. It all depends on what is the situation. So I'll just run you through two small cases. This was a 65-year-old female who had MGD, who had allergy to T+, so the pupil was not dilating well. And I planned a EDOF lens for her on the first post-op day. I was shocked to see that her vision was only 6/36, in spite of a very well-done surgery. And we looked into her record, and there were two patients who had similar name, and the optom had put the wrong sheet so the patient was taken up for an IOL exchange. And I think this is something that we all need to now understand, that IOL exchange is nothing to be very scared of. It can be done very safely. You should use a good viscoelastic, and there are very good techniques. Either you can do divide the lens into 2-3 halves, or even if you do it a 90% cut, you can dial the lens out of the bag very easily. So that's what we did for this patient, and she was taken up for an IOL exchange after 2 days, and instead of a 23.5, we put a 26.5, and the patient was 6 parts N6 the next day.
Thank you.
Okay, so I'll skip the second video, though this patient was a toric patient, and she was planned for T4 IQ at 1115 degrees. And unfortunately, we put it at 15 degrees, so I just took her up very easily the next day, the patient, and dialed the IOL, and we had a good result. So just to conclude, prevention is always better than cure. A pre-op counseling is very important to set the patient's expectations. A careful biometry, careful IOL selection, and a surgical timeout are essential to prevent what are avoidable errors. But the barrier to 100% success is predicting the effective lens position, the absence of having the IOL power in 0.5 diopter steps, and in spite of our best efforts, even in high-risk cases, you will have some errors. So of course, we don't have the light adjustable lens as yet in India, but once that is there, I'm sure our surgical outcomes are going to improve. Thank you very much.
Thank you, Ritu, for the wonderful presentation. Just a small query. The first case which you showed in the last, the IOL exchange, how did you calculate the IOL, which IOL has to be put after the exchange?
No, we already had actually. The biometry sheet was incorrectly put. The two patients' biometry was exchanged.
In a situation like if it was correct.
Even if it is correct, I don't think there's any problem. Even with
if
your lens in place, you can always...
If it was correct and you get a surprise, suppose you got this +3 diopter.
Yeah, so then once you've done a very accurate refraction, but in that case, you'd have to wait for some time for the refraction to sort of settle down. And then
any calculation method to do that for that?
I'm not aware of any calculation method.
So
I think you can do your biometry.
One very simple technique, because you have to, if you have a say +3 diopter, you just take half of that, half of the actual power, and add 1.5 diopter to that.
Okay.
0.88. So then
I
you get
think the points
the
make are
IL
very clear.
exchange, the exchange power will come up.
See, we must not forget the biometry machine is still available with us.
Yeah.
So even with the IOLN, you can do the biometry.
You can do the biometry again, that's
and
exactly.
then in case you don't have an access to an optical biometer, to be very precise, you can use this multiplier effect. But I was just sharing with Kumar, for last 6 years, we've never explanted single lens because, you know, I'll name a company, no commercial interest. Sensors gives you till -10 and high plus powers. 3-piece lenses are so beautifully put even in a hypermetropic patient. They don't cause any problems. I think we are a living proof. Hundreds of these patients done over so many years. We don't explant lenses now. So I think this is a caveat for all people. You can use a 3-piece lens in the sulcus. If there's no yak top
No,
slot
but
me.
that's what I'm saying. What is the, I mean, there's nothing to be scared of explanting a lens
know.
if it is done early. It depends on the timing. If it's, you know, your patient is coming to you after a couple
Within
of
1
months,
or 2
then
days,
there
yes,
may be
but
a issue.
not everybody is Ritu or Dr. RP because there are different people operating in different centers. So if you let them loose to explant a lens, a junior colleague, you have a corneal edema XYZ, so it's always a better. So I train them in piggyback how to do it, how to calculate it. It's a idiot-proof technique.
True. Now we have a very beautiful piggyback IOLs coming up, and even not only piggyback IOL. Now we have done few cases where there was an IOL surprise, refractive surprise. We have put IPCL. The phakic IOLs can work over the natural, over the actual IOL also, because that is one of the way I think we can do.
I think
but IOL exchange should come at the last option. Like if at all we don't have any other way to do that, then
I think it depends on the stage.
But as you have shown, because early stage, IOL exchange is not a difficult job, because we can very well do the IOL exchange also. It's the techniques have become very, very good now, because we can very easily take out these IOLs.
I think piggyback also one should look out. I mean, there can be interface problems.
That's true.
No,
yeah.
That's
no,
true.
with the newer piggybacks, we are not getting those problems. And the calculation is very, very simple. If you want to exchange, you may again get surprise also.
Yeah.
There are a possibility. So we got a lot of options. We should not restrict to one.
Yeah.
It depends on the patient to patient whether we to change the IOL or if you want to put a piggyback lens, the calculation is very, very easy.
True. Even the surface procedure, like we can do the LASIK, PRK, or anything can be done with lower power.
The
like
reason is that's not depend on axial length or keratometry or anything. It's just the specs power.
Right.
Suppose the patient got -2, you put a -2 there. If patient has +2, you have to put a +3 there.
Right.
So
right.
calculation is very simple and based only on one factor. So chances of getting a wrong is much lesser than exchange. Of course, exchange is always the option with us.
Yeah.
And the only thing she clearly pointed out that we should use a good viscoelastic. Our instrument should be very, very sharp. If you are not comfortable, you can increase the incision, take it out without cutting.
True.
That's much easier than hardening
True.
it.
Thank you, Doctor. Call up the next.
Thank you, ma'am, for wonderful talk. Now I want to invite our next speaker, Dr. Shivani Patnaik, who is leading cataract and refractive surgeon in Mumbai. She will be talking about anterior biometry, case-based discussion.
Good morning, everyone. Thank you for the introduction. I thank everybody from the Uttarakhand Ophthalmic Society and Dr. Gaurav and Dr. Saurabh Luthra and Dr. Kumar Doctor for giving me this opportunity. So my talk is on the biometry aspect of Anterion, and so just getting into it now. So why did we require a new system for biometry? So since I work with someone who loves to explore new technology, as we all know, Dr. Kumar Doctor, we have worked with Aladdin, Nidec, ALScan, Zimmer G6, and now we have the IOL Master and we have the LensStar and the Anterion. So why did we require Anterion as a new system in spite of having LensStar? It is an all-in-one system. So we have explored all the aspects of the Anterion. We have done topography, aberrometry. We have used this as an excellent ASOCT and the biometry. So initially we had purchased for the biometry, and then later on we started exploring all the modules. I would like to talk about the biometry today. So it is backed with SSOCT. Swept source OCT is known for depth of penetration. It has a wonderful 1300 nanometer wavelength. Resolution is less than 10 microns. It gives you excellent scans, multiple scans, and very short acquisition time. So error and movement time is also not much. It captures are excellent. So here we can see a difference between SD and SSOCT. It is time consuming. SDOCT, SSOCT is much faster, deeper penetration, more details, and gives us excellent images of the lens for better planning. So why SSOCT? There were studies, and all the studies have come to a conclusion that because the lenticular changes are visible, they are comprehensible in a much better manner, it gives us a better planning platform. Also, biometry is much more accurate. There are 50,000 scans per second, 65 radial scans are taken. So we are measuring more than 16,000 data points all over. That gives us the entire corneal accurate biometry. Corneal planning is very, very important in terms of biometry because that is where maximum errors are noted. There is no range for keratometry. It can penetrate through very mature and hypermature cataracts as well. We can, of course, increase or decrease the intensity of the target for fixation. We can also add the refraction of up to plus to minus 15 diopters. It gives us an objective fixation check. We have to have certain parameters which have to be completely aligned in order to accept that scan as a proper scan. So this fixation check tells us how much movement is going on. Active vertex tracking is going on for all the measurements. Detailed measurements give us a corneal analysis, AC depth, lens thickness, and axial length, all important for ELP, all important for my accurate biometry. The entire anterior chamber is seen. Now in some cases where we cannot get the axial length by automated method from the machine, we do get peaks. We can measure the peaks and manually enter the A-scan, the axial length. So precise axial length and precise A-scan. We can change the mode of the capture even after capturing the eye. So after capturing, we can go from phakic to phakic IOL to aphakic, pseudophakic, silicon-filled eye. That gives us the range completely. So IOL power calculations are very important, as we saw in the previous talk, to prevent post-operative surprises, especially when we are dealing with premium IOLs or any IOL for that matter. Nobody likes a post-refractive surprise. So corneal keratometry is the most important culprit that we have to deal with. That is why we require a very accurate keratometry. Now, my keratometry sheet looks like this. So if there are, so both the eyes I can look at the same time. The total corneal power is given, angle kappa is mentioned. We also have the corneal wavefront right there to look at for higher order aberrations and spherical aberrations. We have the axial length and the white to white. So we have a built-in Barrett universal suite. We have a toric planner all rolled into one. I'm aware that many other machines also give this, but this gives us a complete range of how to plan the IOL, the ELP, and the whole package. So the toric planning is seamless. We just enter the incision, we get the surgically induced astigmatism. The incision can be set manually. Just carry the sheet to the OT. We can enter, as I said, axial length can be entered manually. So premium IOLs always have the upper hand. So now total corneal wavefront is very important. This is a feature that we have used a lot and depended on it. We also have a pentacam with us, a topographer, where we look at the higher order aberrations. We have a Keratron Scout for the aberrometry. But whenever we compare, we've seen that the total corneal wavefront gives us a good reading of the spherical aberrations and the higher order aberrations, which is dependable for doing our premium IOLs. We have a good number of multifocals that we do. So the corneal data for IOL selection, we get the anterior posterior curvature as it is with the topographer. We get all the maps. We can look at the entire surface, the pachymetry, the refractive index, and then we get the total corneal power out of that. So just wanted to show some experiences of calculations with Antirion and Lenstar. No financial interest with any. So we had a NIDEC AL scan, but it would give us very good axial length, but it would not give us a good keratometry reading. And now when we started comparing, we always perform an Antirion and a Lenstar and the pentacam to see the curvature. Now there was a series of odd incidents where the keratometry readings were poles apart among the three machines. So we decided to stick to Antirion readings in all of them. So this was the kind of difference that we were getting. Some axes were completely flipped. Some of them were showing exactly 90 degree or 180 degree apart. So that creates a lot of confusion in your mind as to what to select. It's not like one is bad over the other, but we selected the Antirion in all the 5 patients, and you can see the results. So it was a trifocal toric in all the cases. It was 6.6 and 6. The astigmatism was showing us 2.25 on the Antirion at 59, and Lenstar was 1.75, 1.5, all different. So coming to a few cases here, this is a person who came for cataract surgery. He wanted a multifocal in both the eyes, very demanding, no history of previous refractive procedures. So this was a few detail. He had a long eye, 23.88, and the white to white was 12.4, 12.5. We did the Barrett, SRKT, and the Hill RBF, and everywhere it was showing around 23 to 23.5 diopters. So we decided to go for the 23. And the post-op result was 6/6 part and N6. So bang on results every single time and repeatable results. Again, this is a hyperopic patient. The previous was a myopic. In hyperopic patients, we have to keep the AC depth in check because that can change your ELP and cause very bad refractive surprises. So prediction is very important. So this guy also wanted a cataract surgery. You can see with the imaging module, I have mapped the angles and it is visible. Sorry, can I take a minute? Yeah. Thank you so much. So the angles are completely narrowed. We went ahead and we did the anterior and we found out that the AC depth was 1.92, very shallow, to 21.3, probably short, and white to white was also small. So again, we went on with our calculations with the Barrett suite and we followed 31 as the power. Now we did a Technis multifocal, 31 with a 3.25 add, completely happy, 6/6 part N6. Now this is the third case, my final case. It's a 55-year-old post-refractive. Now for post-refractive, Antirion does have a formula called Oculix where it uses ray tracing to give us the formula. So it is a little more accurate, but we also do the ASCRS and the ESCRS for the same. So we planned for a multifocal IOL, 24.29 long eye, and a deep chamber. Again, that plays an important role for ELP. We implanted a 22. Antirion gave us 22 and so did the others. So it was repeatable and accurate all across. We chose the Antirion results are in front of you, 6/6 part. Patient is happy the next day. Thank you very much. Just wanted to highlight the importance of having a good optical biometer for premium results and biometry as a very important aspect in planning the surgery. Thank you everyone.
Thank you, Dr. Shivani, for wonderful talk on latest biometer. Now I would like to invite Dr. Rajendra Prasad for next talk on when lenses go wrong, pearls and pitfalls of IOL exchange.
If one has slight differences in keratometry reading on, say, your autorefractometer, your lens star or IOL master and pentacam, leave aside Antirion. So I'd like to ask the panelists, which reading would you select?
If you're getting a multiple reading, you have to look for the cause first. Whether the ocular surface is proper or not, that's the number one cause. Number two, whether your instruments are properly calibrated or not. I've often seen people have got very best equipments, but they are not managed properly. So we have to look for the cause also, if there is any discrepancies too much. Otherwise, I think it's a personal choice.
So between lens star and say pentacam, if you have to choose.
Pentacam, if still confusion, go for EKR reading. And now the studies have clearly shown the zone between 2 to 3 EKR reading. That is quite perfect for any cornea, irregular cornea.
Mike.
No, that's true. But
reading of pentacam is good, but not always. And lens star measures only a few points.
no, lens star measures. No,
IOL master
it measures 2
700 is
rings.
better
It has
in
more
that
than
aspect.
32 points.
That's all. That's very less.
It measures the central 1.6 also. So I mean.
Previously, lens star was a gold standard.
No, of course, I'm saying Antirion, if you don't have access to that, I mean, if you have a choice between your pentacam and your lens star, if the readings are slightly changed.
Lens star.
Then follow lens star.
That's what I'm asking.
Then follow lens star.
Thank you very much. Good morning, friends, ladies and gentlemen. First of all, I'll thank you, UKSOS, for giving me this opportunity to be here with all of you in this beautiful morning. The talk which I'm going to give is IOL gone wrong, because we have 2 talks before this, and you all know that for an ophthalmologist, one of the most satisfying procedure of the profession is the cataract surgery and implanting IOLs, and that to the premium IOLs, and offering the patient what he expects. Yet we know that every rose has its thorn. And for cataract surgery, it is the most frustrating situation when you have to do the IOL explantation and put a new IOL, or you come across a very high IOL refractive surprise. So that situation, how to deal, because I'll just go through a series of cases where you can, in some cases, you can avoid the IOL exchange and do the job intraoperatively so that you do not need to do the IOL exchange. So these are some of the videos I'll be showing, because we know that we all want to fly very high. Just a minute. Can you give me the sound please? Voice. Okay. So we all want to fly very high, and this is what we expect. But there are situations in just landing of the flight. So same thing what happens, because when you put a very good IOL and it has landed wrongly. And here you can see this particular case, there is a stuck haptic. This patient showed a very high cylindrical error post-operatively and very high refractive error. So it wasn't very difficult to correct this patient, because what I did was just dialed this IOL out of the bag and did a good visco injection and redialed it in the bag. And once this IOL went into this bag, this patient was quite highly satisfied. This is another case where the IOL is almost floating. This is a trifocal IOL. You can see there is a PCR where the IOL is sinking, and now the option was either correct this IOL itself or do the exchange. But you know that there is a PCR, then you would have gone for the SF IOL or something of that kind. And what I did for this particular patient was I just took out the haptic which was in the bag on one side and brought this IOL on the anterior surface of the anterior capsulotomy edge, because the anterior capsulotomy was intact. And as you can see, because I tried to fix it on the capsule, and this is how this patient looked after the surgery and post-operatively. And it was quite satisfying, because this patient had a very good vision after correcting or repositioning this IOL. I did not need to go in for the very drastic kind of surgery, removing this IOL and all. Now this is another case where the IOL was almost sinking through the PCR again. And you can see one of the haptic is in the bag. I took out this haptic and just redialed it and brought both the haptics on the anterior capsule. And this is the second haptic which is coming out. And as you can see, the IOL can be repositioned on the anterior capsule away from that PCR area. And post-operatively, this patient also did very well. I did not need to go for the IOL exchange in this particular case. Now coming to the another case where there was a very high refractive surprise. This was a patient of RK patient, and we had done a cataract surgery and put in IOL, and this patient showed almost 4 to 5 diopter of the IOL surprise. So this was the patient where we had to go in for the IOL exchange. And doing IOL exchange in a post-RK surgery, you have to be very careful, because these incisions are already weak, and as you can see, because the hook and flip technique, because you just hook the haptics and bring that out of the capsular bag and bring it on the anterior surface of the iris. Just take out one of the haptic, hold it away within the incision, and then cut, because you have to prevent the flipping of the IOL, because if the IOL flips inside, it can damage the endothelium. And if you hold the haptic out of the wound, the eye will not flip. Then you can very easily cut it. You can cut it into complete 2 pieces, or you can cut 3/4 of the IOL and then dial and pull technique, like you just dial it and pull out the IOL. This is how you can take out this IOL without damaging anything, the wound, the corneal endothelium. keep on injecting a good amount of the viscoelastic within the bag and within the anterior chamber. And then I'm trying to put the IOL within the bag now. That's the IOL which is gone in the bag. And the post-operatively, this patient also had a very good vision, and the refractive error was completely corrected. The another case, you can see this is a completely opaque IOL. The patient had a very bad vision after the surgery, and this was around 6 months post-op. Now the only option here, because you cannot do anything else except the exchange of the IOL. So again, I'm trying to remove this IOL out of the bag. And the technique, as I told you, is the hook and flip. It's very simple technique. You just hook the haptic and bring it out of the bag. Now, but this particular patient, as you can see, there was a PCR behind the IOL. So this could have been the reason for the opacification of this IOL. There are certain other reasons for that. And now this was a little difficult case because I brought one of the haptic out of the bag and trying to bring it on the anterior surface of the iris, and this is the second haptic which has come out. Now again, I'll be taking one of the haptic out of the incision, and once you take it, now this IOL was, because since there was a PCR, I did not take much risk. I just went from the main wound, held the IOL, and then cut it into two. Now this IOL was cut almost into two pieces, and again, I'm just trying to hold the haptic, pulling it and dialing it. I'll just take 1 minute only. Now once the IOL is out of the bag, now you can see this opaque IOL cut into two and brought out of the capsular bag. Went inside, I did an anterior vitrectomy for this particular patient, and a good anterior vitrectomy is very important because if you have vitreous loss. And then went in with an IOL, and as you can see, because I'm trying to put this IOL in the bag itself again. So first haptic, the leading haptic went into the bag, and I'll be dialing the second haptic again into the bag, and you can see the IOL well fixed within the bag itself, and this patient also did very well post-operatively. So you have to do a good sealing of the wounds and be sure that nothing is there in the anterior chamber now. So travel with Air India, you'll be very safe and land very well. Thank you very much.
Thank you very much, Dr. I think one tip I would like to share also, if you got your haptics stuck and don't struggle to take it out, suppose an old case or something, you can cut the haptics and take out the optics only, and then you can put a lens and the sulcus. So if you feel there's a problem, you can do that one also.
Thank you, Dr. Rajendra, for wonderful talk. Now I want to invite next speaker, Dr. Kumar, who is leading ophthalmologist based in Mumbai. He will be talking about cataract applications, Z8 cataract applications.
Good morning. At the onset, I'd like to thank Gaurav and Saurabh for this opportunity. Fantastic hospitality. We've got the Z8 now since 2 years. I had the Catalyst before this. So the Z8 is actually a complete system. It does everything. I don't have the cornea module, but it does flaps, it does lenticule, it does cataract, it does intacs, and the cornea module does lamellar, penetrating, etc. So the biggest advantage is it's a phenomenally mobile unit. So it can move into the LASIK OT, to the cataract OT, to another center. Dr. Ramamurthy moves it between 6 centers per week. So it's as simple as that. But if you want to really see the cataract applications, what I'm going to show is just a cataract part. So what I'm doing here is a marking. The advantage of doing the marking, you'll realize when I'm showing incisions on the Z8. So the femto incisions are far better. The reason why I'll tell you later. So here I've done the marking, and then I make sure that the mark is more highlighted. Once the highlighting of the mark is done, we go ahead and do the Z8 application. So we put on the handpiece. It's a liquid interface. Once that is done, it scans. Then it scans for the rhexis, scans for the lens, scans for the incisions, and you can actually place your incisions in the way you want. You want it at 170, 170, 180, 180. It's a biplanar incision, so the first incision and then the second. So here you can see the scanning happens. Once the scanning is done, we go ahead and do the lens fragmentation, followed by capsulotomy, followed by incisions. So once the incisions are done, I'm now going to show you how the incision opens with just a Sinskey hook. So you can see the incision, that was a clear corneal incision being opened. I also made side ports with the same laser, so you don't need anything else. Once this is done, I just put a viscoelastic. You can see a free floating rhexis, and you can also see six fragmentation and a central circle. So this is a side port being opened with just a small instrument like a Sinskey hook. So incisions, side port, rhexis, lens fragmentation, all is possible with this equipment. And it's not imaginary. So you will wonder what happens if the rest is not there. You can go ahead, do your phaco. I'm not going to waste time in that. The fragmentation is excellent. You can see a straight, clean cut made by the laser. So when you separate out, and again there is no controversy that the femto-phaco is EPT is half the time of normal. So if someone says that's wrong, it's well proven, it's well published that the amount of EPT is less in femto cases, okay? Once that is done, we go ahead and just do bimanual IA. That was the thing. Once the bimanual IA is done, go ahead and put a toric IOL into the bag. So it's really a mobile unit. You can see that I'm pushing it into my clinic. When you buy it, this is what happens, because you know what happens to your pocket. Well, you push it through, and it's as simple as that. You can push it with one hand. It's very, very light and nothing really to worry. Now coming to incision making, now you can see that I planned an incision at 140, and when you have image guided technology or you have Callisto, half the incision should be on one side of 140 and half the incision should be on the other side of 140, and that's the accuracy I'm talking about. So you can see here the accuracy, half the incision is on one side of 140 and the other half the incision on the other side. Now here you can see a fully free floating CCC. We have images of anterior segment OCT having done the CCC, and you have a 200 disc of cortex which is also floating behind. So this is as far as the accuracy is concerned. As far as incisions in arcus, this is controversial, but now I can show you that there's an arcus. Does it cut in an arcus? And you can see that yes, the incision is made, and I'm now using a Sinskey hook to open the incision, and you can see that it just enters. It's biplanar. How do you know the incision is made well on a femto? When you put in an IOL and you want to remove a viscoelastic, normally in a case when you do a knife incision, the viscoelastic comes out through the wound. But when you have a femto incision, the viscoelastic will not come out through the wound. It just shows how well self-sealing it is. Once this is done, we go ahead and make all the other steps of phacoemulsification. So we go to the next one. Again, high level of high magnification incision at the same time, and you can see that just opening the incision, all the aqueous comes out. I make the incisions through the femto, and it's very, 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 very accurate. As far as the placement is concerned, you can manipulate it according to the axis you want, between 80 to 170, whatever your eye sits superior. If you want to sit temporal, you can make that incision. Coming to posterior polar, we know that femto has big advantages in the posterior polar. So I just want to show you the posterior polar case. So this is posterior polar, and surprisingly you can see that it had gone through, so there is a posterior dehiscence, okay, in this case. And now I'm going to go ahead and scan. Now the posterior plane is kept 1.25 millimeter away from the posterior capsule. Normally it's 600 microns. In this I've kept it more than 1 millimeter. So I'm doing CCC, I'm doing fragmentation in a posterior polar cataract with dehiscence, okay? This is only possible in a femto. We go ahead and do that. Then it's a soft cataract, so I'm going ahead and doing a bimanual IA. And when you see the last part, I'm going to show you that there is a pre-existing dehiscence, and that's going to be followed by placing the IOL in the bag and then seeing a post-op picture. So you can see the last part that I remove is the center, because that's where the posterior polar is actually having a PC defect. And now I'm just gently doing low bottle height. You can see the bottle height of 44 centimeters. Going ahead and gently going to lift that piece off the posterior capsule where there is a pre-existing dehiscence. So I'm going ahead and you will see that there is a pre-existing dehiscence just behind, because it was detected on the pre-op with the OCT. So you can see the dehiscence there. You can see the dehiscence. The rest of it is around fibrous, so that's a big advantage. So once you remove the last part, I go ahead and put an IOL in the bag. So this is the last part. being removed. After this is done, I will put the IOL in the bag. So you can see the center part, that's a pre-existing, and this was diagnosed in pre-op, also diagnosed on the OCT which comes with the, now of course you don't let the chamber collapse, go ahead and put the IOL in the bag. Once the IOL is in the bag, you can see that I'm going ahead and putting the lens in the bag, and I'll show you the first day post-op picture. You can see once this is done, the lens is in the bag, well centered, and you can see the dehiscence which is post-op. Now the last case, I'll take less than a minute. Now if this comes to you and the patient says, I want femto, it's not possible on all the systems because you are not going to be able to do anything with this guy to making him lie down. So here I'm going to show you kyphosis, very difficult to measure, challenges in every level, but he wanted a femto. Okay, so I shifted the femto laser from my LASIK room to my cataract OT. So this is my cataract OT. I have a German bed, which becomes a chair. So the head has been tilted up. Of course, you know that when you need to do this, extremely cooperative guy, he himself helps you, takes his legs, I mean, we have to take the legs up, that's the only way to do this. And then you can tilt the whole bed downwards. So you can see this, and that's the Z8 you are seeing here, which is the femto laser. And now I put the ring. Once I put the suction ring, I go ahead and take the arm. It's got a twistable arm, so you can increase the height or reduce the height, and you can adjust. So that's one big advantage of this unit. So once this is done, I go ahead and do the laser. Once the laser is done, you drape the patient and then go ahead and do your femto. That was the incisions made on that. Once the laser is done, the phaco is done, and once the phaco is done, go ahead and put an IOL in the bag, which he needed a toric IOL. So this is quite possible in today's world with these mobile systems. So once the lens is in the bag, you arrange it, then release the haptics into the bag where it is, and align the toricity of the IOL. So I think this is making the unbelievable possible. Thank you all for your attention.
Thank you very much. Thank you, Kumar, for the wonderful presentation and the wonderful technique what you have shown. And this machine, actually, because as you've shown, portable, and then secondly, so manipulable kind of machine, because the handle, which, because this kind of patient, otherwise it's so difficult, no? Because even thinking of phaco doing in these patients where you have a kyphosis of this much, it becomes so difficult because you manage so very well.
It was quite easy because of all this.
That's good, that's good. And then your, this posterior polar case was very interesting because what you have shown, the femto laser cataract surgery in the posterior polar cataract, because the technique what you have shown, the last piece was still intact over that defect in the posterior capsule, and very nicely taken out, and then you have gone with the in the bag IOL implantation. So in these cases, like if you have a defect in the posterior capsule, is there any need of doing PCC in such cases?
No need. Actually, you know, the best part is the patients who have a posterior dehiscence pre-existing, the rest of the area is quite fibrosed. So it really doesn't enlarge the way a normal PCC will enlarge. So it actually supports your IOL and it won't enlarge. So that's a big advantage of this. So the only care we have to take is never let the chamber collapse. The rules are the same. Make sure that the last piece is removed very carefully and gently. Reduce the bottle height. Prevent excessive hydration. Always put a good viscoelastic. And I think the results are very, very good.
That's true, because if you have a circular kind of defect in the posterior capsule, it's always fibrosed. The edges are fibrous, so you don't need to do the PCC. But if it is radial tear kind of thing, sometimes these defects you see with the radial extension, and that while putting the IOL tend to extend to the periphery. So these are the cases we may
need to do another PCC.
PCC and then put the IOL in the back. So thank you very much. Thank you, Kumar, for the wonderful presentation. And now we'll go ahead with the next speaker is Dr. Bhupesh Singh. Dr. Bhupesh, you all know he's a cornea and cataract surgeon at Bharti Eye Hospital in Delhi. A very prominent cornea surgeon now in India and a very well-known person. Yeah. And he's going to talk about challenging case scenarios.
So thank you, Dr. RP, for the introduction, and thank you, Uttara Eyecon, for inviting me here. So I'll be showing some of the interesting cases that I dealt with. And so this was the first case. So this was a case of keratoglobus. Came with a intermittent hypermature cataract for the surgery, and this patient's K reading was 49 and 63. It was difficult to calculate with any formula, and somehow we managed, and the IOL power was -10 diopter in this case. So now the challenge was the corneas are brittle with keratoglobus. It's high myope, you cannot give the block also. So I give some injection in the subconjunctival area and make the scleral incision here just to avoid any rupture of the cornea. And as soon as I entered the intumescent, you can see the fluid is coming out. Nothing was visible. The AC depth was 5.2. So you cannot either focus on the cornea or in the lens. It was so difficult to change the focus with every step. And you can see the lens is not clearly focused because I'm not able to see the instrument, either focus on the instrument or focus on the lens capsule. And somehow I managed with a smaller rexis because rexis extension was quite high in this case. So a small rexis, and I follow this technique in all my cases. Just a small hole and then just drop it. And the iris was fluttering throughout the case, so it was very difficult to manage, but somehow it went well. I think thanks to the machine, this machine is pretty stable in these scenarios, and the patient did well, ultimately 3-piece lens. And patient did well with 6-12 vision post-operatively. And coming to the next scenario, this was again the intumescent cataract. So sometimes I tried yak capsulotomy in such cases. You have to give just 1 or 2 shots of yak capsulotomy, just 1.6 or 1.8 millijoule, and then you get a hole, and the excess liquefied cortex comes out in the anterior chamber, and the chances of extension is minimized after this maneuver. You can see it's dripping down, and this is another situation in which there is a bleb here, and in these cases we have to be very careful not to damage the bleb area, and always stay away from the bleb. Do not overfill it with the visco. It was non-dilating pupil because of the chronic glaucoma, and somehow I managed with the smaller rexis again, around 4.5 millimeter. Dissection. So there are high risks that blebs failed after cataract surgery, so we have to be very careful not to damage the bleb and stay in the center, just keep on doing the cataract surgery. Surgery was simple, not that tough. So in these cases we should wait as much as possible after the glaucoma surgery, at least 2 to 3 years before planning the cataract surgery, so that the bleb is functioning properly and the risk of failure is minimized. And the IOL was placed in the bag. Coming to the next cataract, this patient came for the cataract surgery, so I advised PK with cataract, but the patient refused for transplant. So we have to take up this case for cataract. It was a tough case because almost 60% of the cornea was covered with the opacity, and this area was vascularized and thinned out. And the plan was to go slow and manage this case. So in this area it's completely blind, so you have to just believe on your senses and complete the rexis. So I made the rexis smaller on the scar side and bigger on this side so that it will be easier for me to handle the cataract. And the plan was to stay on the clear area, not to go there, and get the pieces to the phaco probe and do not chase the pieces beneath the opacity. Keep rotating the pieces, and the cataract was done comfortably. So sometimes these challenging situations we have to manage. You don't have any other options. Although the prognosis are explained in most of these cases, but still you have to give your best, and patient deserve the best. So the lens was placed at the back. So patient gained 624 vision, and she was pretty happy with the vision. And so coming to the last surgical situation. So this was a patient came to me with a complaint of glare and halos, and this patient developed traumatic mydriasis after cataract surgery, and came with a glare, and I planned a pupilloplasty for this case. So single pass photopupilloplasty, as described by Dr. Amar, is a wonderful technique to manage all such cases of mydriatic pupil. So you have to pass the 10-0 proline suture from one end of the iris by pulling it like this, and the same needle is passed on the opposite side of the iris. So usually 2 knots works very well in most of the cases, and you have to do the ray loading technique. I'll take 30 seconds more. And the ray loading is done, and you have to pull the suture out. And then you have to take the loop out from the other side and take 4 throws through this loop. So it's very easy to learn, easy to perform and give good results. You can see just one suture, and then cut the sutures there. Same maneuver on the other side. Four throws, and the pupil is round and regular, and patient did well. Thank you so much. Thank you.
Thank you, Bhupesh, for the wonderful two cases. And the case before this, where the corneal opacity was there, was quite interesting.
Yes.
What was the vision the patient got?
The patient got 624.
624.
And
so
before it was hand movement, so she was pretty okay.
Yeah.
But my plan was to plan the PK surgery, because I was not sure whether I will be able to do this case
so
or not.
That is what I was thinking, because you are a corneal surgeon. Why didn't you do the PK for this patient?
So I thought, let's take it on, because the patient was very old, 75 years old lady. So after PK also, I don't know how she'll manage.
But 624 vision is a very good vision.
Wonderful vision. So
the two important points which you mentioned in that particular case was you have to do eccentric capsular axis. That is what Bhupesh did.
Yeah.
Your capsular axis should be more on the area where the cornea is clear.
True.
That is one thing. And sometimes we have, because if the opacity is a little bigger, and the eccentric implantation of the IOL is also have been described.
You cut
just cut one of the haptic and make the center of the IOL towards the clear area of the cornea. So you may get little better vision, more better vision. But you did very wonderfully in this case. Thank you very much. Thank you, Bhupesh.
Thank you so much.
Prafulla, you want to make any comment on this patient? Because cornea, from the cornea point of view.
Just to continue that point, Care Group, they do prepare a customized IOL where the haptic is long on one side, small on other side. You can choose that also. And while Rexis, although Bhupesh relied on his senses, but for beginners it's always good to use a Rexis forceps.
Beginners should not do these cases.
So don't rely on your senses. 26 gauge, once you left the flap, then it's very difficult to know where the flap is exactly. With the Rexis forceps, hold it and just in one go rotate it through the opacified area.
True, that was a very good point brought by the Prafulla, because whenever you are doing Rexis in these cases, you have to use forceps. Because if you happen to if the flap disappears during the Rexis formation, then you won't catch it again. Won't be able to catch. So you catch with the forceps and do the Rexis. So that is a wonderful point. Yeah. Thank you, Bhupesh. Thank you very much.
Thank you so much.
So now our next speaker is Dr. Gaurav Mishra. Dr. Gaurav, are you ready?
Yeah, I'm ready.
So Dr. Gaurav is one of the very good and energetic cataract surgeon. I've seen his videos, and he his surgery is really, one has to watch how he does. And Dr. Gaurav today, he's going to talk on
low IOP.
Low IOP.
A boon.
Dr. Gaurav will be talking about low IOP cataract surgery, a boon.
Thank you, Uttarakhand Open Ophthalmic Society, for inviting me. And this is especially for Kumar. If you are not looking, just look here. If you have not seen this, see it today, because everyone is here to see this. So, sorry? No, this is for Kumar to see, because yesterday he did not see a monkey also. No, yesterday he did not see it. So I'll be talking about surgery on physiological IOP, a boon. So all of us are talking about artificial intelligence these days, and probably the time has come that we shift to machines which have some artificial intelligence. So doing surgery on physiological IOP, what is operating on a physiological IOP? It is maintaining the IOP close to the physiological one. The IOP with the gravity fluids, fed fluidics, the bottle height of the IOP, 15 centimeters of bottle height is equal to 11 millimeters of IOP, and 100 centimeters of bottle height is equal to 66 millimeters of IOP. So instead of lowering and upping your bottle height, you just have to feed these parameters and everything is done by the machine. There is optimal efficiency and efficacy with the lowest energy and shortest time without causing any collateral damage when you are doing your surgery in a physiological IOP. This is only possible with the latest and most advanced phaco equipment. It synchronizes, and there should be a good technique to do it. What is the significance? There are a lot to be studied about this, but what I think is the adverse effect on the endothelial pump is prevented to some extent. The blood flow to the retina and choroid is maintained and is not hampered. With higher IOP, there are causes of cellular and molecular damage, which is lesser with a lower IOP. There are chances of increased corneal edema and central corneal thickness and decrease in the endothelial cell density with the increased IOP. The higher IOP causes trampolining of the lens iris diaphragm and rupture of the anterior vitreous phase, which was very well demonstrated by Shail Vasavada in one of his videos. And there is a negative impact on the post-operative vision in glaucoma patient, floppy iris syndrome, and high myope patients. And you can do this even in challenging cases like subluxated zonules, compromised PCs, and traumatic cataracts. So the advantage is that you keep the tissues of the eyes to its normal, comfortable state, which leads to lesser inflammatory response by the iris tissue. It reduces the fluid usage, and there's a lesser stress on the ocular tissues. It improves the anterior chamber stability. It is safer in advanced glaucoma, myopic, and floppy iris syndrome. And the patient feels less pain, especially in high myopes and sensitive patients. And there is lower mechanical stress to the ciliary body, zonules, and the PC. So the key fundamentals are, this is not possible with gravity fluid fed fluidics. There is an active control of the IOP, so the chamber is very stable and there are least fluctuations. The quick post-op and break response is there. There is less compliance of the aspiration tubing because the sensor is already there in the handpiece. And the followability and the holding power is unmatched. So this is the active fluids technology. There is active sentry handpiece. There is fluid pressure sensor and quick valve technology is there. Just 3 videos to take you through. First, a soft gate cataract. You can just note down the IOP which is there, that is just 20. And all the things are being managed by this only. So this is the CD. You can see the CD also. And now this is the soft cataract. Now the moderate type of a cataract with a small pupil. Sorry. So the pupil is not dilating, but still you can manage the things with a 20 IOP. So that is the beauty of this machine. I'm still not an expert on doing that, but I have gradually brought down my IOP from 40 to 20 now. So it is a regular feature in all my cases, and I think this is the future where to decrease the tissue damage, you should get into practice of doing a 20 IOP. Probably this is the only machine that is providing a pressure of 20 IOP. No other machine provides this. And I will shift over to the third, that is a moderate grade small pupil with 20 IOP. This is also small pupil, non-dilating. One can use the dilators, but if that also does not work, we can use these expanders. But just to save the time, you can go ahead with these even in small pupils without much of the iris fluctuations. So I think this is a boon for all of us, and time has come when we should shift to normal as soon as possible, because physiological IOP is the time of the future. This is one more case I'd like to show you. This is a hard cataract, but since the microscope is so good that the illumination is very fine in such microscope, even a harder cataracts look a softer cataract. So repeating the same things, that IOP in all these 4 cases that I have shown you is not beyond 20. So we can skip this, and thank you for your patient hearing. One more case. This is a harder cataract. This is a white cataract where the rhexis has extended, and still I am comfortably able to do this case with a 20 IOP. Otherwise, if the IOP would have been higher, probably the rhexis might have extended and I would have landed up into problems. So thank you. It just needs a mindset, surgeon's experience, technique, and the technology is already here. Thank you very much.
Thank you, Gaurav, for the wonderful video and wonderful presentation. When you are keeping your IOP at 20, what I had seen, your rest of the parameters, especially in fluidics, the vacuum was around 400. 500. But you are operating at 400.
Yes,
the cases were under operation.
So still I am in a learning phase.
And your aspiration rate was around 36. So how do you balance these factors? Because if your IOP is low, then because especially we are worried about mainly we are worried about the posterior capsule.
Yes, sir.
And if your IOP is low, your posterior capsule is going to fluctuate.
Yes, sir.
So how do you balance the rest of the parameters so that you do not have the fluctuation of the posterior capsule?
So that is the beauty of this machine. It is a gradual process. The learning curve is slightly higher. You just have to manage your parameters slowly. Oh, sorry.
Can I just ask one question?
Yes, yes.
So do you find your corneas to be clearer or not as clear?
No, initially it was a difficult task for me to see my post-op results, but gradually with time, on doing 40 or 50 or 100 cases, I found that now I am very comfortable doing my all surgeries under 20 millimeters of IOP.
Fluid consumption, is it less or is it more?
Inflammation is definitely less.
No, fluid.
Fluid consumption is very less.
We'll have to move on to the next speaker. Dr. Satansi is asking us to wind up.
Initially, I used to do 3 or 4 cases with one bottle. Now I'm doing 8 to 9 cases.
11 o'clock we started.
By the way, I agree with you. I use Stellaris Elite, and we also have this system of setting the IOP at 28, and it works like magic.
All right. Thank you, Gaurav. And we'll go ahead with the last presentation of this session. And the last presentation is...
Request all the faculty to collect their momentum from the registration counter.
So the last session is Dr. Vipul Arola, and he's going to talk on CRB, the life begins at 33 centimeters.
So good morning, respected seniors and dear friends. Today I shall be speaking on continuous range of vision in presbyopic correcting IOL. So we are all aware that rise in screen time coincides with significant growth in digital technology across all ages and genders irrespective of educational level. Be it a mobile screen, which is most common, followed by a tablet or even a laptop or a desktop. Whatever we do surgically, visually speaking, we are compromised. Even if we use multifocal or a trifocal IOL, each of these solutions creates a specific gaps within patient's visual range. So it's our job to figure out which of these compromises suits us the best. Some activities that benefit from good intermediate vision include computer work, looking at GPS while driving, checking price tags, and cooking. Now, previous generation multifocal IOLs gave good near vision, but they struggled with anything around intermediate range. So the newer lens, which is a Synergy, it's a hybrid model that combines both multifocality and extended depth of focus technology, and it provides good near vision and wide range of continuous vision. It combines the diffractive technology from Technis Multifocal and EDOF-like Technis Symphony to deliver wide visual range. The IOL design is not dependent on pupil size. It also has a chrome aligned technology to correct chromatic aberration for enhanced contrast sensitivity, and also a violet light filtering chromophobe, which reduces the transmittance of violet light, that is a shorter wavelengths. Now, one strong objective clinical measure to know that how well a lens is correcting presbyopia is the defocus curve. It directly addresses the main factor, that is the desire for good visual acuity for all distances. Now, these defocus curves are created by presenting a series of positive and negative lenses in front of patient's eye and measuring the degree of defocus that is induced. Now, the zero reference on the x-axis is controlled across patient by correcting for the best possible distance acuity, and now using 0.5 diopters increment, defocus curve measures a patient's binocular visual acuity ranging from +1 diopter to -4 diopters. And in doing so, the resultant acuity that is measured can be used to stimulate what the patient visual acuity will be at different distances. So in the zone, continuous vision in these means to see clearly from 33 centimeter to distance or infinity. And it also bridges the visual gap left behind by other trifocal lenses. Now, the pupil size independence contribute to the best low light performance, and MTF is a modular transfer function, which is a measure of amount of contrast transferred by the optic. Now, in a recent study by Dr. H.P. Dick et al. In JCRS 2022, they compared the clinical performance of Synergy with panoptic trifocal IOL in case of bilateral cataract surgery, in which they reported that Synergy lens have an extensive range of vision, particularly through near distance, and better mesopic performance when compared to its counterpart. And in another study by Rojas et al. In recent 2023 edition of Clinical Ophthalm, they studied the various parameters in relation to Synergy IOL, and they reported 88% of subjects being completely or mostly satisfied with their overall unaided vision. They also commented on its good visual, functional vision in dim light. So in conclusion, this Synergy lens gives wide range, continuous range of vision with better image contrast, better satisfaction in dim light conditions, improvement in reduction of dysphotopsia due to its violet light filtering chromophobe, and above all, the reduced need for glasses. In the end, I would like to say that all presbyopic correcting IOLs have some sort of photic phenomena associated with it. Therefore, for these lenses, counseling is the most important thing that leads to a happy patient. So whenever limitations are expected, patients need to tolerate them pretty well. Thank you.
Thank you very much. Thank you, people, for the introduction of Synergy IOL. And I think we are short of time. Just want one comment from Kamal about the Synergy.
I actually believe that the future now actually belongs to these continuous zone vision lenses. In fact, my practice, 70% of practice is moved to lenses of this category. And I know tomorrow whenever I need a surgery, probably I'll be going in for these kind of technologies.
Yeah, true, because I think the time is for these ARV IOL, because extended range of vision, and Technis Synergy is one of them, and Technis Synergy works really very well, because it's a combination of EDOF as well as the diffractive technology, which has been combined and given a very good range of vision. You get a very good distant, intermediate, and reading vision. What your experience, because you have shown a good presentation, but what is your personal experience? How many cases you have done, and what is your result with the near and intermediate vision in these cases?
So I'm pretty satisfied. I have used all kind of multifocals initially and now trifocals. I have used Indian versions also, but the performance of this has been really, the patient satisfaction as such has been good, very good. Even if I have operated one eye, they are quite happy. And when binocularly operated, they are like more.
In terms of dysphotopsia?
Yeah, that is there, because that in that
cases they report
works.
to you with the dysphotopsia.
So it has reduced, like what we used to do in multifocals. It has definitely reduced, and when compared to the other lenses, it's less, signipantically less.
If we compare
but it's still
with
there.
If we compare with the trifocals like Zeiss trifocal or other trifocals.
I've used like Panoptics. So when I compare both of these, they're slightly, like I can say the patient doesn't say by himself that he's facing these problems unless and until asked.
Yeah, definitely, very true, because the symptoms of dysphotopsia is very less with this scenario.
We are
That's
getting
what
late
my
for-
experience, because. So thank you. I think now we'll, Dr. Binod, you want to make any comment?
No, just we are getting late for the next session.
Right. So we'll close the session now, and thank you very much all the speakers, panelists, and our moderators, and the audience, especially because of those who have been with us here throughout the session. And thank you very much. And we'll hand over the panelists of the next session. And our panelists, the chairpersons are Dr. Devin Chandra and Dr. Umang Mathur.
And the panelists are Dr. Kamal Bandhu Kapoor, Dr. Gaurav Mishra, Dr. Bhupesh Singh. Moderatist Saurabh Chaudhary is not here.
So, very good morning to everyone. I would like to invite our chairpersons, Dr. G.N. Rao sir, Dr. Devendra Chandra, Dr. Umang Mathur, Dr. Kamal Kapoor, Dr. Gaurav Mishra is already here, Dr. Bhupesh, and I am substituting for Dr. Saurabh Chaudhary, who couldn't be here today. And I also wanted to invite Dr. Sandeep Mittal sir to please come and join us. Please. So this session is on cataract surgery nuances, and we have, each talk is for 7 minutes. We have a galaxy of amazing speakers, and we are going to start off with a keynote address by none other than Dr. Rajendra Prasad sir, whom I'll invite to come and set up his presentation. And he's going to be talking to us on complex, sticky and glued soft cataract management pearls. He's a master surgeon. He's well known for his amazing Terminator chops and so many other innovations. He's been winning awards and film awards. Please, in fact, we are looking for sir also. He's going to come? Okay, we'll call him over once he comes. Yeah. So I'll also request our next speaker, Dr. Kamal Kapoor, to prepare his presentation and then take his seat. Yeah.
So thank you, Gaurav, for the nice introduction. And friends, I'm going to talk about challenging soft cataract surgery. We all know that we generally take a lot of stress and care about the rock hard cataracts, managing things rock hard cataracts. But you know that these soft cataracts are similarly challenging to all of us. And if you look at this study, have shown that many of these intraoperative complications, whether it's PCR, zonular dialysis, or corneal decompensation, are quite common with the soft cataracts also. So you have to be very, very careful when managing the soft cataract. Don't think that the soft cataracts are the easiest cataract, because many times these soft cataracts would present a quite challenging soft cataract. You know, these variety of these soft cataracts we come across in our clinical surgical practice, and but most of these soft cataracts have some kind of similarity and some kind of challenges, and because of their characteristics, they have to be managed differently. So I'll just go through a series of cases, and this is the first case, a pediatric cataract, very soft pediatric cataract. You don't have to worry much because the cataract, there isn't much cataract, just a soft complex of the nucleus and the epinucleus. You just go inside and do the aspiration of the cataractous complex, and you finish the surgery in a second's time. So you don't have to bother for much for these cases. The another case, a very soft cataract, but not pediatric cataract. You can see it's a juvenile cataract, where you could see the whole cataractous complex is, whole complex of the cataract is opacified, and you could see some flex also within the cataractous complex. You just have to flip it out of the capsular bag and start aspiration. And it becomes so simple, because once you could get this whole complex out of the capsular bag, you can start doing the aspiration just with a simple aspiration without putting any energy, any phaco energy, and you can complete the surgery simply with this technique. Then comes a moderately soft cataract. A simple technique again with a moderately soft cataract is visco flip technique, where you use the viscoelastic to flip out the whole complex of the cataract out of the capsular bag. So because if you are able to flip out the complex, then it becomes very easy, because many of these cataracts are stuck to the capsular bag, and flipping them out or bringing them out of the capsular bag becomes difficult. And then you can, without using too much of phaco energy, you can just start phaco aspiration. And you can see, because these, once you have a complete complex out of the bag, you can just simply use the phaco aspiration technique and aspirate the cataract out of the bag and complete the surgery. Then comes the soft cataract with some amount of the brittleness. And if you think that there is a little bit of brittleness, stickiness of the cataract with the capsular bag, you can use stop and chop technique. Stop and chop technique is a very simple and very good technique for these cases. You make a small trench at the center, and then split the nuclear complex, or rather the whole complex, into two segments. And if you are able to split the nuclear segments into two, then you can very simply draw the segments out of the bag with a very low phaco energy and very low vacuum. So you don't have to use very high vacuum in these cases. Use a very low vacuum, no energy, and you can simply aspirate the complexes out of the bag, bringing these the segments of the cataractous complex. So you can see here, because the whole nucleus as well as the epinucleus complex has been aspirated, and then you have to go for the cortical aspiration. It becomes so simple. If you have a soft cataract with grade 1 to grade 2 nuclear sclerosis, because where you expect some amount of the brittleness in the nucleus, then these techniques may not work. Then you have to use some of the chopping technique. So what I am going to use here is the phaco chop technique, because you have to chop the nucleus and make the segments of the nucleus, and then you can very simply take out each segment out of the capsular bag and start emulsification. So if you chop it properly, if you have a complete full thickness segments, then it becomes easy to bring these segments from the capsular bag, as you can see here, because these segments would come very easily, and you can start the emulsification. And then you may come across sometimes these soft cataract with a sticky brittleness, because some amount of the stickiness of the cataract would be there. You have to do a good capsular axis and do 5 to 6 millimeter of the capsular axis. And once you do the axis, do a good hydrodissection, hydrodelineation, and once you complete the delineation procedure, then you do a chip and flip phaco aspiration technique. You have to again make a small trench and make the segments, and then the small pieces you can chip out and start emulsification. So these are the cataract, not so difficult cataract. But then what about this soft, sticky, gummy, pre-senile and the senile cataract with some amount of the brittleness. So these are the real difficult cataract, because what happens with these cataract is neither they can be held, you can't hold these cataract, you can't chop them, or you can't crack also them, and nor they can be moved. You can't move because they are stick to the capsular bag. You can't flip them out, and the capsular bag may be sometimes compromised. So you can see this is one of the cataract, these sticky gummy cataract, and the current chopping and cracking techniques won't work very well in these cases. So what I'm trying to do is I'm trying to make a small trench and trying to split this nucleus. But as you can see, because my phaco probe would have a Swiss cheesing effect, because the moment I try to hold, these pieces would be aspirated, and you cannot hold the nucleus, you can't hold the cataract complex, and you cannot split or separate or segment the nucleus. And then what happens, because you keep on doing this, and these small chips would keep on coming out with the phaco probe, but still you cannot do the job of cracking. Then I'm trying to use this second instrument to hold the nucleus, because you can't hold with the phaco probe. I'm trying to bring them on the phaco probe. So this would be disastrous, because many times if you use the second instrument to bring these segments on the phaco probe, you may hit the posterior capsule and may land up with the posterior capsular disruption. So somehow, like with the lot of manipulation, you can complete the surgery. But then another case you can see here, yet again a very gummy and sticky cataract. I'm trying to go ahead and trying to hold it, trying to do a chop technique, but it's not possible because I can't hold, because these cataracts, you get a Swiss cheesing and Swiss wiring effect, cheese wiring effect also, because you use the chopper would just cut through, but you don't get the crack of the nucleus. And if you don't get the crack, you finally land up with a bowl kind of formation, and finally you will have a plate, and it becomes real difficult to bring out that plate of the capsular bag. And many times this is the situation where our phaco probe would go through the cataractous complex and hit the posterior capsule. So these cases can be dealt. Can I take 1 minute, Gaurav? Yes. And as you can see here, I'll just show you a very simple technique. Do a good so I'll just fast forward it, and so do a good hydrodissection. This is the very, very important step in a soft cataract. A hydrodissection, you should do a cortical cleaving hydrodissection and a good hydrodelineation, so that you separate the cataractous complex from the capsular bag completely. And once you are able to do this, use this kind of a splitter. So I use the splitter because you don't use a chopper, because if you use a chopper tip is sharp, and you may not get the crack, you may not get the split of the nucleus. If you use the splitter, you can split the nucleus into two very easily, because this is the fundamental of soft cataract. If you are able to split the nucleus, then you can play with the nucleus. Then the splitted nucleus or these heminuclear, the segment, they come very easily on the phaco probe. So this is what I'm trying to do. You can see I'm trying to hold it with very low vacuum and splitting. So this is how you get a split. Now if you get, I'll be showing a few more cases here. Just go inside and hold it softly and split it. So if you are able to split, so this is the important point. Split the nucleus. Don't go for cracking, or you don't go for holding the nucleus before you could split, because you try to split it, use a very low vacuum, very low energy, and very low aspiration mode, and split the nucleus. So once you split the nucleus into two fragments, then these fragments would come automatically on the phaco tip, and you can see here now these fragments would come on the phaco probe very easily, and then you can do the phaco aspiration depending on the hardness of the nucleus or the softness of the nucleus. And once you complete the aspiration of these segments and do the cortical aspiration, as you can see, these are the soft cases. You have to do a good polishing, because this is very important again, because these soft cataracts, do the anterior capsular polish, posterior capsular polish, and this is the sandblasted tip what I am trying to use to polish the capsule, because this is possible only with the bimanual. It won't be possible with the coaxial. So always use bimanual technique for the soft cataract. So because you need a good polishing, and once you polish, then you can go ahead with the IOL implantation, and you will get a very good result with these cases without any complication. So thank you very much. I'll just stop here.
Thanks, Dr. Japas, for that lovely collection of videos. And I'll take a quick comment from Kamal or Dr. Gaurav Mishra.
I think paper leak hua hai because the same question paper is with him and me. So I'll be doing something similar, but I'll be probably adding a few more systems. I'm also talking about soft cataract because as technically people are more afraid of hard brown cataracts.
Yeah, that's right. That's right.
Soft cataract, especially when it becomes a katori, becomes a katori and gluey, that's when trouble happens. So I'll probably show more styles of handling such cases.
So that is the most important point. You should not let the soft cataract turn into katori. If it turns into katori, then it's a hell of a problem.
So very nice videos, and
thank you
very nicely demonstrated and very patiently. Thank you so much.
Thank you very much.
So we'll have our next speaker now, Dr. Kamal Kapoor, who is going to be speaking on many ways to skin a cataract, interesting techniques for soft cataract management. Wonderful. And we'll request our next speaker, Dr. Satanshu Mathur. Is he here? So if he's not here, I'll request I know that Dr. Jagdish Rana won't be able to make it. So I'll request Dr. Gaurav Mishra to get his talk ready on this side. Great.
Good morning. Hello. Hello. Yeah. Okay, I think very interesting videos by Dr. RP, and as I was just seeing, soft cataract is not a thing which you can take softly or lightly. Well, it can actually spring up a lot of surprises for you, especially for beginner surgeons. So I'll just skip through very fast, an aerial view. Rexes can be tricky in these cases because the rexes a lot of times is stretchable, it tends to run out, it doesn't get the size you want. One tip for beginners is whenever you're doing a soft cataract, aim for slightly bigger rexes. Until unless you're going for a toric lens, go in for a bigger rexes. It'll make life a lot easier for you. Hydrodissection is one of the most important steps, as said by my previous speaker. Hydrodissection will make your job very, 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 very easy. You do not need to do hydrodelineation unless you're dealing with a gluey cataract. And we'll see what we do when we see a gluey cataract. That's where hydrodelineation will come in. Otherwise, for a soft cataract, just do a hydrodissection. The trick is to go 90 degrees parallel to the plane of capsule rexes, 0.75 and just see one wave. I use these special cannulas. They have been designed by me. I use them for my polar cataracts and hydrodissection. They work wonderful. So as I said, a good hydrodissection, we will say you should have one long continuous wave. See how I go. First, make sure you take out the viscoelastic. The fluid should go 90 degree and see the wave it will come. Yeah, that's what you should be looking at. The end point is the nucleus rising up. Once the nucleus rises up, just push it down and try and rotate. If it's rotating, your job is done. You're just ready for the next cataract. Now, simplest situation is have a large rexus, give two bursts, one burst in one angle, other 90 degree opposite, and the cataract is in the anterior chamber. You can just coat your endothelium with good amount of viscoelastic, and all you need to do is use very low phaco power. I'm a Venturi guy, so I just use 5 to 10 phaco power. My standard vacuum settings are 350. The vacuum settings never change in my machine. I only change the phaco power, and you will see the surgery probably is going to be over under 1 minute 40 seconds, 1 minute 35 seconds. That's it. Surgery is over. So you just need to have large rexes, one hydro burst in one angle and bang opposite another hydro. The second hydro is to pull it out. The first hydro is to delineate or dissect it from the base. Now we'll see different styles. Now this is again after femto. The job in a soft cataract, it's very, very easy to do delivery of your cataract into the anterior chamber because the nucleus becomes pultaceous, it's more spongy, and just out it comes, and it will not do anything to your endothelium. So the age-old wisdom of not getting the cataract into the anterior chamber is long gone. If you coat your endothelium with viscoelastic, soft cataracts never do cause a problem, though the patient is slightly uncooperative here. But you see 15 to 10 phaco power, 350, 400 vacuum, and the cataract is again over. So delivery into the anterior chamber, you need to have a good hydrodissection, and vectors should be perfect to get the thing into the anterior chamber. Now, in case you have a gluey cataract. Now let's understand the anatomy of the cataract. You need to separate the epinuclear plate from the nucleus. So this is hydrodelivery disc. So what I do is, suppose a little gluey cataract and I'm anticipating a saucerization, this is what you can do. This is where delineation comes in. You do a delineation and your nucleus is into the anterior chamber. And dealing with the plate and the cortical plate is very, very easy in these cases. You just go in, take the nucleus out. So when we have a gluey cataract, which are more stretchable, they're not attuned to chopping, you can actually get the nucleus into the anterior chamber, and the rest job is so easy. So you'll notice all these surgeries are over under 1 minute, 1.5 minutes, because you are doing a good hydro. So the hallmark here is a good hydro dissection. I'm trying to go fast because there are many videos which I want to share. Now this is called the disc lift. You create a nuclear disc. Now this nucleus is slightly harder than the one we saw before. It gives you enough holding power. So I use a FIC of 10, a vacuum of 200 or 180. Just go in with a bevel, lift it, and if required, use a second instrument to lift the instrument out. And this is what we'll see. We'll see a nucleus disc lift technique here. This is a polar cataract. This is one of my go-to techniques in polar cataracts. I create a nucleus. I create many rings in the nucleus. I'm forwarding the video there. So once this is done, now the trick is to free the nucleus from all the sides. So I'll go on a very low vacuum. I will clean the nucleus roof and the edges, which will separate. You see so many rings there. I will separate it on all the sides with my phaco tip. There you see that. And then with the bevel, what I'm doing is I'm shaving the surrounding areas. Now this takes away the adhesions of the nucleus from the cortical plate. This works 100 on 100 times. If you clean this properly and see what beautiful separation this creates, and all you do is just a bevel down, low, very, very low vacuum, get the disc out. So this is your solution, Dr. RP, to gluey cataracts. You can just clean the place, get the nucleus out, and then the whole job is easy. And then you can finish do your centripetal irrigation aspiration and complete the case. Now again, disc lift technique in a different style, again a polar. You separate, create many rings. I'm going forward, fast forward. Meticulously, as I said, separate again from all the sides. This is a very, very soft nucleus. You would probably think that I will not be able to lift it up. 5 phaco, 180 to 200 vacuum. It will not bore through. It gives you a very, very good hold. But again, I'm using a Venturi system. It may be a little tricky with peristaltic because it takes some time to build the vacuum. And see how beautifully the nucleus is lifted out, comes out, flips over as if, it's being attracted like a magnet. And there it's done. Now you can also chop a cataract. Now the trick here is very, very soft cataracts. How to chop them is never cross the midline of the nucleus. The nucleus is the thickest and the densest part of the cataract, and it is the most anterior depth. So do not cross the midline. Maximum 50 to 60% of the total diameter of the cataract. Stop there. Embed 2 phaco tips deep. Very low, very, very low phaco power. Vacuum moderate, and you will be able to chop it. So you'll see this is a soft cataract. I'm just going to show how we chop. It looks quite soft. We do a hydro, and see, I'll just show you how. There, you chop it. No cleaving, no separation, you can chop it. So the only thing is, do not cross the midline. The moment you cross the midline, you well past the hardest part of the nucleus. And then now you will start sucking it in, and you will just won't be cheese wiring all through. And there you use I call this the D flip technique. You just rotate the D, hold it from one edge. This edge has to be 30% from the edge of the D. Hold it there and it flips out. So you don't need to chop these D segments. Just rotate the D segment, hold it at one edge, 30 degree from one corner, approximately 30%, not in the center. If you hold it in the center, you'll bore through or it will flip through and get caught into the rexes. So hold it at one edge, it will flip through. And then the case is over. Cartwheeling. You can also do this. You create a little nudge, one steep, hold it at one edge, high vacuum, 350, 400 vacuum, and the whole cataract will come out like a cartwheel. So these are different styles of managing a soft cataract. I think, do we have more time? Okay, so this is a D-flip technique again. Rex is done. And we will see, this is a soft cataract. I'm just jumping the video. So there, made 2 Ds, separated is again the gluey cataract we talked about. So there I have a D segment, hold it at one edge, rotate your wrist. So that's why I prefer making my incisions at 30 degrees, because it gives me my wrist a free rotation. If I go at 180, my maneuvers will be restricted. So I sit like this with two angles, 3 clock hours away, and my both hands are moving like this. So my chopper and my hand move like this. So again, if you notice, the case from start to end is over under 2 minutes. Thank you. Thank you.
Dr. Kamal, the main problem in such cataract is the plate Katori left in between. How you deal with that?
So once the nucleus is out, the Katori is not a problem. The Katori is problem as long as there's even slight amount of plate of the nucleus, which is not letting. It's like the spine of the cataract. If you've not taken the spine or broken the spine, the plate will never flip out. The moment you have the nucleus or the nucleus plate out, sir, the plate will come out just very easily. So the trick why Katori is giving us a problem is because we think that we've taken out the nucleus, but a base plate of the nucleus is still stuck to the cortical plate. So I always tell my new trainees that break the backbone. The backbone is the nucleus or the nucleus plate. If it's there in the epinuclear plate, it's very difficult to flip it.
Thanks, Kamal. I'll take comments from Dr. Umang, they have one of the best phaco training programs.
No, soft cataracts, I think what we've discussed are not the easiest. And often a lot of the conventional techniques don't work. And so you need to improvise in between.
Absolutely.
Their soft cataracts also have different types. I mean, the young 40-year-old with a PSC or something is easy. You can flip them in the anterior chamber. I think the tough ones are those 75-year-old cortical cataracts, which are not hard enough to crack and not soft enough to flip. And they also have corticocapsular adhesions that don't allow those nuclei to rotate. So that's where the bowl forms, because if they are not hard enough, and so when you're trying to hold, you create a crater. So those are the ones which people find difficult because they're not really hard, but the age doesn't allow those cataracts to be flipped like the ones we were seeing.
Yeah, so the trick lies here is, as I said before I started, a good hydrodissection and a large rhexis. Yeah. So if we have a large rhexis, and even if you have a Katori, the chances of you getting away with the Katori are far higher than you have a small rhexis.
The only problem, a lot of times the rhexis runs out because they have capsular cortical adhesions as well.
Yeah, true, but then that's where your expertise comes in.
Ones that create trouble.
Yeah,
in fact,
true, absolutely.
The trouble I find with soft cataract techniques is that oftentimes we are talking of these 35, 40-year-old cataracts. Those are easy. With hydrodissection, they come out.
So when you do a soft cataract, I guess you need to be thinking on your feet. You have to keep innovating as it goes.
Thanks, Kamal, and I also enjoyed doing that cartwheel thing and enjoyed that. So we'll quickly go on to the next talk, and Dr. Gaurav Mishra from Meerut, who's a brilliant surgeon, and he's going to be speaking on his topic is crater chop for mature cataract surgery. So we are moving on from the soft to the mature.
Thank you, Gaurav. And it is always a pleasure to be in Uttarakhand and delivering, and especially great when Dr. Rao is here. I would request everyone to please give a round of applause to Dr. Rao, who has made all the way from Hyderabad, and let us give him a standing applause, please. I would call him the father of ophthalmology for the young ophthalmologists, please. Thank you, sir. Thank you for being with us. So I would be just discussing about a technique which is known as a crater chop technique in harder cataracts. So my idea is that the lens is thickest in the center part. So if you make a center part slightly smaller, then would be easier for you to break the nucleus and take out the fragments. So form a crater in the center of the crystalline lens, and the depth and the width can be adjusted according to your requirement. If you find it is too hard, make a bigger crater. If you find it is slightly softer, make a smaller crater. The parameters for sculpting and chopping have not to be deferred. It is all done in the same thing. That is ultrasound, vacuum, and flow rate is maintained the same. So the thing that has to be taken care is the width and depth of the crater. That should be adequate and not too wide and not too small. And this can be done in different types of grades of cataract. The parameters, and there should be adequate tip exposure for the tip to be buried. The role of the second instrument is also very important. The phaco tip stability and complete separation of the nucleus fragments, especially from the base. So the advantage is that even you make a small crater, you can do away with your cataract surgery instead of sculpting and going behind the iris and going beyond your excess margins. The energy and time and fluid usage is lesser. The pressure exerted is lesser when you have already reduced the size of your center part. Unwanted occlusion is prevented, and you are always away from the rhexis and the PC. And it is always suitable in small pupils, weak zonules, and complicated cataracts. And I use a torsional energy rather than a longitudinal energy to make my crater, because the torsional energy, the heat generated, is 60% lesser as compared to the longitudinal energy. So that is the advantage. I'll just show a few videos. This is crater chop done. You can see the central part where I am doing just the torsional phaco used, no longitudinal phaco is used, and you just make a small crater, you just debulk the center part, and then you try to embed and separate this nuclear fragment. So this is, here you impale and you chop the nucleus. So this is the point of importance, that your nucleus should be very well separated. If not in a single sitting, you do a sequential chopping or a multi-level chopping. This is slightly softer type of a cataract. So now we move on to this next type of a cataract, which is a moderate grade. In this, the pupil is not dilating, even with the best of my things. Instead of putting these iris hooks, I thought that crater chop can be done in this, and we did a crater chop technique by making a, just using the torsional phaco in the center part. Make the crater according to your choice, depth and size, and then impale the nucleus with your handpiece and just separate the nuclei. You are not going to the periphery, you are remaining in the center part, which is the deepest part, so you are not hurting the rhexis, or you are not going to the posterior chamber, posterior capsule. And this all is done with the torsional phaco. Longitudinal is only done while you will impinging on the This is a hard-bound cataract. Same things. This does not look to be a very hard cataract, but because of the microscope, which is very good, you can still see the glow, and the pupil is non-dilating. So in this case also, I do a central crater chop technique with the torsional phaco, with an IOP of 20. You must have seen in all these cases, there is a physiological IOP which is maintained throughout my case. I've just made a small crater, and you see that you are able to crack the nucleus. And if at all you are not able to crack it, just do a sequential or a multi-level chopping. Thank you so much.
Very nicely shown, Gaurav, and it makes a lot of sense. And any comments on this, Kamal?
I think this is a very good technique, because the main chopping vectors and the forces are always for the nucleus. So if you already debulk the male criminal, it makes the job a lot easier. It's a very interesting technique, I think, which is very handy for hard cataracts.
Absolutely. So thank you, Gaurav, and I enjoyed your videos. And we'll go on to our next speaker, Dr. Prafulla Marana from RP Center AIMS, who's again very talented surgeon, who's going to be speaking in phaco and corneal ectasia.
हाँ नहीं चलेगा capacity and percentage, okay. Good morning, everyone. First of all, thank you, Uttaranchal Ophthalmic Society, Dr. Gaurav, Dr. Saurabh, Dr. Satansu for inviting me here and let me present in front of dignitaries like G.N. Rao sir. So it's a privilege for me. So I'll be speaking on the surgical challenges when you're doing phacoemulsion in cases with corneal ectasia. So the challenges that you encounter while dealing with such cases like keratoconus or pellucid marginal degeneration or Terriens or keratoglobus are like biometry. That is the most toughest task while performing cataract in such patients. Why? Because your corneal apex is shifted. So axial length measurement using ultrasonic may not give you that accurate result. Always rely on optical biometry. The second component of IL power is keratometer. So in keratoconus, all the traditional methods of keratometry estimation, they presume that posterior corneal power doesn't contribute to total corneal power. However, in cornea, in keratoconus, it's not like that. So always rely on VKG or maybe pentacam equivalent K reading for that. In IOL, choosing IOL, whether to go for single piece monofocal or a torical, I'll subsequently show you nomogram and show that. And the so which IOL power should be, each IOL power calculation method should be used. So this is a study from American Journal of Ophthalmology recently published. You can see they compared a lot of IOL formulas, and if you look here, the modified Keynes keratoconus formula, that was the one who came out with least prediction error, so which is almost 0.8. However, if you notice carefully, SRKT and other commonly like Barrett's universal, True K, all this, they also had almost similar result except some significant errors. So this modified Kane formula you can access online, so you can always use that. So this is a video where I'll be discussing which are the difficulties that you encounter. The first is corneal incision. Don't go for clear corneal incision because the cornea is thinned out. So it's always preferable to go for a limbal incision. And remember, if there is a scar, you should always avoid that scarred area. And then capsular access, always stay in the capsule, because you will see in the video subsequently when you are going from the normal cornea to the cone area or ectatic part, the instrument becomes distorted. At the depth perception that you are getting is may not be accurate. You may be thinking you are at capsule level, but you may be little bit above or beyond that. So as you can see here, the moment my instrument will move from this cornea to cone area, there is a distortion in the image. So it's always good to use a rhexis forceps rather than capsulotome, because if you, in capsular rhexis forceps you can hold the flap, but in capsulotome you have to exactly go to the area where you want to pull the capsule. So once rhexis is done, rest of these steps are not that difficult in such patients. You have to remember the pupil is little bit floppy in such cases, and the chamber, interchamber volume is quite high. So as you can see, the moment irrigation is on, the pupil dilates. If your phacoprobe go below the pupillary plane, the pupil will constrict. So you have to keep that in your mind. And there may be a lot of aberration or corneal surface. You can use some viscoelastic blob on the cornea, that will help you in that. And visco cushion, so at times what happens, even if you have divided the pieces tend to go here and there. So what you can use some viscoelastic below the lens fragments and some in the periphery, so that all the pieces stays in center and you can aspirate those nuclear pieces. And yes, one more problem, if you are going for a limbal or corneoscleral tunnel, there may be conjunctival ballooning, which you can easily take care by giving some nicks there. And as you can see, while I am injecting IL, one nuclear piece was there. So these are hidden nuclear pieces, since the chamber volume is high. So these pieces may be here and there. So to be careful, ensure that all the pieces are taken care of by the end of your surgery. So this is another case. It was a case of pellucid marginal corneal degeneration with healed eye drops, as you can see here. So surgical steps are similar to the previous video. Only thing to remember is always try to avoid the scarred area. Don't make your incision through that area. Even if you have to, you should be perpendicular to the area of scar. Don't make your incision along the scar axis. Rest of the techniques are same. Use your use trypan blue, use rhexis forceps, and while doing phacoemulsification, you can use that visco cushion as I showed you in the previous video. IOL power, which IOL to choose, that depends on how stable your keratoconus and what is the difference between your manifest axis and your topography axis. That I will show you in the next nomogram. Rest of the steps are similar. So this is an article that we publish, me and Professor Namta Sharma published this article about how to do cataract in corneas with coexisting opacities. They published in JCR. You can go through that. So just to summarize, the problem with operating such cases is primarily visualization. So how to tackle that? Use viscoelastic, trypan blue, and I'll show you my next slide. People have used RGP for that also. And incision, always prefer a limbal or maybe corneoscleral tunnel. Don't go for a clear corneal incision. And always remember, these wounds may leak at the end of the procedure. You can use suture or even glue. People have used glue that. So this is the study I was talking about. OE et al. What they did, if you see the this picture, this was a picture with the RGP lens, intra-op picture. As you can see, the intercapsule cannot be identified clearly because of some distortion. But once you put an RGP lens, you can see the intercapsule becomes quite well defined. So if you are doing surgery in cases, although I haven't tried this method, you can try this method. So this is the nomogram by Jarrard et al. Which suggests how to approach such cases. Just to summarize, if your keratoconus is advanced with significant keratometry deviation and scar, always go for triple procedure. If it is a mild to moderate, you are planning, first try to stabilize the keratoconus by CXL or Intax, whatever method you try, and then check with whether the manifest axis and the topography axis matches. If it is matching, go for a toric IOL. If it is not matching, go for a monofocal IOL. And in spite of doing all this, you can still have some error, and people have tried toric ICL for that. Before I conclude, this was a patient referred to me for cataract surgery with keratoconus, but as we examine the patient carefully, you can see these are short stubby fingers, obesity. Of course, there was keratoconus pentagram, but he had RP, retinitis pigmentosa, with right eye optic disc atrophy. So that was the primary cause of loss of vision. So whenever you are operating, so this was a classical case of Lawrence-Mood-Bardet-Biddle syndrome. So whenever you are operating in such patients, please be clear that the pre-op visual acuity, whatever it was, that has reduced because of the cataract itself, not because of other pathologies. If there was good pre-op visual acuity, then only go for cataract surgery. Don't jump into cataract surgery, and always counsel the patient. Whatever surgery that I have done in such patient, my experience says that in mild to moderate keratoconus, the best BCVA that you can achieve is 6-12 only. And in advanced cases, whatever IOL formula, whatever IOL you put, it's very unlikely to get visual acuity beyond 612 to 618. That you must have to convey to the patient before going ahead with surgery. With this, I will conclude here. Thank you very much.
I'll request comments from Dr. G. N. Rao sir on this topic.
You're asking the wrong person. I haven't done any surgical procedure in 20 years, and I haven't seen patients in 20 years, so I'm here to learn more than giving. So I'm the first one to admit. Thank you. Thank you for asking. I don't want to comment based on theoretical knowledge.
Interesting talk, and I think it's an area that we encounter reasonably often nowadays. And you're right in saying the power calculation itself is a problem. On the toric IOLs, I would say that if there's a person who's already using RGP contact lenses, then don't go for a toric lens. Put a monofocal, because they will always be comparing their vision with a toric. And once you've put a toric lens inside, then that toricity you'll have to counter on spectacles, because the contact lens will not be able to counter that. So if somebody has already used contact lenses and is using, even if they push you that they don't like it, I would suggest that don't put a toric lens inside. But if somebody hasn't been using, then toric lenses reduce the cylinder and it may be of use to them.
Very true. In fact, the literature also suggests that. And if patient is using RGB for a long time, you have to be very, very careful while operating such patients, because no matter what you do, the quality of vision will always be inferior than RGP lenses.
How predictable have you found cane formula? I've used it as well, and I'm just wondering that any quick pearls on specifically
No,
the
we
cane.
have used that recently in one patient only, so I cannot. But earlier we used to do Barrett's universal formula. That gives quite good result.
So we were having certain patients where we have found big differences in between the 2-3 standard formulas. We went to the cane, and a cane requires a little bit of kind of thinking to use, because the variables you have to feed in correctly as well. It's online and it's free.
Yeah.
But I found that it was for our patients, like we have done about 3 or 4 patients with the cane formula in the last few months. It's really actually come out pretty good. And then of course the comments stand on what the use of astigmatic correction. Thank you so much.
Thank you.
So I think we'll take our next. So I'm going to go later. My laptop was discharged completely, so I will invite our next speaker. Okay, so Dr. Rishiraj Singh, Impress latest EDOF, what is new, and also we'll request Dr. Ritu to set up on the other podium. Is Dr. Rishiraj here?
While waiting, I recount an experience. Since you asked me to comment, I'll tell you. About 20 years ago, I was asked to come and look at the President of India because he had some vision problems. So I went along with my colleague, examined him, and then conveyed that he had a cataract that had to be taken care of. So then his secretary asked me who would operate. I said, one of my colleagues, who is a very competent cataract surgeon, will do it. So he pulled me to the side and asked, why don't you do us a favor and you do the surgery? So I told him, I'm doing you a favor by not doing the surgery. So that's about 2 years past when I gave up cataract surgery.
The person who did it is sitting next to Dr. Rao.
No, not that.
Good morning, everybody. First of all,
it also tells the humility of Dr. Rao and how he promotes younger surgeons always and encourages them to do well.
No point pretending. Patient should be the central point.
good morning, everybody. My topic is about the Vivinex Impress IOL, the latest IOL that was introduced by the Hoya Optics. Because nowadays, patient not only demand a good, excellent distant vision, but also for the spectacle independence for the near as well as for the intermediate vision. The most commonly used monofocal IOL provide only a good distant vision, but the other options like the mini monovision, it may cause loss of stereopsis, or the multifocal with the diffractive or refractive technology, it can provide distant and near vision. But there are some effects like the affect the contrast, sensitivity, and the visual disturbance in the form of glare or halos, especially in the low light conditions, and compromise the intermediate vision. So the trifocal IOL that provide a good intermediate as well as near or distant vision, but it also affects the glare and halos. So the EDOF IOL were introduced. The EDOF IOL provides the intermediate vision as well as the distant vision, increased spectacle independence, excellent computer vision for the because of the intermediate vision, higher quality and the clarity of vision, and minimal visual symptoms as compared to the multifocal or trifocal IOL. The basic principle is to create a single continuous elongated focal point from far and near to enhance the depth of the focus. And because of the elongation consequence of the linear distribution of the light energy, instead of going all this energy to one or different foci, there is potential decrease in the contrast, sensitivity, and degradation of the retinal optical quality of the image. So it's kind of a pseudo accommodation. It's due to the static optical property of the pseudophakic eye that is independent of the ciliary muscles of the IOL. There are various factors that provide the EDOF IOL, either the corneal and IOL wavefront aberration, astigmatism, or small pupillary size. Based upon this, the EDOF IOL were introduced. So the EDOF IOL are basically either upon the spherical aberration based, pinhole effect based, and the multifocal IOL with the low power near vision addition, or even with the hybrid multifocal EDOF IOL, that provides a kind of EDOF effect with the intermediate vision. But nowadays the monofocal plus IOL, that is the modified central optic profile lenses that are providing a good intermediate vision. So this is the Vivinex Impress IOL, the enhanced monofocal IOL. It is on the proven Vivinex platform. This is the optics that is tolerant to coma, the aspheric design, which is for the improved intermediate vision, and the distant visual outcome are more tolerant to the residual refractive error as compared to the standard monofocal IOL. The another thing is the material that is glistening free and there is no calcification chances, and the design provides an outstanding rotational stability. While the preloaded injector system with the push or screw method provides a smooth and controlled delivery. So the Vivinex Impress IOL as compared to a monofocal aspheric IOL provide a wider range of focus and improved outcome in the presence of the residual refractive error. But as compared to the standard monofocal IOL, it provides good distant visual acuity, and the incidence and the intensity of the glare and halos are comparable, that is nil. The standard monofocal aspheric IOL that provide a good distant vision, while the Impress IOL which provides a good intermediate as well as a distant vision. So the optic design, the refractive optic design that is introduced in the Vivinex Impress IOL is the central part. The 2mm has a smooth combination of an even order and standard aspheric surface, while the peripheral part has a standard aspheric surface. So in the center there is an optical element is introduced with a smooth surface profile that creates a variation in the power to provide a wider range of depth of focus for the intermediate vision. So when the compared with the monofocal IOL, the distant visual acuity is comparable, while the intermediate visual acuity is 66 cm is excellent as compared to standard monofocal IOL. And the multi-site injector that provides push or 200 screw injection provides a smooth and consistent delivery. So when we compare a small center study with our center with the trifocal IOL, and we also assess for the photopic phenomenon of patient with the subjectively assess for the glare and halos in the 25 eyes implanted trifocal, and 25 eyes we implanted a Vivinex Impress IOL. And when we compare, the distant vision was comparable in both the group, but the intermediate vision was better in the Vivinex Impress IOL as compared to the trifocal IOL, while the photopic phenomena, glare and halos were much higher in the trifocal group as compared to the Vivinex Impress IOL. So we can conclude from our study the Vivinex Impress is provided the best uncorrected intermediate vision, while the near vision is somewhere between the trifocal or the monofocal IOL. So before implanting an IOL, we also consider the patient demand as well as his or her personal lifestyle and preferences before implantation of the IOL. And in cases of the relative contraindication where we cannot implant the trifocal or multifocal, like in case of the corneal defects, macular alteration, glaucoma patient, in such type of patients, Vivinex Impress IOL can be easily implanted. So this is a small video. It is showing that it can be easily implanted with the 2.2 mm incision, and the delivery is very smooth and consistent. So it can be easily implanted and very. Thank you.
Hello, thanks. That was a nice talk, and I think we'll take help from Dr. Kumar here to comment. He's been using these lenses, and it's always intriguing for me that if an ophthalmologist has to get a lens implanted for himself, what would he choose? And I think Kumar operated on his dad, who's a renowned ophthalmologist. And what would you have chosen for your father, and what if you had to choose something today for yourself, what you would choose? Would one of these kind of enhanced monofocals or an EDOF or a trifocal? Quick comment, not a very lengthy one.
So I operated my father and my mother. My father I put a Technis 1, and my mother I put a Technis multifocal, the folder 1. It's many years back. Of course we are more dear to our mothers, so I was a little partial there. But if I had to do something for myself, I think today I would select a EDOF IOL. I still have a psychological, I am doing Synergy, and I'm using the Vivinex platform also for the Hoya. and results are excellent, no doubt about it. Patient satisfaction is brilliant. But I thought as an ophthalmologist, I don't need to look at the trolley, and I don't want halos. I also do a little bit of photography, so I don't know how it will behave in photography. So my thought, for my own eye, I would prefer a EDOF IOL.
Would you qualify what kind of EDOF? Like, because EDOF has
So
a
right-
spectrum of lenses.
So right now, I would still prefer something like an Eyehance, no financial interest, or an Impreza from Hoya, any one of those. But there's a new one coming from J&J, which is already launched in Europe, which almost removes your reading. I forget the name. I think Nanavati implanted that, guy in England implanted that.
From
it's
which,
gone
come from which?
J&J.
Oh, that's Pure C.
Pure C.
Pure C.
So I don't know how Pure C will behave in our Indian eyes, but I know that eyes behave a little differently with different IOLs, like the Array IOL, which was the first IOL which was launched in the US, which was FDA approved, didn't do very well in India. And it was out of India very, very soon. So I think Pure C might be a better solution than one of these EDOFs.
We always live on hope, right?
Yeah, we always live.
Okay, Kamal. Yes.
Okay, I'll, for the audience, I operated my wife 1 month ago. Clearance extraction. I used my hands. I've used most of the lenses, Sifi, Lucidus, name all. Even my partner I've operated, Samir. And all these are clear lens extraction. Mind you, they didn't have cataract. With I had anisometropia. My wife had anisometropia of -5 in one eye. So I operated one eye and she's emmetropic. And so few learnings, of course, but yes, if it's of me or my close relatives, I would not go in for a combination hybrid EDOFs. I still am averse to the diffractive things there. I've used a lot of them. I would probably go in for an enhanced monofocal for patients who are looking at very fine quality vision, people like Kumar, photographers, surgeons. You could go in for enhanced monofocals, at least as technology stands today, in my opinion.
And I think Impress is almost pretty much similar to Eyehance, right? And a very good injector system, as you
Yes,
said.
sir.
So we'll quickly go on to the next talk.
Thank you.
And Ritu is going to speak on algorithmic approach to premium. That's a very interesting topic. I think we could have taken this question after her talk. So, and also I'll request, I think Saurabh is not here. So next speaker will be Dr. Umang Mathur on how newer AL materials is improving outcomes. So please go ahead, Ritu.
Can I have my slides? Thank you, Gaurav, and it's wonderful being here at this platform, and I'm truly honored to be speaking in front of Dr. G.N. Rao. He's been an inspiration to all of us for so many years, and I'm sure his principles will always guide us to do the right thing for our patients always. So I'll be talking about an algorithmic approach, as we've just recently discussed. Premium IOLs are definitely taking a bigger share in our practice, and we need to understand which ones to choose. Now there's really become too many options available. What we need to understand is that we have to give our patients a more physiological vision. I think that is something all of us desire, is to have vision that we had in our, maybe 20s and 30s. And we have so much technology available. We've been hitting the target better with better machines, better biometry. But the main problem is the loss of accommodation the moment you change the lens. And that is what we need to, the barrier that we need to overcome. So what we are wanting is a quality of vision, a seamless vision from near to intermediate, because that is what most of us are using functionally, practically, whether we are reading a book, it's not a rarity, whether we are using a tab or a mobile, most of us are, spending at least more than 50 to 60% of our time on some kind of a digital screen. So the intermediate and near vision has become so important to us. And as you can see, it's not just the younger generation, but anyone above the age of 65 is also spending a large amount of time on a digital screen. And in time to come, that's increasing. So the options for presbyopia correction, as we can see, there are so many, and it's also very confusing. But if we are not clear in our mind, then it's very difficult to give a clear picture to our patient. And a confused doctor can never convert a patient. So because patients are going to leave that, you may explain everything, you may counsel them, but the ultimate decision, and we have to nudge them in the right direction. So we need to decide what are we going to go for. Now, the key to success is always a proper patient selection, a thorough counseling and workup. There's no shortcuts to IOL selection and planning. And in our previous section, we've already spoken extensively about it. A pristine surgical technique, that is extremely important, because if you want a good lens, unless your surgical technique is pristine, you cannot deliver what you want. And of course, a proper post-operative management also, because dry eye is one problem where the patients can get dissatisfied, and you need to, manage those things. So in patient selection, I would say you need to give adequate chair time. You understand what the patient is wanting. Not all patients are looking for spectacle-free vision. What is the distance which is important for their daily activities? So, delving into their routine, seeing the patient's hobbies, occupational needs, do they do night driving, what is their expectation, and also to understand what are the limitations and explaining to the patient, what limitations we have with our current technology. So counseling should be done properly, either yourself or you have a counselor, telling the patient that 100% independence may not be achieved. You may require good light for reading and some amount of glare and halo, so spend some time pre-operatively rather than having dissatisfied patients later. Knowing when to say no to premium IOLs is also important. So see your kind of patient, whether there are any comorbidities which would hamper your results, and whether if there are intraoperative complications, you may have to change your plan of action. So do a proper workup, and I'm not going to delve into this. We've already had several talks about it. And as you can see, there are so many designs of IOLs available. I think practically every few months you have a new IOL coming up, and the industry is also pushing you to try them. But do you keep trying new things, or do you try to sort of see when do you enter? Is it when the lens is just coming into the market? Or do you, see for the results? Do you see the peer group, go into the literature, and then decide whether that lens is worth trying or not? So doing a comparison of different lenses is also good to see what lens would suit your patient, understanding the strengths and weaknesses of each lens, because there is no perfect lens. But when you're going in for an IOL, you should understand what are the strengths and weaknesses and where these problems can arise. So my approach is firstly to find out whether the patient wants a spectacle-free vision, can he afford it, or if he can't, I would not say no. I would still try to give him relative spectacle, freedom by doing a monovision. And if the patient can afford, understanding his personality, his night driving problems, or if the patient has never been able to adapt to progressives or has some, problem like a mild glaucoma or ERM, I would go for the extended range of vision or extended depth of focus lenses. And definitely my tolerability for astigmatism is very low in such cases. If the patient is easygoing, has a lot of reading work, hobbies like needlework, is an outdoor person, and a patient is very, very keen on spectacle independence, I would prefer trifocal lenses. Again, the astigmatism has to be corrected in such patients, because even a small amount of residual astigmatism can lead to a less than desirable result. So how do you select the lenses? Depending on the patient's need. We used to do a lot of blending earlier, but you can still do mix and match. You may have a patient with a monofocal who wants to have a multifocal. You do not need to say no. You can go for enhanced monofocals or extended depth of focus lenses. You can go for mini monovision, where you're using EDOF lenses that can enhance monofocal. The first eye you can target for distance, and the second eye you can leave them slightly myopic. Again, for trifocals, it's always better to do a bilateral implantation. It gives you the best results. And in some eyes, you need to see whether you want to do a dominant monofocal vision, and in the other eye, you can go for a multifocal or EDOF. I have done even one eye multifocal lenses, and patients are reasonably satisfied. So patient satisfaction, it all depends. It's inversely proportional to the preoperative expectations. The cost of surgery also counts. Patients who are too internet savvy and are searching all kinds of lenses, or who are discussing too much with you, they are less likely to be satisfied. And it's directly proportional to the chair time you spend preoperatively. Of course, the easygoing patients and hyperopes, they're usually very happy patients. So in conclusion, no one lens suits all. Customization is extremely important with counseling, setting the realistic expectations, delivering your best, And yes, the quest for the perfect presbyopia correcting IOL still continues. Thank you.
Very nicely summarized and explained, Ritu. And I think all of us sitting in the audience here are always in a dilemma on how to choose and what is the best way. I just had a quick question for the whole audience. Like, how many of us still do monovision? Can you raise hands? Like, is anybody?
Yes,
huh?
Absolutely.
Yeah, even I do monovision. I mean, I don't necessarily have to put. So I think monovision is still a great choice, and I do practice monovision sometimes, not as a uniform thing, but there are patients which will do really well with monovision. And any comment, Gaurav, on this talk? And then I have a quick question for Sir, because not related to surgery, but something else.
It's really difficult to give a choice of lens to a person, but I think all the lenses are good, provided you have the right patient to implant it.
Absolutely. And so for Sir, I have a special question to keep this light, as a follow-up to what situation you were talking about. If the current Prime Minister of India calls you up and says that I'm really confused, I've consulted 3 top ophthalmologists of Delhi and I'm now confused about which lens to go for, and you were asked this question to, he wants to get operated in Delhi itself, but a choice of the lenses, how would you tackle this? It's going to be a tough situation.
I would tell him straight, now I don't even examine patients. So I can't give you any consultation of any value. And I suggest the names of people that he should see.
Yeah. So telephonic consultations can be terrible, and I think when you don't have the whole picture, that message is so loud and clear. But these are some very difficult situations, and I'm sure Umang deals with a lot of such patients as well. So, oh sure.
So which lens would you like implanted in your eyes?
Oh, wow.
I see you're not wearing any glasses.
Somebody joked and said, since he doesn't read anything, so he doesn't need any correction. No, I had both eyes had cataract surgery, and I had monofocal lenses. And I don't need any correction. So ask Praveen what the trick was.
Praveen, yes, of course. Brilliant surgeon. So I think we are on to Dr. Umang Mathur, who is going to be speaking. This is one of our sponsored talks, how newer AL material is improving outcomes. And I'll request Dr. Mayank Pankti to be ready on the other podium as well.
Thank you, Gaurav, and thank you, Uttarakhand Society, for inviting me. Yes, it is an honor to share this platform with my guru, Dr. Rao here. This talk, I think the organizers wanted this talk to be presented, so I'm just sharing my own experience with this newer material. So Clarion is a new material that has come, and it is a hydrophobic material, and from the Acrosoft platform. And over years, we've seen a number of different, this whole material evolving, and all our Torix premium IOLs have been on this platform. We've been generally happy with the hydrophobic material, the Acrosoft material, very stable refraction, predictable, very low PCO rates. But there is always a need to improve. There were issues with the glistening of the lenses over time, which of course in the last few years had reduced, but then that was one issue that was there. So how do you get better optical clarity? And also as surgeons, we want very smooth unfolding. And typically, I think the closed cartridges that come with the lens make it very smooth, but the newer material makes it even smoother. We are part of the study that when this was getting introduced, and this was a multicentric study where we studied the material for over 12 months with very close follow-up. And the refractive stability, both the unaided and the best corrected visual acuity, remained very stable throughout the whole period. And that tells you about the stability of the lens in the eye. And we also look for the clarity of the lens, contrast sensitivity, and how the surgeons felt about unfolding of the lens. What we are also seeing is that although it's a classic monofocal lens, But in a lot of patients, we get reasonably good near vision. I think something that Dr. Rao was alluding to, we do have a lot of patients who can manage near vision pretty well, although it's a classic monofocal. And that's the thing that we enjoy. I think it doesn't give you any kind of issues that come with monofocals, multifocals, but to get some reasonable independence of near vision. So also the design is such that the entire optics gives you a very sharp, crisp vision with no edge issues. Very predictable, low PCO rates. They've become even lesser than the earlier ones, with less than 2% of the patients needing any YAG capsulotomy. Like I just mentioned, so a lot of these patients do have pretty good near vision, which I think is just serendipitous. We never expected it, but a lot of patients have reasonably good near vision. So a lot of the newer platforms of Toric, the Vivity, and the Panoptics now are being introduced on this very platform. And quite happy with it. Especially the injection system, both the autonomy is very smooth, but then it adds to the cost. So sometimes you feel that it's a bit of an overkill, but the usual cartridge by which you inject also makes it a very, very smooth delivery. Thank you.
Thanks, Somang, for that nice presentation and for accepting to speak on this one. I wanted to ask, of late, we've been having lots of visits by the Eyecon team, and they keep trying to convince me that the Clarion, just the monofocal, seems to have ability equal to the enhanced monofocals from the other platform. Have you noticed any kind of? So
you can't really overpromise. It's not that everyone will get it, but yes, a reasonable number of patients are something like N10 when you do implant in both eyes, and that has come as a bit of a surprise. But I think we were never evaluating a lot of our patients earlier also. Now I think a lot of us try to test for near vision. Otherwise you'll find the optometrists would generally just put 2.5 and you send the patient out. But a lot of patients, I think when we started doing this, we realized even some of the older patients actually had
absolutely. Even with the accuracy of IQ, I used to have some patients just reading N8 or N6, just by doing that, and Sir himself has just told us that.
I know Dr. Kalam had a monofocal, and he was 6.6 and N6.
I think
but maybe that's to do with the greatness of people.
No, I think the cornea, the prolateness of the cornea might be playing its role as well, and then the negative Q value on these lenses as it is, they've enhanced that negative sphericity.
So they weren't designed for it, but you find that many patients have reasonably good intermediate vision.
Absolutely. And Gaurav Mishra is a big user of...
I am a big user, and I think in younger patients we find that this is much better, the near vision is much better after implanting these lenses, because we are getting younger patients coming with cataract nowadays, lot more than earlier.
So do you implant, in younger patients, are you going to implant a pure monofocal or like
sometimes
enhanced monofocal or like beyond?
No, it depends upon patient's capacity to pay.
Okay.
Yeah.
No, but why not then just use an Indian good, they are pretty much...
That is also what we are doing. So it is a plus and minus combination of both the things that you have to see to it.
Wonderful. Great. I think we'll request Mayank to take stage now. And
thank you, Gaurav. Right. So I think I will be ending the ION session. So lots of questions were asked. Gaurav, you were thinking what makes a monofocal better. Let us see if we can resolve the questions here. Okay. As Dr. Umang had beautifully put up, there has been advances in various ion technologies, from only quantitative vision, where we had put spheric monofocal ions. Now we have gone to quality and quantity vision both. And the aim is to improve the intermediate vision as well as near vision. So intermediate vision in today's perspective, it is very important. Most of our colleagues, let us say 90% of the professionals are on laptops and computers, or if they are not, then they would be playing video games, or usage of internet is extremely high in India as well. So at present, how do we define the availability of the lenses? So the ions could be monofocal or premium category ions. And then there is a subset of ions which we can call as a monofocal plus ion, which we also discussed just before. A monofocal ion, which is in plus in nature, would provide you an extended intermediate vision, whereas a simple standard ion would just be providing a distance vision. So let us understand the concept of a monofocal plus. The FDA criteria is clear about the classification of monofocal plus. So it advocates the implant should have a monoocular, distance corrected, intermediate acuity of vision of 2032 or 0.2 logMAR units at 66 centimeters in 50% of patients. So that is how we would classify a lens to be a monofocal plus. So this is in addition to a 2020 quality of vision for distance. So various ion designs have come up for trying to reach the aim of reaching better intermediate visions. This could be spheric aberration based, as pure spherical optic design, zonal non-diffractive optics, and then there is an option of refractive technology, which is no rings, no zones, no non-spheric, continuous high order spheric ion surface, namely which we have Technis Enhance, which was discussed previously as well as a preferred choice. So what does it do? It does increase and improve the intermediate vision compared to a monofocal ion, and has a dysphotopsia profile which is similar to or less than or equal to an aspheric monofocal ion, and reduces the spherical aberrations to almost zero. Moreover, there is no detectable anterior surface differentiation. If you see that even on a slit lamp or a microscope, there is just a small change in curvature which causes the same in the central part. It provides you an extended area of intermediate vision, which is better than a pure monofocal lens. It's equally tolerant to decentration as a standard monofocal ion. So the properties are more and more like a monofocal ion, whereas the behavior is that it has a better bigger landing zone, and it provides you intermediate vision of more than 84% spectacle independence for intermediate zone, which we, to begin with, had asked for at least 50% and more at 66 centimeters. So that is how it qualifies into a monofocal plus ion category. These are various studies to show that dysphotopsia profile and contrast performances as compared to other monofocal ions are same. I would like to conclude. Thank you.
Mayank, very nice talk and very well concluded. Only one thing I want to tell everybody here is that whether you're using an Eyehance or you're using a Panoptic or a VVT or a Clarion, there's no learning curve.
That's
because
right.
if you used a Technis One or you used an IQ, you don't have to really think how are you going to put an Eyehance or how are you going to put a Synergy, because the lens platform is exactly the same. So the injection technique is not different. So that's the big advantage of the new platforms that are coming out, that the learning curve for implanting a new, in the initial days we used to say that if you want to put a multifocal, your technique of insertion, presentation, etc. should be different. But here it's exactly the same. Very nice talk.
Moreover, counseling techniques are also very easy.
Yeah.
Your chair time is also important.
Yeah.
Thank you.
I think, thank you.
Thank you, sir.
Next, we'll have Dr. Asif Khan, and he'll be talking on rotational stability of lenses.
A very good afternoon to all of you. Thank you, sir, for giving me this opportunity. I'll be speaking about the newer version of the Technis Toric, that is Toric 2. Few lines about the astigmatic burdens. Astigmatism is the most common refractive error in adults, and even as low as 1 diopter of astigmatism impacts the quality of life. Toric IOLs reported significantly have better quality of life than the patients who receive the monofocal IOLs. Reduced quality of distance vision. Uncorrected astigmatism is associated with reduced distance visual acuity, contrast, sensitivity, and depth perception. And it was also the patients, 60% of patients implanted with a monofocal IOL had equal to or more than 1 diopter of residual astigmatism with or without corrective co-surgeries. The uncorrected astigmatism is also associated with a decreased reading speed and clarity of images on a mobile phone or a computer, and it also causes negative effects of glare on oncoming traffic headlights. The prevalence of astigmatism more than 1 diopter increases with age, and these patients are twice as likely to fall. Axis misalignment of toric intraocular lens, placement error, and postoperative rotation. It has been seen that the greatest misalignment occurred as IOL rotation of around 5 degrees within 1 hour after surgery, and the IOL orientation was highly stable after 1 hour postoperatively. Technis Toric IOLs are the same Technis, it is based on same Technis platform, that is lock-in Technis Visual Performance. Technis Toric 2 is a new toric design platform which offers more surface texture and friction on the IOL haptics to hold an IOL in proper position within the eye. It is made up of the same Technis material platform and the same optical features that provides high quality vision. The new Technis 2 haptic has got the square edge and the frosted appearance. Technis Toric 2 study background was the clinical evaluation of 4 prototype designs were done. Prototype and control were spherical, 4-spot axis making enable assessment of lens orientation, intraoperative baseline photos used for final surgical position, baseline photos compared to determination slit-line photos at each post-op visit, haptic development project for improved rotational stability, project scope. Selected design was squared frosted haptic for improved rotational stability, a new haptic design with significant rotational stability, and there was no change in the optics, only the haptics were changed. Selective landmark features. Order of priority for ocular features for the marking: the blood vessels of the pigment in or on the cornea, the blood vessels of pigment close to the limbus, iris features. Use of process described earlier to select the correct location of the limbus in each image. Blood vessels where they stop or go into the cornea or the other blood vessel features. Protocol recommended at least 10 features per analysis if possible. As we can see in this picture, the blood vessels which are going into the cornea are more reliable. Inner edges of vessels growing into the cornea are good landmarks. In this picture, points where blood vessels appear to stop where it goes into the sclera. As we can see, this vessel is going into the sclera is more reliable. Although blood vessels may change appearance over a time and in different images, so long as you are clicking the same location on the vessels in each image of analysis is valid. The picture is base image and the test image. The blood vessels are same, although the appearance is different. Selecting pigment landmarks. Here you can see with the red arrow the base image and test image of a pigment landmark. Using iris features. Iris features can be problematic. They can change position when the pupil changes size. Pupil is smaller in the operative image and bigger in the post-op image, so the iris pigment spots are further out in the second image. Image rotation and rotation measurement. Operative and postoperative photograph registered by manual selection of matching scleral vessels and iris details. IOL markings identified to determine change in the lens orientation. Study results and performance. 100% of the eyes has less than or equal to 5 degree of IOL rotation at 1 week. 99% of the eyes had less than or equal to 5 degrees of IOL rotation at 1 month, and less than 1 degree absolute mean rotation at 1 week and 1 month. See, not all 20/20 is equal. So high quality vision is ability to see clearly even in low contrast situation for your patients. Deliver highest quality vision by simultaneously addressing both optical aberrations. Addressing chromatic aberration and spherical aberration together provide better quality of vision than simply reducing one or the other. The Technis monofocal IOL provides 14% improved image contrast in a pupil size of 3 mm and 35% improved image contrast in a pupil size of 5 mm. Glistening also causes light scatter from the IOL. Sustain high quality of vision with capsular quality, the capsular phimosis can occur after cataract surgery and can lead to decreased vision and IOL decentration. It is only 4% in Technis IOL and 48% in the competitor. Benefits of Technis toric IOL. Technis IOLs leverage the strength of proven platform. It has provides sharp quality of vision, provides highest image contrast performance under the lighting conditions, minimizes light scatter, minimizes decreased vision and IOL decentration. At higher cylindrical correction, 94% of patients had binocular uncorrected distant visual acuity of 20/25 or better at 6 months. Use of toric IOL provide improved uncorrected distance vision, reduction in residual refractive cylinder and increased spectacle independence for distance vision. Excellent binocular distance vision acuity for patients with best astigmatism. 88% of patients achieve 20/20 or better monocular corrected distance visual acuity. Technis toric one piece delivers an outstanding cylindrical correction for high quality of vision. 94% of eyes achieved less than or equal to 0.5 diopter of residual refractive cylinder, and around 98% of eyes achieved less than or equal to 75% of residual refractive cylinder. Higher confidence driving at night without glasses. So the 97% of patients would choose to have the Technis toric IOL implanted again in the eye. Thank you, sir. Thank you.
I just wanted to ask one thing. What is the cutoff criteria for putting in a toric IOL? Is it 0.75 or 1 or 1.25?
Sir, I started my cases with 1.5. But now cutoff, I am taking around 1 diopter of astigmatism.
Yeah, I think all of us have accepted toric IOLs as almost the norm for most people.
One of the Indian manufacturers 7 years ago started with a concept called universal toric of 1.25, which was a smart universal toric, and that's when I believe the market started swinging, and it was low priced as a little bit more than the monofocal. I think that was a good move to switch people from get the taste of torics over the last 7-8 years, and it has worked.
I think our next speaker is Dr. Vipul Arora.
Yeah.
We're talking Eye Connect.
Yeah. So, good morning, respected seniors and dear friends. I shall present key features of dry eye and their management, specifically the role of lipid-based artificial tears. So, dry eye, as we all know, is a very common issue which we face daily in our OPD practice, and 32% is the overall prevalence of dryness, which increases to 81.3% when measured objectively. Most patients are of moderate dry eyes, followed by severe dryness. Unless patient complains of dryness, it's often missed in initial screening. And the reason behind this is symptoms only appear in moderate to severe dryness. Also, there is no one test to diagnose this issue. Most of the tests commonly available are invasive, and non-invasive tests are costly. Also, there is high chance of poor correlation between the test and the symptoms. So, using artificial tears in a patient with dry eye reduces the discomfort by almost half, and dryness affects, as we all know, in our daily life in many ways. Now, tear film traditionally has been described as a 3-layered structure, but in contrast, the Tear Film and Ocular Surface Society Dry Eye Workshop, 2nd edition, which is commonly known as DUCE 2, depicts the tear film as a 2-layered interactive structure composed of a mucous aqueous layer and a lipid layer. The tear film has a hydrating aqueous layer and a protecting lipid layer. These form nourishing and defensive barrier against pathogens. Now, lacrimal gland secretes aqueous and meibomian gland secretions form the lipid layer. The lipid layer acts as a barrier, retarding evaporation of aqueous layer. Now, identifying the primary dry eye disease subtypes as an aqueous deficient one or an evaporative one remain important for classification. However, the consensus of DUCE 2 is that these subtypes are not they are not separate entities, rather they are under a single entity. Determining the predominant underlying etiology can be useful in directing primary treatment strategies. Evaporating being the most common form in these subtypes. DUCE 2 defines dry eye as a multifactorial disease of ocular surface characterized by loss of hemostasis of tear film accompanied by ocular symptom in which tear film instability and hyperosmolarity, ocular surface inflammation and damage and neurosensory abnormalities play etiological roles. Lamb et al. Studied the distribution of the two varieties of dry eye, and in summary they concluded that evaporative dry eye with meibomian gland dysfunction is around 86%, is significantly higher in subjects than the aqueous deficient one. They also concluded that the disease was significantly increased in the mixed form of the disease. Risk factors for evaporative dry eyes includes MGD, that is meibomian gland dysfunction, ocular surface related issues, systemic disorders and others like lid disorders and contact lens wears, etc. Now, treatment aims to relieve symptoms of dry eye, increase the comfort of the patient, prevent corneal damage and maintain tear film homeostasis. DUCE 2 presents an evidence-based multi-stage management algorithm in order to determine the most appropriate dry eye disease treatment for each patient based on subjective and objective severity measurements. Now, step 1 includes patient education on the disease condition, preventive measures, ocular lubricants and lid hygiene. Step 2, compromise management with prescription medicines. Step 3 includes oral secregods, then bandage or scleral contact lens, autologous serum eye drops. And step 4 is reserved for refractive dry eye disease that require long-term topical steroids or punctal plugs. And if we see the treatment as per of the layer affected, then we have warm compress and lid hygiene if lipid layer is affected. Artificial tears, punctal plug if aqueous layer is affected, is deficient. Anti-inflammatory drugs like ripamamide if epithelium, and autologous serum in case of globulate cell deficiency. Corticosteroids and cyclosporins are used in a case of ocular surface inflammation in refractory cases. Now, available artificial tears are either demulcents or emollients. Aqueous tear, though increases bed time and reduces fluorescence staining, they are not effective in all the cases. So, aqueous artificial tear do not work in lipid dysfunction and inflammation of ocular surface. So, as lipid layer ensures reduced evaporation by 90 to 95% and reduction in surface tension of tear film by 25%, by reducing the tear film osmolarity, emollients are useful adjuncts in dry eye disease. And as per a recent paper by Ronald M. and Mario Lovis et al., management of evaporative dry eye is based on patient symptoms, severity and disease pathophysiology. Like if the patient have active blepharitis associated with MGD obstruction and evaporative dry eye symptoms, so first we have to treat it with antibacterial and steroid combination drops and maintaining lid hygiene, followed by maintenance of epithelium and restoring the lipid quality. If the case is of mild meibomian gland dysfunction and chronic dry eye, we have to use less potent steroids along with lubricants. And in cases of overusers of screen and have patients having increased screen time, we have to educate them on the behavioral changes, and also regular use of lipid containing eye drops are useful. Now, nanoemulsion eye drops are composed of particles that are generally 10 to 1000 nanometers in size, and they are packed with both aqueous and oil component. It increases the lipid layer thickness and improve OSDI scores. So one of these drops containing these features is Sustain Complete, which is a nano-sized lipid droplets, and also has polyethyl glycol and propyl glycol with HP-GOAR, which increases the mucus layer thickness. It works on the lipid layer and the mucous aqueous layers of tear film, and it increases the lipid layer thickness and also the patient satisfaction. So in conclusion, dry eye, as we all know, is a common disease. 4 out of 5 cases are of evaporative dry eye. Lipid-based artificial tears are effective in evaporative dry eye as they mimic natural tears and replenish lipids. Thank you.
We all know dryness is important, but I remember the first week in LV Prasad, and I was seeing all the files had something written as flat lids, and I didn't know what it was. And that's when I discovered how important it is to look at the lid margin. And I think we keep missing out on that part. I think a basic clinical examination of meibomian gland disease, I think drops apart, I think it is, you have to look at what is the pathology and then attack it. And I think the commonest thing that we see is the meibomian gland disease, especially in older people.
Yeah.
And that is something that we miss out on in our clinical examination.
Especially if we are just looking on the slit lamp and not the lids.
In 1987, when we started the LV Prasad, when I was asking our colleagues in India how much of dry eye and meibomitis problem we have, everybody told me we hardly have any dry eye or meibomitis. That was because there was no practice of examining a patient on slit lamp in those days, very rare. And I remember that Professor Klaus Dolman, he's now 102, still goes strong, works 6 days a week. And he was the father of cornea research, corneal training in the world. He used to say, dry eye and meibomitis are the commonest misdiagnosis in the world. So, detailed evaluation of the lid margins and the precorneal tear film is paramount to ocular health, surface health.
It continues to remain the least diagnosed.
So, I think having an ocular surface analyzer in our practice has now become mandatory. Because if you're doing premium IOLs, if you're not able to analyze, I mean, you can do your Shermers and all, but it's a very quick way of analyzing, and including something like a Lipido or IPL in your practice. Again, I think the number of patients we see of MGD now, if you actually look for it, I would say every second patient has some form of MGD, whether they are symptomatic or not. So prior to your cataract surgery, optimizing the ocular surface is very paramount.
Ritu, I would have an opinion from Umang. Is it necessary to have this lipid flow and all those things instead of a slit lamp? Because slit lamp itself is a good tool to diagnose.
I find most of these machines very confusing. And I think dry eye, mostly it is clinical, and also a lot of it is questionnaire based. That in not so much as hard science when you're looking at improvement. But I'm happy just doing clinical examinations.
No, but I partially agree with Ritu. A lot of times to convince the patient, you need some diagrams or some investigation. So the compliance goes up. A lot of times they do not figure out and they don't think there's much wrong with them, and they come back much worse.
I think one other area we continue to neglect, even in the best of the institutions and cornea units, is the role of corneal sensitivity in preservation of corneal epithelial health. And even till today, we depend on the 100-year-old instrument, Koscheban anesthesiometer. No progress has been made. Just a couple of weeks ago, I have challenged our cornea group and the technology innovation group, why don't you guys work together and come up with a patient-friendly and user-friendly way of measuring corneal sensitivity. It it is going to be increasingly important as you do more and more of, what should I say, multiple kinds of attacking the cornea that we are doing now. So if you don't understand that and continue to neglect it, we'll get into trouble. Even today we don't have any proper understanding of neurotrophic mechanisms in the cornea.
Thank you, sir. Thank you.
So I'll next invite the man, Gaurav Luthra here. Of course, he's responsible for this meeting and making it into what it is today with several years of work. He has an interesting talk. I really don't know what he's talking about.
Yeah, so I think you guys deal with a lot of these things since you have a training program, and anybody who has a training program would probably be dealing with these. I deal with them for a different reason. I get referred sometimes these cataract aborted surgeries where suddenly you have a constricting pupil or a runaway rhexis and somebody panics and says that, oh, you get, go and show somebody else, and they'll call in and say that, can you please handle this? So a few situations I thought I'll share. There are some learning points there, and I was looking to make something different and this came up. So one of these patients was here referred with an air bubble in situ. This was just 2 days after surgery where this surgery had been kind of aborted and referred, and I couldn't see much to decide whether the, what was the status of the rhexis. The pupil was not, in fact it was a suddenly constricting pupil which required the surgeon to refer off because they did not have access. So I think first learning lesson here is let all of us keep iris hooks handy. They are so easy to use, they are so easily available, and they are inexpensive, and I think most of us do keep them. But for that occasional situation where somebody who's still not using one, if you have a suddenly constricting pupil, they are invaluable and can be used very easily. So here I decided to stain under that bubble itself because I wanted to know the status of the capsule. And sometimes you'll get an honest opinion when the referring surgeon tells you everything, and then sometimes you'll just say, oh, everything is good, I have an intact rhexis. You just have to kind of go in and get it out, and then you're not prepared for what you'll eventually see inside. It may be totally different from what you thought it is going to be like. So here I had this thing which looked like a Argentinian flag sign, which immediately got runaway rhexis kind of a situation. The surgeon had tried to convert it into a can opener, and then the pupil became really small. So when I got this, and then of course many of these patients, the cataract is also kind of, the consistency changes over those 2-3 days that it takes for these patients to reach you, and they become sticky, and sometimes it's tough. I was trying to use the pre-existing side ports where possible, and I created 1 or 2 more side ports, and then to reassess where it stands. Sometimes the media is hazy here, sometimes the cornea is not good at all. I remember a time when I had to do one of these patients where the cornea was so bad that I had to abandon the surgery on that sitting itself and then wait for another 15 days till the cornea improved, and then go back in to operate because the view was so bad. So anyway, here I could have either created some kind of a rhexis, but I thought that since already it was a can opener which had been attempted, I'll just, after many years of having not done a can opener capsulotomy, it was nice to be able to practice a can opener. In retrospect, I felt that I could have just used a fine scissors and had a continuous as much as possible, but at that point I just decided to go like this, and then trying to mobilize that nucleus. Of course, now the important thing is, if I have to attempt a phaco kind of a thing here, it's not a very hard cataract, but if I do any forces of lateral separation or anything which is going to expand those, all those capsular tags, it'll just run away to the posterior thing. So I've managed to get a big enough opening so that the forces are not going to be really bad, but just seeing if it cracks, and then ease out those pieces from the back without doing too much of lateral separation forces inside, and of course not going too much in the periphery. And when in doubt, always convert to a stop and chop, just make a trench. So these are some of the principles when you have to deal with situations like this, that you can then sometimes, if you're not getting a good crack, you can just make a crater and do a lateral separation. I thought I was going to do that here, but I've again managed to chop it there, get another chop there. So you cannot use very high parameters here. You have to go easy, you have to be patient, and you have to keep on the lookout because things will crop up. You may end up having Descemet's tears, you may end up having capsular tears running away to the periphery, and some of these eyes are also inflamed, and you have to be cautious getting all that out. Very often you'll have an epinuclear shell left behind, as it happened in this patient, and then you have to be sure that you don't pull in any capsule. Always good to, once the epinucleus is out, good to quickly switch to capsular cortex removal. So anyway, I mean, the message was that you can just deal with this gently and slowly, and then you, of course, iris prolapse can always complicate surgeries like this. It was a floppy iris which had caused sudden constriction of the pupil for the surgeon who was dealing with it first, and then gently getting all the cortex out, which is sometimes very, very sticky. So you have to be careful, and then analyzing whether your bag is intact to take a lens, and then you can go in and implant a lens. And see, you can see here that because of the floppy iris, I'm just moving the iris away from the section with my left hand instrument as I go in to inject the lens, because very often the iris will come and plug the incision when you put in your injector, and you stand at risk of damaging the iris there and traumatizing it. And always a good idea to go with a 3-piece, and you can see that, to add to all your problems, the lens sometimes starts to tumble and it will twist, then you can quickly recover it. And then, as you can see here again, it has fully opened up upside down. So when you don't want things to go wrong, they always do. And then flipping it inside with a totally broken rexus is always as tricky, and these 3-piece lenses also, the haptics are going to be tricky. Your iris will bleed probably. So all these things, I think add to the excitement of such surgeries. And then trying to get this into the bag, and then you can see that, as I predicted, there will be a bleed. So all these things add up. Anyway, so it's always a challenge, but it's also very interesting to deal with such situations because they throw new challenges. Otherwise, run-of-the-mill cataracts you get to do every day, and you tend to get bored, doing the same thing over and over again. Good idea to suture them. This was an interesting thing. It was in our hospital itself. Somebody had started operating, and then suddenly there was a pupil which came down and became so small with every possible thing, with phenocaine and everything. Nothing helped, and I was by chance there to help out. So because the rexus had already been done, I do not normally suggest that we use a pupil expansion device when a rexus is in place, because you will sometimes catch the rexus with one of these devices and break it. But here I got away and managed to get the Malukin's ring in place. This is one of my favorite devices, and then got away with this surgery. Again, iris hooks may have been the best choice, but I just wanted to show you that it can be done like this as well if you are comfortable doing it like that, and of course the rest of the surgery will be straightforward. But sometimes the pupil can suddenly come down like crazy, and then it will not respond to any of your mydriatic drugs. I'll finish with one last situation. I have many, but for the sake of time, this is the last one I'm going to show with you. So this was again referred off with an air bubble in situ and a runaway rexus, and I was trying to understand how far it's gone and whether it is still recoverable, and as you can see here, it has gone far. So I will try to fashion a slightly larger rexus, I think, maybe creating a small flap there, and then trying to make a bigger. I like micro rexus forceps because they can be used from any port depending on where you want to go, like any of your side ports or the main port, and they do tend to keep your chamber more stable. So these are 22 gauge micro rexus forceps, and I think most of us do use one or the other form of this, but they are handy. I don't like to introduce big instruments from the main port because the viscoelastic tends to come out, and even if you have to go from the main port, these fine forceps will be good. So this was a soft cataract, and I was able to get away with this situation. Had it been a black-brown cataract, it would have been a different situation altogether. Since I've run out of time, I had an interesting case, but I think we'll keep that for another day. Thank you so much.
Thank you, Gaurav. Very interesting. I think it's wonderful to have a situation where you have trainees with you, because I think you become a good surgeon you would start learning what's happening and you get a chance to do all these things. And I think we're all very fortunate that we have that opportunity that you get.
It's a different game altogether, and I know that in your institution there's lots of such situations which will be dealt with. I'm sure it can be a great teaching tool to actually have such a collection
you're
of.
Not so stressed. It's not your own case, so
Right,
so you're
right. Patient already understands that it is something which has gone wrong and it's being rescued. So your responsibility may be a little less, but thank you.
Gaurav, one more point is, this is very good that what you did, but you can have one more instruction course as to why it happened. So you can do a retrospective analysis, what went wrong and why that person was in that situation, and of course to avoid the same situation in the other eye, or again, what can be done. Very, very nice. It's a good concept.
Kumar, that's a very interesting idea, but you see, normally what happens is, once you're called in the theater, you start the recording. Your juniors, when they are operating, they're usually not recording.
Yeah, so that's another thing. I used to do that initially, record only hard cases, difficult cases, black cataract, subluxated. But now it's a rule, I learned it from Gaurav only. Yeah. Record all cases.
So that's what we do now, and that's what they learn better, because once you review the film with them, they learn better.
I think recording and showing and discussing is the best way to learn. Sorry, sir.
I'll just give my experience in the 70s when I was a fellow in the US. My mentor had 2 operating rooms in the middle of this is a place called Rochester, New York, Kodak headquarters city. So he used to work with Kodak to get all kinds of technology from them. He has a complete studio between the 2 operating rooms, and we were recording every case. And he insisted on us, the fellows, that after each case that I operate, I have to go and edit my own surgical procedure and learn from it. And then he would come and see. And if we didn't do it properly, he would not allow us to operate any longer. So these kinds of things are valuable learning experiences. That was the era of the beginning of IOL surgery, actually.
I think we're on the last stop. We'll have Dr. Ankit Agrawal on optical and ultrasound biometry. Are we in time?
I would like to thank UKSOS for giving me this wonderful opportunity. My talk was scheduled for the previous session, but I could not do it because I arrived late. So I've heard all the stalwarts and speak about the various complicated surgeries and the various methods of doing the soft cataract, the hard cataract, the various chopping techniques. Let's talk about something which we do before the surgery. That is choosing the right biometry settings, choosing the right IOL power. Because if that is not correct, any kind of surgery you do, the patient will be unhappy. So my talk is a very basic one. It's regarding the biometers. So there are 2 basic types, that is ultrasound based, which we normally use as A-scan, and the optical light based, that is optical biometers. The A-scan, A is amplitude. So basically it works by the reflectance of sound waves from the various tissues. The density of the tissue gives the more amplitude as it is more dense. Optical biometers work by reflectance of light waves from the tissues, and is currently the gold standard of biometry, because it is not operator dependent much. The technologies used are PCI, that is partial coherence interferometry, OLCR, that is optical low coherence reflectometry, and swept source OCT based. The PCI ones were the first generation optical biometers, that is the IOL Master, the NIDAC AL scan and all. The OLCR ones were the next generation, that is the LensChar, Hark Street. And swept source OCT ones were introduced recently, that is the IOL Master 700, the Tomy, the Argos and all. Coming to the A-scan, it works on an 8 to 10 megahertz probe frequency. It's an apnation scan, hence probe needs to come in contact with the cornea or through a medium like immersion scan. It requires good skill to get reliable and precise data. The probe has a red light in the center in which a patient can focus, so that we get the visual axis and not the anatomical axis. There are chances of user error, and inter-user variability is always present. Coming to the optometers, these are the various optical biometers which are available in the market. Mechanism of optical biometer technologies, that is PCI, it depends on infrared rays reflecting from various surfaces. There are different refractive indexes of each surfaces, thus the distance between each surface can be calculated. OLCR is SGOCT based. The interference patterns formed by emitted and reflected beams of light are compared with scanning reference beams, just like a Michelson interferometer, and it identifies its location. And the swept source OCT based biometers are nothing but PCI based biometers with the high infrared wavelength. Thus, the penetration is improved. Coming to the first optical biometer, that is ZEISS. It is the innovator optical biometer. It was launched in 1999 at 780 nanometer wavelength, the PCI based. It has penetration of up to 2 to 3 nuclear opalescence LOX grading in up to 60% of the cases, as in reported in various papers. But the data varies from country to country because the kind of patients which visit us are different. Inbuilt formulas in this biometer include SRKT, Haigis, Hoffer Q, and Holiday 2. The problem with this biometer was that the newer formulas could not be applied as it does not give CCT. Coming to Nidal AL scan, it's also a PCI based biometer, but it has much more anterior segment data procured, like pupil size, CCT, and it has a corneal topography of up to 5 millimeter, which is done using shine flux imaging. The newer formulas which are available in this are Barrett Universal 2 and Barrett Toric Calculator, Barrett 2K. Its penetration is similar to IL Master. It also has an option to attach a scan probe so that the patient need not move from machine to machine if the scan is not possible on this. Coming to Hark-Street lens char. So this machine is a OLCR based biometer at 820 nanometer wavelength. The penetration is better than the previous generations, and the biggest advantage of this machine is that it has a very good corneal topography in the 6 millimeter zone with 32 points of fixation. Next generation comes to Topcon Aladdin. It's also OLCR based, but the Presidio ring based topographer has a 9 millimeters topography zone. So it has a topography as well as biometer combined in single machine. It gives anterior segment data which includes keratometry, CCT, ACD, white to white, and a mesopic pupillometry, which is very important in the practical aspects of patients. It also has corneal wavefront analysis, which gives aberrations, which is important in treating patients for premium IOLs. The newer formulas which are available in this are Abdullafia Koch astigmatic regression formula and Olsen formula. Now, this is the current generation which is being used by most premium centers now. That is ZEISS IOL Master 700. It's a swept source based OCT based biometer. It works at 1060 nanometer. The biggest advantage of this is that it gives total K, that is, it also gives posterior cornea curvature. And as per the various reports on published, about 0.5 diopter of difference of power comes with this. It has a very high penetration and successfully does biometry in up to 95 to 98% of the eyes. The special formulas used is Barrett TK Universal 2 formulas and Barrett TK Toric formulas. One more important feature in this machine is that it can show OCT images of the macula and the lens. So lens tilting, macular edemas, macular pathologies like macular hole, etc. can be diagnosed even before doing the surgery at the time of biometry. It integrates with the ZEISS Callisto system. Next is Tomy OA 2000 optical biometer. It's also a swept source based biometer. It has a Presidio bliss based topographer with the anterior segment analysis, and its penetration is similar to IOL Master 700. It has ray tracing formula which is included in this, that is the Oculex. This is the latest one which has been launched few years back, that is the Alcon or Movu Argos. It's a swept source based optical biometer. It integrates into the Alcon Varion system, and its penetration is almost similar to IOL Master 700, but few reports claim even better penetration than that. Now I've talked a lot about these biometers. So we have to think about the cost factor also, because not everyone can afford everything. So this is the approximate cost which I have found from the by talking to the various company representatives. The IOL Master 500 costs between 16 to 20 lakhs. The Nidec Air Scan 16 to 20 lakhs again. Hark-Street lens char 20 to 25 lakhs. Aladdin 25 to 28 lakhs. The Tomy OA 2000 25 to 28 lakhs again. The IL mass is 700 between 32 to 36 lakhs and Alcon Argos between 42 to 45 lakhs. So we have to justify the cost for the benefit also. By going for the higher newer generation models, the cost also increases. So if we believe that in our practice, the accuracy and the penetration of the higher generation optical diameters do benefit us, then we can always go for them. Optical diameters have made life much easier for doctors since the time taken to do an immersion A scan saved. Also, now any optometrist can also do the biometry under the guidance of the doctor without much of a specialized training. They are becoming more and more advanced with greater accuracy and is therefore slowly becoming an essential tool in the arsenal of the cataract surgeon, but the cost factor is always there. Thank you.
Thank you. Very nice talk and a very good comprehensive conclusion of all the other machines, but I want to tell you something which is very practical. I have a staff of X. I took reading of whole of my staff on 4-5 different machines. The actual length measurement of all this optical biometer is pretty accurate, but the biggest problem comes from keratometry. For example, NIDEC AL scan, the keratometry is very poor, just for the information of the audience. 2, NIDEC by default takes a lens thickness for all patients as 4.30, and no lens thickness is exactly 4.30 everywhere. So that's another problem with NIDEC AL scan. As far as the Argos is concerned, don't go by what the company says. You'll be shocked. Argos does not look at the posterior float at all. And in today's Jamana, if you have an optical biometer which doesn't look at the posterior float, which is not believable. So yes, I know that the accuracy is good. And as far as A-scan is concerned, I personally feel that contact biometry should be banned. Either if you can't afford an optical biometer, do an immersion, which is much more accurate. Never do contact. We used to do contact many years back. Kamal also must have done. I also used to do. Sir also must have done. It's not bad. It's not accurate. But those sudden surprises which you get will be avoided. So I personally feel that immersion or optical is the way to go. Only the optical part is also available. It's around 30-35, and the whole unit is around 55. But that's including metrics. Metrics means does angle measurements, does corneal measurements, wavefront. Another big advantage is it gives you anterior segment OCT image. So there are lots of other advantages besides only optical biometry and accuracy of optical. And now all optical biometers have a built-in Barrett suite or a formula. They have one additional thing called as ray tracing, which is an Oculux, which I'm also analyzing now. Sir is here, Rohit sir is here, and his team is analyzing it in even more depth as to different formulas and how accurate they are. I'm still following the Barrett suite. Sometimes the ray tracing Oculux does not match the Barrett suite, so I'm still following Barrett suite. And we are looking at our post-op, the results are pretty accurate. Yeah, but you should have a device which is looking at it. If you don't have a device, like LensStar, for example, LensStar does only anterior cornea. It's extrapolating the data of the posterior float, which is not accurate in post-refractive cases. So the cases like RK, you may get away with it, or normal virgin eyes, you may get away with it. But LASIK operated patients, you will be in trouble if you don't look at the total K, which is measuring the posterior float.
I agree, but what I'm just trying to say is if you're using the Barrett, you're already taking posterior cornea.
So Ritu, yeah, I get what you're saying. Now the thing is that in normal eyes, the Barrett's nomogram already takes into account posterior corneal astigmatism. But what he's trying to say is that, if you are not measuring posterior corneal astigmatism, there will be outliers. So we now, like, even I'm using the Anterion and the Almasa 700. So I always look at the posterior. In fact, now my Al calculation shows K and TK, for every patient. So, and if I notice a difference between K, which is basically using the Barrett suite, and TK, which is using the actual posterior corneal astigmatism, if I see a big difference in Alpar, I'm immediately alert that something is wrong. I look at the posterior corneal astigmatism. If it's significant, then you have to relook at it, see why it's showing up differently. Is it post-refractive surgery? Is it something else which is an outlier? And that's how you can prevent refractive surprises. So if your machine doesn't even measure posterior corneal astigmatism, you will not know.
Exactly.
Right? The best part is that even the Cirrus machine now, they've given you a software where they do the posterior corneal curvature and total corneal powers. For those outliers, all you need to do is put in your optical axial length, and the other parameters are already there, and it's very, very accurate.
Yeah, with that, I think we'll conclude the session. Thank you all the speakers, and a special thank you to Dr. Rao for being here, and thank you everyone on the panel. Thank you.
So I'll request everybody to remain seated, please. We are coming up with a very important session. We have an oration coming up, and I'll request Professor Rao to please stay on the dais for just another 15 minutes. We need you. We need you there. Oh, we need a picture with all the. Okay, so let's have a picture with all the panelists here, and then we move on to the oration. There's a very prestigious oration right after this, and we have a very interesting lunch after half an hour, which will start. So, please don't go for lunch yet. So all the speakers can quickly come, and panelists, and maybe Rohit can join us here. You're the scientific committee. Yeah, you can come right in the middle. Come. Yes, of course, main person. Great. So, Saurabh here, you can take over now. Thank you.
मेरी टॉक पहले नाम की हाँ मैं इधर से
Very good.
यही
Common application.
Yeah, I'm here. Good afternoon, everyone. It's a pleasure to welcome you all for this very prestigious oration, and we have very distinguished guests on the dais, Dr. G.N. Rao sir and Dr. Rohit Shetty sir. Welcome, sir. And so I would like to invite Dr. Gaurav Luthra, who's the chairman awards committee. I would like to invite our president, Dr. Sanjeev Mittal sir, our secretary, Dr. Satanshu Mathur sir, to please come on the dais. Yeah. Our incoming president, Dr. Vinod Arora sir, to please come on the dais. So it's a pleasure. And also by popular demand, Dr. Ashok Garg, the organizing secretary, please. So it's my pleasure to introduce this Dr. C.S. Grover oration, which is named after Dr. Chandrasekhar Grover. He could not be with us today, but he is the chief eye surgeon at Abhilasha Eye Hospital, which is at Roorkee, Uttarakhand. And after finishing his graduation in medicine and post-graduation in ophthalmology, he joined L.V. Prasad Eye Institute at Hyderabad for phaco training. And subsequently, he has been amongst the first in northern India to start phaco emulsification. He is keenly interested in social welfare of eye patients, has been routinely conducting protocolized eye camp in and out of India, and his motto of serving beyond borders took him to a remote African country with Rotary International to perform surgeries there. And on the land of Swaziland, phaco surgeries were performed for the first time, and he gave massive training to eye surgeons of South Africa. And within the state, he has been performing free eye surgeries in remote areas of Chamoli, and he was awarded the Uttarakhand Ratna in 2012 for his selfless service. He is committed to the highly ethical and best quality services to the society. These are some of the distinguished past recipients of the Dr. C.S. Grover Oration Award, and last year it was Dr. Lalit Verma sir. With this, it's my pleasant duty to introduce our C.S. Grover Oration Awardee for this year, who is no other than Dr. Vishali Gupta, who is Professor and Chief of Vitreoretina and Uvea at PGI Chandigarh, who's a teacher and mentor to so many of us sitting here, and also to me. She has 400 indexed publications, 84 book chapters, 6 books as chief editor, 2 US patents, 995 invited lectures internationally and nationally, She is the President of the IUSG, past President of the Uveitis Society of India, past Secretary and Chairman Scientific Committee of the Vitreoretinal Society of India, several named awards at the AIOS, including the P. Siva Reddy and the Colonel Rangachari, and several orations, including the P. Venkataswamy oration and the SN Alumni oration. With these words, I would like to invite Professor Vishali Gupta to please come on stage and accept her oration. I would request Professor Sanjeev Mittal to please come on the dais as well.
Thank you. Thank you.
Could we request you to please, receive this, the certificate before we,
Sure.
hear your address?
Whatever you say.
Yes. And I would request Dr. Rao sir and Dr. Shetty sir to please come forward and, hand over along with the executive.
Thank you. Thank you, Saurabh. Thank you, Uttarakhand. Thank you, everybody on the dais, off the dais, for this great honor. The topic that I have chosen for today's oration is the road less traveled. Well, the art of medicine cannot be inherited, or nor it can be copied from the books. This art is something we have to learn, and it comes only from its practice and its exercise, and that's what a couple of next few minutes I'm going to be talking about. This is one of my favorite paintings. It's painted by Cristobal Rojas, a Spanish artist. It depicts the wife who has recently died of tuberculosis, but what it expresses on the face of the husband is the shock, numbness, helplessness, and anger. And these are precisely the emotions that we feel when we are not able to help our patients by instituting the right therapy or making the right treatment and giving them the timely treatment. So, unfortunately, the artist himself died 4 years later of the same disease, that is tuberculosis. And this was the year 1856 when it was painted. And if you go back to 1800 paintings, most of the paintings of Mysore are related to systemic tuberculosis because there was no treatment for that. Again, A Sick Child by Edward Munch, showing the helplessness of a mother because her daughter is looking at something on the wall, maybe death. The disease not only affects the people, the patients, but it affects each family members in their own right. And this painting depicts that when somebody is dying, how lonely each member of the family is. This was systemic tuberculosis. Year 1995, that was the year I joined my residency at PGI Chandigarh. And I read this paper by none other than Dr. Jyotirmay Biswas, where 5 eyes were enucleated at Shankar Nethralaya and were diagnosed as ocular TB. I asked Professor Amod Gupta, "Sir, why are we removing the eyes with ocular TB? We should be treating them." but unfortunately, we were not even diagnosing ocular TB. So TB was causing blindness for the simple reason that we were not able to recognize or treat TB. And blindness is not a disease. Blindness is a lifestyle changing. And if you look at Pablo Picasso, I love Picasso, but there was a time in 1903 when Pablo Picasso went through a very bad phase, and that's called the blue phase of his life, the blue period. And he painted very sad paintings during that time. And one of those sad paintings were about the blindness. Because, you know, this is what I have highlighted. He painted beggars, street urchins, old, frail, and the blind. And this is one of those, Breakfast of a Blind Man, or the old guitarist. Something which should be giving you pleasure is not able to give you because of the blindness. So this comes back to my journey beginning in 1995. Two roads diverged in the wood. I took the one on the right side, that is the less traveled by, helping the patients with uveitis. So the road is lonely, and I am honored to be giving oration on this topic today. So I told you that in 1800, people were struggling to find the treatment for tuberculosis, and this is a very famous painting, The Doctor, by Luke Fields. It shows a lot of things, but I will quickly highlight what it shows. It shows the doctor sitting without any equipment, not even stethoscope. He's thinking. He's trying to think how to administer treatment. The parents are in the backdrop. The mother is helpless, and father is just looking at, not managing primarily. And there is a lamp, and then there is a light coming, which means that the doctor has probably spent the entire night trying to think how to help this young girl dying of tuberculosis. The medicines on the side of the doctor, not by the parents. And finally, that eureka moment came in 1905, where in Berlin, Robert Koch got, this is the picture taken, it's not really a picture, but it's the depiction when he just came out of, after receiving the Nobel Prize in Medicine for treating tuberculosis. And it took ophthalmology nearly 100 years to start treating our patients with ocular tuberculosis. So I come back to the story that my first question to Dr. Amod Gupta was like, how can we diagnose TB? So this was year 1995, we just started doing PCR from intraocular fluid to diagnose tuberculosis. Lots and lots of criticism. And this is the experiment of the bird in the air pump, where they were actually testing whether the bird can survive without oxygen or not. If you look at the expression on the face of the person who's holding the cage where the experiment is being held, he is looking straight ahead. He is not looking at the people around him, because people around him could be nonchalant, as is the couple on this side. They could be really stressed and worried. Why are you doing this experiment? And they could be very observant. But if you are doing something new, you just got to ignore all those around you and look ahead like this guy. PCR, I'm not saying was the greatest of the tools, but it did give us a tool with which we can describe the phenotype, and which kind of gave acceptance of to the Western world that, and to our own world actually, that ocular tuberculosis does exist. And one of these articles actually now has 800 citations about tuberculosis. We described various manifestations, the way tuberculosis could present in the eye, and one of the biggest was the tubercular serpiginous-like choroiditis, because before we mentioned are before we discovered that this disease was caused by tuberculosis. It was believed to be autoimmune in nature, was being treated by triple immunosuppressive agents for periods of years together with multiple recurrences. And we ourselves published 95% recurrences on triple immunosuppression. Just the addition of humble ATT reduced the recurrence rate to just 10%. We could take care of 90% of our patients. And this to me was a significant achievement. Tuberculosis is like these skeletons, the triumph of death. These skeletons are lurking behind somewhere, and that's the problem with recurrences. And the moment we give anti-TB drugs, it reduces recurrences. So between the description of the disease in 2005 until 2015, this is a picture taken at Dr. Gupta's retirement at his home. So we all believed that we had reached somewhere with tuberculosis, and we had described quite a few of things. And then came the Index TB guidelines by Government of India, which absolutely ignored ocular TB as a form of extrapulmonary tuberculosis. We did not even exist there, So that was the physicians all over the globe were very reluctant to start anti-TB drugs, just based on a uveitis expert telling them that this is ocular TB. So we did feel the need to have a multi-centric trial where the uveitis experts from all over the world come together to say that this is a potentially blinding disease which has a specific therapy. So this is what needs to be treatment. So I'm very honored to be associated with three of them. Kwan is from Stanford, Rupesh from Singapore, and Carlos is from Moorfields. So we started this group, Collaborative Ocular Study Group. And as you know, the collaboration, the colors form the rainbow. A single color does not. I remember sitting in one of the crucial meetings and being told that there are only 2 or 3 centers in India which believe in ocular TB, so this probably does not exist. And that is how we started Collaborative Ocular TB Study Group. Mind it, 25 centers, no money, nothing, just the goodwill and the genuine quest to start something new, and we had a very humble beginning. This is the group we started. This is San Francisco during academy pictures. So we defined the criteria. We had the online, the records where all our PIs entered their patients, no CROs, no money, nothing. I'm not going to go into the details because we even published the lessons in digital epidemiology and how to overcome the funding deficiencies, because this trial was a purely academic trial and was, of course, encrypted, web-based with all the securities. What we found was that ocular TB existed all over the world. There were global variations, there were a lot of challenges, but one thing which was common was if you diagnose and if you treat, you reduce the recurrences by 80%, and that was a significant improvement. Multiple publications came out of courts in all the journals, but these are the 4 essential lines which I would summarize. That there is no evidence of systemic TB in more than 90% of the patients. So please don't rely on the pulmonologist or internist to tell you that this is not TB, because this is just active in the eye. Posterior uveitis is the commonest phenotype, and serpiginous-like choroiditis is the commonest. Montius was positive in 87%, TB Gold in 89%. And these are the tests which are most commonly performed. PCR was not commonly performed or trusted because we don't have standardization of the PCR, and chest CT was better than X-ray, but it will not show you active disease. It's just the old primary GONS focus. We did standardize the nomenclature for ocular TB during workshop in RO, and my last leg of the talk is to establish the agreement for initiating anti-TB therapy in patients with ocular TB. And by this time, COTS was not alone. We were joined by 3 major uveitis societies in the world. I think that's all that the uveitis world has. International Uveitis Study Group, International Ocular Inflammation Society, and Faster Ocular Immunology Society. So this is the thing which we all collectively came up. So we had 486 questions which were given to the experts more than 20 years of experience in managing uveitis. Phenotype, where the patient came from, what kind of disease, what test positive. So we did have 486 questions. It was sorted out by Delphi. Delphi 1 was online. Delphi 2 was in Chandigarh, and you can see amongst others Saurabh also sitting, thinking. It was a very intense 2 days workshop, and you have virtually everybody of the uveitis world there seriously talking, discussing, and you can see the amount of the discussion which had gone on there, and the tense moments, and finally we did come up with this summary defining the guidelines for the ophthalmologists all over the world to show it to their physician friends when to treat ocular TB. So serpiginous-like choroiditis is the one phenotype which experts felt that this is very typical for TB. So if both immunology test and one radiology, that is CT or chest X-ray is positive, you would treat. If one immunology, one radiology, yes, to treat. If one immunology is positive, and they felt that the phenotype is so classic that even if you just have IGRA positive or Montius positive, you would still treat. Because if you are not treating, you are giving a lot of immunosuppression. So it's better to treat even if there is one test positive. We do have other phenotypes, which I will show you how to reach them. Both the reports are published in ophthalmology, report 1 and 2. And then we thought that this has a lot of statistics. To be very honest with you, it's a complicated statistics. And every time you have a patient sitting in front of you, you can't really recall what COTS consensus said. So to make it simpler for friends all over the world, we have this calculator, which is very simple. You enter the patient name, ID, age, gender. The moment you enter the country, it gives you the endemicity on its own based on the WHO criteria. You enter the clinical phenotype. For example, serpiginous choroiditis, endemicity comes on its own. I say TB, well, Montius is positive, gamma interferon is negative, chest X-ray is positive. You press the button, it says there is very high probability amongst the expert, more than 90% who will treat it. Of course, it gives the median score and interquartile based on the publication, but you do not need it. And finally came the moment when this national emblem had TB, ocular TB, in its standard treatment workflow for the management of intraocular TB, so that even now, if you go with this to the DOTS treatment, they will not refuse treatment to patients with ocular TB because it's not the systemic TB we are treating, it's the ocular TB. Time to thank all my collaborators from all over the world and my fellows and my faculty who are always, always there for me. And finally, my last slide for the youngsters. How do you travel the road which is less traveled? Always have your family with you, because without them it's very difficult to travel these areas that have not been traveled before. With this, I'm extremely humbled and honored to be receiving this from none other than Dr. Rao, somebody, you know, who is so iconic that the moment you see Dr. Rao's, your heart is like, oh, sir is coming. So it is a huge, huge honor. And thank you, Uttarakhand, and everyone on the dais, Dr. Arora, Saurabh, everyone, Gaurav, for giving me this opportunity to speak to all of you. Thank you.
Please give a standing ovation to Dr. Vishali Gupta for such a wonderful talk. Thank you, ma'am. We are honored with your oration.
Thank you.
Thank you.
Thank you, ma'am, and thank you, sirs, for gracing the occasion. And it was not only such a nice TB journey or your journey in ocular tuberculosis, but such lovely paintings that you shared and, you know, enmeshed with your journey in ocular tuberculosis. Thank you so much, ma'am, for this oration. Thank you. So now I think, yeah, so the formal award will be handed over in the evening during the inauguration, ma'am.
Thank you.
Thank you so much. So I think we have time for lunch till 2 o'clock, and then the next session will start in Hall A. Thank you so much.
extra beats on the track.
So very good afternoon and welcome back after the lunch, everyone. And we have now a very interesting session. It's called Under Pressure. And this, as you can understand, is our glaucoma session. And I would like to invite the chairpersons, Dr. Kirti Singh ma'am from Maulana Azad Medical College, New Delhi, Dr. Nandita Chaturvedi, Dr. Ajay Agarwal, Dr. Priyasuman Rastogi, Dr. Nutan Darda Jain, and to moderate the session, Dr. Mansi Pokhriyal and Dr. Dinesh Singh. Please come to the dais, and then we can kick off this session. This session will be followed by a very interesting session again. It's the audience quiz, where we will have voting pads for the whole audience, and there will be lots of prizes to be won. And after every few questions, the update of the number of people, who is on the hot seat is coming up. So the top 10 or so people will be getting prizes. The winner will get a separate prize. So please be here at sharp 3 o'clock. The quiz is being done by Dr. Prashant Bavankule and Dr. Renu Dasmana. So that will be another interesting one. And following that, we have yet another interesting session, which is the big standoff, where we have very interesting debates on everyday situations that we face, whether to do refractive lens exchange or ICL or LASIK or SMILE or glued IOL. So there'll be a very interesting debate on that. So with that, I'm handing over to the chairpersons of the glaucoma session.
Good afternoon. So, a very interesting name given to glaucoma, under pressure, although we all know that glaucoma is just not pressure. But, and I thank Uttara Eyecon for having us here. So, I'll introduce the chairpersons, Dr. Nandita Chaturvedi, and Dr. Dharmendra Nath, is he around? Okay, and the panelists are Dr. Ajay Agarwal and Priyasuman Rastogi and Nutan Darda Jain. Okay, great. Moderator is Mansi. You have Dr. Dinesh with you, or you are the moderator? Okay. So I think we can have the first presenter, ocular hypertension, by Dr. Nutan, please.
Hello, good afternoon everybody. So we will be starting our session after the lunch. Hope everybody had a good lunch. So coming to the under pressure team, we are having Kirti ma'am with us to guide us, and all the respected members on the dais. We will start with ocular hypertension. So coming to the definition of ocular hypertension, and intraocular pressure greater than 21 millimeter of mercury in one or both eyes as measured by applanation tonometry on 2 or more occasions. No glaucomatous defects on visual field testing. Normal appearance of the optic disc and nerve fiber layer. Open angle on gonioscopy with no history of angle closure, and absence of any ocular disease contributing to the elevated intraocular pressure. Now, as we all know that early detection of glaucoma can be done with the help of OCT, but the OCT findings are detected only after the 20% of the damage has already been done, and visual fields detect after the 40% of the damage has been done. So we can prevent this in this phase. Initial 4 important steps of ocular hypertension can help us to prevent further progression of the glaucoma to go to blindness. So we have to start early detection and early treatment. Now, why IOP cannot be ignored? Elevated IOP is major risk factor for development of glaucoma. Detecting raised IOP warrants further investigation and management decisions. So IOP is the most important factor which can be changed. So we have to reduce the IOP if required. Now, primary questions which should come in our mind when we are thinking of a patient who is having raised IOP. Whom to treat, when to treat, and how to treat. Now, further questions which needs to be answered are these individuals with false high recordings of IOP? Are they having a single high reading? Are they actually preclinical glaucoma? If so, should they be treated? Are ocular hypertensions with thinner corneas are at increased risk? So coming to ocular hypertension, we divide it into three categories. First, when IOP is less than 24, I think we need to wait for the treatment to start, so we should observe it. Now when the IOP is more than 30, there is no doubt we have to start the treatment. Now the important criteria comes for in-between patients, in which the IOP is between 24 to 29. What to do? So for patients who are having IOP between 24 to 29, we have to first observe and look for glaucomatous changes. Then if it is seen that the glaucomatous changes are seen, then we should go for treatment. Or we can go directly for treatment. There are both categories. Now why IOP cannot be ignored? This question. Elevated IOP is the major risk factor for development of glaucoma and only modifiable factor. The only factor which we can modify. So we have to think about it. Detecting raised IOP requires further investigations and management decisions. Now there are arguments against for early treatment and against the early treatment. So we will see all. Now IOP variability. Significant diurnal variation may mask true maximum IOP and delay treatment of early damage. Early damage detection up to 40% nerve fiber loss may occur before visual field changes detected, as I already told you. Treat all patients until reliable test for early damage is available. Unpredictability. Impossible to predict which patient will convert to frank POAG. Worthwhile treating 20 patients to protect one, if we think like that. Corneal variability. Corneas of different individuals may have different mechanical properties. True IOP may be significantly different in two patients with the same CCT. No test of individual corneal mechanics to estimate true IOP available. Now, some arguments against early treatment. Low risk of glaucoma in ocular hypertension. Only 1 in 10 ocular hypertension patients develop POAG in 5 years. Risk for significant visual acuity loss also relatively low. Cost. Treating 20 patients to prevent one from developing early glaucoma is not cost effective. More cost effective to observe until early changes are developed. Now arguments against early treatment. Treatment risk. Treating patients who may never develop glaucoma may result in unnecessary burden and side effects of the treatment. Treatment decisions should be individualized based on various factors, multiple factors which we have to take into consideration. Risk factors, individual patient characteristics. Now coming to risk factor, the major study which was done was ocular hypertension treatment study, which has defined various risk factors and provides a better framework for decision making. This study, which was done in 2000, estimated 2.5 million will have primary occult angle glaucoma. Fewer than 50% of this will be diagnosed. 4 to 7% of population older than 40 years had ocular hypertension. However, also known that many OST never progress. No consensus on was made whom to treat, when to treat, and how to treat. So, coming to this study. This study was a multicentric prospective randomized trial. Inclusion criteria was untreated IOP of 24 to 32 in one eye and 21 to 32 in fellow eye, normal visual fields and normal optic nerves. Primary outcome, development of POAG in one or both eyes. So 1,636 subjects were randomized in two groups, observation. First group was the observation group and second was topical treatment with aim to reduce IOP by more than 20% from baseline by any commercially available hypotensive drugs. Central corneal thickness measurement for 82% of participants was done. Examined every 6 months with 30-2 HV visual fields and disc photos. 5 years follow-up was done. And results were found that IOP reduction of 22.5% in treatment group versus 4% in observation group was seen. Probability of primary open angle glaucoma was in treatment group was 4% and observation group was 9%. So I will rush out through this because it will take time. Therefore, 50% reduction in risk of POG was there seen with the treatment. Now, this is the important point. The central corneal thickness, if it is less than 555, you had threefold greater risk of developing open angle POAG, and compared with CCT, if it is more than 588, then there is a less risk. So cup disc ratio should be evaluated. Various other risk factors should be taken into consideration: IOP, older age, family history, cup disc ratio, pattern, standard deviation, CCT, and heart disease. Now, what does ocular hypertension treatment study tells us? Reducing IOP reduces the incidence of glaucoma. Risk factors for primary open angle glaucoma include, as I already told you, and yes, ma'am. How many patients we should treat? So, will all patients convert? We have to find out the answers for this. So, coming to this risk benefit assessment, we have to take all these factors into consideration: age, IOP, CCT, pattern standard deviation, and cup disc ratio. Benefit, how much it is giving to the patients. So imaging modalities which we should use is fundus photographs, OCT, HRT, JDX. FDT techniques should be used for perimetry. Swab test should be done. Sample case, I will rush it out.
We need to wind up. We have
yes,
the first lecture, and so we have around 5-6 more.
Yes, ma'am.
So,
okay, ma'am.
Thank you very much. He's talked about the OATH study, a landmark study, which talked about the risk factors. If the other speaker can be on the target IOP, is it still relevant? We have Dr. Bhalla to tell us, and he's a very renowned glaucoma specialist from Delhi. So till he loads the slide, the OATH study gave us 2-3 features. One was the corneal thickness, and the other feature it gave us was that over 5 years, in fact, very few people did progress. So it is a tailored management for ocular hypertension. The risk factors would be, if it is above 30, the pressure, and mind you, take the pressure at different times of the day. If it is above 30, then the risk of vascular occlusion also is there. It's just not the glaucoma progression. Keeping that in mind and the comorbidities, you had these calculators which are no longer used much, but the corneal thickness did emerge as a feature, and that most of them did not progress. So thank you very much for that lecture, and we have Dr. Bhalla now to tell us about target IOP. Is it still relevant? Could I request the next speaker, Dr. Mansi, to be there once half the time is over? Thank you.
Starting second. Yeah. Thank you, Dr. Kirti, for those kind words. At the outset, I'm thankful to Uttarakhand Ophthalmic Society for giving me this opportunity. Okay. So, the title, na? Title slide. Okay. Okay. My topic for presentation is target intraocular pressure still relevant today? We are born with about 1 million ganglion cells in each eye, and we lose about 5 to 10,000 ganglion cells annually from aging alone. And it is said that if human race lived up to the age of 150 years, almost everyone of us is going to develop glaucoma. We all know this definition. Open angle glaucomas are chronic progressive optic neuropathy in which intraocular pressure is the single most modifiable treatable risk factor. What exactly is normal intraocular pressure? The so-called cutoff of IOP of 21 millimeter mercury is neither clinical or evidence-based evidence, but a statistical construct. I'll tell you, Hollows and Graham survey in UK, they found mean applanation of intraocular pressure in males was 15.9 and in females was 16.6. Two standard deviation above this mean was calculated to be 21 millimeter mercury, and hence normally held belief that any intraocular pressure more than 21 millimeter mercury should be considered as abnormal, and less than 21 millimeter mercury is considered as normal. So what is the definition of target intraocular pressure? Various definitions have been given by the various societies. European Glaucoma Society said it's an estimate of the mean intraocular pressure obtained with treatment that prevents further progression. American Academy labeled it as a range of intraocular pressure, again adequate to stop progressive pressure-induced injury. World Glaucoma Association said it is an estimate of mean intraocular pressure at which risk of decreased visual-related quality of life due to glaucoma exceeds the risk of the treatment. So target intraocular pressure is not an estimate, is a guesstimate range of intraocular pressure that is expected to at least slow the progression of the disease, if not completely halt it. So when chalking out the target intraocular pressure, certain parameters need to be considered and every patient has to be individualized. So what are the baseline investigation we need to do? Thorough clinical examination, slit lamp based optic nerve head evaluation, baseline intraocular pressure, and 3 consecutive intraocular pressure, follow-up intraocular pressure, perimetry, reliable baseline perimetry, central corneal thickness, presence or absence of comorbidities like pseudoexfoliation. Why is age important? Because with increasing age, we find that glaucoma risk increases. And why this increases? One reason I pointed to was the age-related degeneration of the retinal nerve fibers, and also ocular perfusion pressure decreases. Optic nerve head examination is important. If we find that there is cupping at the both ends of the disc, intraocular pressure was, and the intraocular, even with intraocular pressure 15 millimeter of the mercury, then target intraocular pressure has to be kept much lower, because normal disc can withstand pressure less than 28 millimeter mercuries for years. If everything is normal, there are no risk factors, no family history. So CD ratio becomes an important criteria to estimate target intraocular pressure, and it has been classified as mild, moderate, severe. Depending on that, we can keep our target intraocular pressure. Perimetering staging again gives us whether it is an early defect, moderate defect, or severe defect, depending on the mean deviation, pattern standard deviation, and whether points in the central 5 degree are involved. Accordingly, we can fix our target intraocular pressure. EMGT found that a greater mean deviation loss at baseline was a risk factor for glaucoma progression. And SIDS test reported that 1 unit increase in their baseline visual field score was associated with 0.74 unit progression. So why target intraocular pressure? Once we have ascertained the degree of the visual field damage, baseline intraocular pressure and the risk factors, then we have to fix up a target intraocular pressure that is going to prevent further damage, that means progression. So what are the methods? One is threshold or absolute cutoff value, then second is percentage reduction or formula-based values. Absolute or threshold target range is easiest for clinicians and is the most commonly used method. The percentage reduction and threshold are popular methods used in many RCTs. Calculated target intraocular pressure requires considerable effort and is not very attractive as a clinical tool. So threshold intraocular pressure, here the target IOP used in this strategy is a fixed level of 12 millimeter mercury based on advanced glaucoma intervention study findings, where it was believed that any pressure less than 12 did not prevented further progression. But not all non-progressive patients had intraocular pressure of 12 millimeter mercury or less. Then threshold or absolute cutoff value, it can be applied to larger population, and in ages, maintaining a target IOP of less than 18 millimeter mercury in moderate and with mean deviation of -10 decibel showed no progression over 8 years of trial. So in general, mild, moderate, severe stage of the glaucoma, initial target for absolute cutoff, IOP cutoff should be kept as IOP equal to less than equal to 18 millimeter mercury in the mild, then 15 in the moderate, and 12 millimeter mercury in the severe. Then several notable trials have used percentage reduction, like OHTS have used 20% reduction, EMGT used IOP lowering by 25%, and SIDS found that mean IOP reduction by 38% and 46% in medical or surgically treated eyes, 15% progress and 15% improved. There are formulas also, mathematical formulas for setting target intraocular pressure like this, but they are not mostly used by clinicians. So let us have some clinical guidelines for setting target intraocular pressure. If you have OHT or PSC with OHT, then the decision to start medical therapy rests on the presence of risk factors like family history, baseline CD ratio, baseline IOP more than 26, low CCT and older age. Target of less than 18 millimeter could be set for these patients of OHT or without any risk factor or family history. So there are medico-legal considerations also. Given professional glaucoma societies from around the world now recommend the use of target intraocular pressure, failure to do so may confer medico-legal liability in the event of glaucoma-related claim. Although these claims are few, but we have to keep in mind that it is better to keep mentioned target intraocular pressure on the prescription of the patient. But there are also arguments against target intraocular pressure. Like Aegis said, target IOP less than 18 millimeter mercury concept, it is a wrong interpretation. And there is no Oxford level 1 or high quality evidence in support of target intraocular pressure. And I won't go into the details why this 18 millimeter mercury figure was kept in Aegis. So let us have benefit versus risk ratio of keeping this concept of target intraocular pressure. Because concept is okay if the side effects, cost, adverse consequences associated with the treatment to reach target intraocular pressure are very mild and insignificant. But ignoring other aspects than just only intraocular pressure, including the stage of the disease, lifespan of the patient, is just like an economist focusing slowly on the supply while ignoring demand and state of the economy. And target intraocular pressure can become an, I'll just take a minute more, can become an albatross for the practitioner who adheres to it when the common sense dictates otherwise. So these are limitations of target intraocular pressure, lack of validation. We still do not know which method is the best. It is a guess, IOP fluctuation, transcameral pressure, ocular perfusion pressure. So, and another thing is the intraocular pressure is not a fixed static concept. It is a dynamic concept because of the fluctuation, and we have to vary the target intraocular pressure depending on the progression and stage of the disease, and we cannot just go with the fixed target intraocular pressure. So this is the consensus statement. It promotes, WGA promotes the use of target intraocular pressure determination in the management of glaucoma, but also acknowledges its limitation. And at present, the target intraocular pressure is estimated and cannot be determined with any certainty in a particular pressure, and there is no validated algorithm for the determination of target intraocular pressure.
Dr.
Yeah.
You have to wind
So
up. We
this is
already
the last slide.
half
Yeah.
an hour is there.
Yeah,
left.
this is the last slide. So in ocular hypertension, less than 18, mild damage 15 to 17, moderate 12 to 15, advanced 10 to 12, and in normal tension glaucoma, 30% reduction from the baseline. So at the end, I'll just say that IOP is still the sole modifiable risk factor, and its adequate control can prevent irreversible blindness. And these factors are difficult to apply in childhood glaucoma, which is a totally different entity. I also take this opportunity to invite all of you to the annual DOS conference, which is going to be held from 9th to 11th February 2024. And I, on behalf of DOS and also my senior DOS member, Dr. Kirti Singh, who is also on the dais, would extend invitation to all of you. Please come and attend this annual DOS conference. Thank you, everyone.
Thank you.
Thank you, sir. Ma'am, can I slip in a quick question, ma'am? Yeah. Okay.
Yeah, I would like to invite Dr. Mansi Pokhriyal for her talk on goniotomy being a game changer in glaucoma management. Dr. Mansi is a glaucoma specialist at Vivekanand Netralaya at Ramakrishna Mission in Dehradun.
The question? One question.
Is it better to write the target intraocular pressure on the OPD slip of the patient or on your glaucoma clinic records? Because sometimes the patient becomes very, every time he comes, you tell him your target pressure is say 16.
No, from our point of view, never on the patient's records, because then the patient runs after the target pressure, and you know, if your optom is measuring the pressures, he will also modify it and you will modify it. Keep a range, keep the range in mind when you have the file of the patient and try to fit in, but as Dr. Bhalla rightly said, it's a dynamic thing. You know, running after target pressure is absolutely not done. Try to keep it there. So, but we'll have to now take because we have already half an hour down the line and we have 3 more lectures. So, Dr. Mansi, please.
Good afternoon. Good afternoon, everyone. Today my topic is goniotomy, a game changer in glaucoma management. De Vincentis introduced the incision of iridic angle, and it was Otto Barkan who performed first goniotomy in chronic glaucoma. Long considered a leading surgical option for pediatric glaucoma, goniotomy has re-emerged as a treatment for adult glaucoma driven by advances in MIGS. The juxtacanalicular trabecular meshwork has traditionally been identified as a site of greatest resistance to aqueous outflow. resistance is overcome either by bypassing or removing this tissue. Goniotomy or trabeculotomy involves surgical incision or excision of the tissue. So, trabectome, GAT, KDB, and bang are the methods of goniotomy. Trabectome, however, is an electrosurgical procedure, ablates the TM, may have residual leaflets, and it causes thermal injury to nearby tissues, though it is an expensive equipment. GAT, gonioscopy-assisted transluminal trabeculotomy. It uses a 50 Prolene suture, which is inserted into the Schlemm's canal, and 360-degree TM excision is done. It is a cost-effective method. However, removing all of the TM is not needed, though 180-degree GAT is good, but it is technically challenging. KDB, or Cahook dual blade, it has a sharp tip. It penetrates into the TM. The ramp lifts and stretches the TM. As you settle the foot plate on the anterior wall of the Schlemm's canal and move it forward, the dual blades of the KDB create parallel incision in the trabecular meshwork. As we move forward, a strip of the TM is removed, as you can see in this video, and the Schlemm's canal is easily visible. Bang or bent ab interno needle goniotomy. This is what I'm doing in my clinical settings as being a cost-effective alternative to many TM-based glaucoma procedure. It utilizes a standard hypodermic needle modified by the surgeon in the fashion of a reverse cystitome. Indications of bang: mild to moderate open-angle glaucoma, intolerant or non-compliant to AGM, uncontrolled IOP on AGMs, angle closure where angles open up after cataract surgery, or angles with minimum pass which can be removed manually. Contraindications: chronic angle closure glaucoma, neovascular glaucoma, corneal opacity, medical inability to hold blood thinners, and where patient's head cannot be tilted in conditions like torticollis, cervical spondylosis, atlantoaxial osteoarthritis. So this video here shows how to make a bang needle. A 25 gauge hypodermic needle is taken with the bevel side facing the surgeon, and a needle holder is used to bend it at 90 degrees. Microscope has to be adjusted. Here my assistant is helping me to tilt the microscope 35 degrees towards the surgeon. The mark on the microscopes helps us to tilt the microscope accurately at 35 degrees always. Patient has to be positioned. This video here showing me, I am turning the head of the patient 35 degrees almost away from surgeon's side. This helps me in having an en-face view of the angle structures. As I put my surgical gonio lens, a Swan-Jacobs gonio lens using viscoelastic on the cornea, we can have a good view of the angle. Once I have visualized the angles, I introduce my bang needle into the anterior chamber and penetrate the TM, moving the bang needle circumferentially and slicing or excising the trabecular meshwork. The inside-out technique is being used by me. As you can see, I've turned the needle to the other side and I'm cutting the other half of the trabecular meshwork. Almost 3 to 4 clock hours of the TM is removed. As you can see, the Schlemm's anterior wall of the Schlemm's canal is visible, and the gush of blood, reflux of blood, is a good sign indicating that the distal collector channels are patent. Phacoemulsification is completed routinely. While closing the eye, we have to make sure that the IOP in the eye is around 30 to 35 millimeters of mercury. And as we hydrate the side pores, you can see the nasal blanching of the vessels. This is a good sign, again indicating that aqueous veins and the distal collector channels are patent. Sometimes, not always, we get a TM strip. Whenever we get a TM strip, I make sure to remove it using a microforceps. In this video, you can see me removing the TM membrane using my microforceps. So post-op medications: high-dose steroids, prednisolone eye drops for 6 weeks, tapered weekly. Pilocarpine 2% 4 times a day for 2 weeks, and then 2 times for the next 2 weeks. Stop all anti-glaucoma medication, and I only restart it if the IOP increases above the goal. Post-op expectations: microhyphema is the most common goniotomy complication. Patients may have blurry vision after post-op for 1 week. Post-op IOP spike is noted. Long-term cases, fibrosis and scar formation have reported, and Descemet's membrane, CME, epiretinal membrane, damage to the lens capsule, aqueous misdirection have not been reported by us so far. This is a photo showing microhyphema. And one of my patients reported here with fibrin, which improved after 1 week of high-dose steroid frequent administration of topical steroid. So pros of bank, it circumvents the issue of underleak, overfiltration, leak and infection, serious complication of the invasive procedures, shorter operating time, rapid recovery, and there is a conjunctival sparing procedure. Cons, skill of intraoperative gonioscopy with a direct gonioscopy needs to be acquired. Patient as well as microscope positioning every time we operate is challenging in a heavy OT. Patients with distal scarring and outflow malfunction may behave with limited success. So we have an ongoing study conducting at our hospital. Till date, I have done 22 eyes of 20 patients with a baseline IOP of 32, which has come down to average IOP at 1 month to 12.9 mmHg and at 3 months to 15.2 mmHg. Almost 75% of my patients are free of medication. As we compare all the goniotomies, most cost effective is GAT and BANG, but excising 360 degree of TM, however, I find it very invasive, and 180 degree is comparable to BANG, but it is technically difficult. And so conclusion is, BANG is not only cost-effective procedure, but also safer procedure to do. Long-term follow-up studies are required. In future, a preoperative diagnostic modality is required to predict whether the distal outflow is working. In Himalayan settings, where patient follow-ups are difficult, safer surgery options helps the surgeon to sleep peacefully, definitely. Thank you.
Thank you for covering in time and a beautiful video, great presentation. And we have a little short follow-up right now, but we are also doing a lot of bang in our setup. So we have next Dr. Priya Rastogi talking about medical management of open angle glaucoma, tips and tricks. He is working in Dehradun, in Rudrapur, I'm sorry, my bad. He's working in Rudrapur. Over to you, Dr. Rastogi.
At the outset, I would like to thank Uttarakhand and Uttarakhand Ophthalmic Society for having me here. So I'll be speaking about the medical management of primary open-angle glaucoma, and it's much talked about topic. But as we go sit into our clinical practice, we miss few tips and tricks while as the time goes on. So it's a theoretical topic, but I've tried my best to make it as interesting as possible. So basically, we've got 6 group of drugs. We all know about these drugs. I'm not going to be in the details of these drugs with varying efficacy between 25 to 30% and maximum effect with, at about 2 to 4 weeks. So my talk will be covering following topics. And when we get a patient of a suspected glaucoma, the first thing that should come to our mind is that is the glaucomatous process present? So what we need to do is we should confirm the diagnosis first. And is the glaucomatous process active? Example, steroid responders, that's a one-time increase in IOP. And is the glaucomatous process likely to cause disability? Because in many cases, patients like comatose patients, patient with disability, patient with no PL patients, do they require a glaucoma management or not? These points are to be considered before starting the therapy. Then history taking before initiating the therapy, I think it's one of the most important points what I consider in my practice. And the important thing is socioeconomic status of the patient and geographic location of the patient. Majority of patients, what we see in our practice, they are old age patients and they depend on their relatives or somebody to bring the medicines to them, whether the medicine is available at their site, whether they can afford the medicine. And if we don't consider these points, it results in a dropout. So again, it's a trouble. And history of previous ocular medication, history of systemic medications like antihypertensive medications, anticholinergics, anticonvulsants, MAO inhibitors, etc. All these can interfere with our management. Then history of chronic disease like beta blockers start to be avoided in cardiovascular diseases, bronchial asthma, diabetes, etc. And carbonic anhydrase inhibitors start to be avoided in sulfa allergies, renal impairments, etc. And history of CVA that can cause visual field defects itself and can interfere in a diagnosis. Then history of migraine, history of yoga like Shirshasana, all these things are to be taken care of before starting the medication. Now, what should be the purpose of starting a therapy? Is to achieve target IOP and reduce fluctuations, administer medication with least side effects to minimize progression of glaucomatous optic neuropathy, to achieve maximum treatment at affordable and sustainable cost to the patient, to monitor structure and function of optic nerve, and to treat non-IOP dependent systemic factors like systemic hypertension, low diastolic perfusion pressure, etc., and to educate and involve patients and family members in the management of the disease process and treatment. When to start the medication? First is patient with reproducible glaucomatous visual field loss, patient with progressive changes on RNFL, on OCT, and or ONH in the absence of visual field changes, as these are the predictive of future functional losses, and glaucoma suspects or ocular hypertensives who are at high risk of developing functional impairment, or who, if you think that you can lose these patients on follow-ups. So target IOP I'm not going to discuss because Dr. Bala has nicely taken that in detail. So So how to start the therapy? The drug what we choose should be efficacious. Patient should be compliant to the drug. It should be safe. The drug should be persistent in managing the pressure, and it should be affordable to the patient. If the drug is cost effective with minimum dosage, then compliance of the drug improves. Then how to start the therapy? I normally start with single drug, preferably as a beta blocker. If it is mild grade glaucoma or moderate to severe, I start with prostaglandin analogs with at least 20% IOP lowering capacity. Treat verse eyes aggressively. Phasing or diurnal variation, if it's possible in your clinic, is advisable. It gives idea about the IOP spikes and its timing, IOP fluctuations, and peak IOP and correct evaluation of the drop in IOP following treatment. And patient to be assessed every 3 to 4 weeks for result, as peak reduction starts basically after minimum 3 weeks of initiating the therapy. And of course, you have to monitor the side effects of the medicines. When to shift to other drug or combination therapy? This is one of the most important points what beginners face when they start the glaucoma medication. If the drug achieves the target IOP, it is continued. If the drug does not achieve the target IOP or patient experiences side effects, shift to other group of drug. If the first drug reduces IOP to more than 20%, but still target IOP is not achieved, second drug of different group are to be added, but 2 drugs should have different mechanism of action. And maximum of 3 anti-glaucoma medication can be given at a time. Follow-up, a newly diagnosed case can be followed every 3 months to monitor progression and side effects, at least for a year or till disease becomes stable. Old diagnosed cases can be followed every 6 months to 1 year, depending upon the severity of optic nerve head changes. And I can see a few of PGs sitting here. So common mistakes, what our PGs and what beginners do is not assessing the socioeconomic status of the patient, not assessing the demographic status of the patient, not assessing quality of life due to side effects, starting anti-glaucoma medication without proper assessment tools and diagnosis, aggressive treatment and combination therapy using more than 3 drugs. This is the most common mistake what we experience in our practice and follow-ups, that patients are, we have seen patients on 4 drugs, 5 drugs also, and faulty monitoring and follow-up. So a few practical tips about anti-glaucoma medication is, in normal tension glaucoma, prostaglandin analogs are preferred to start with over beta blockers, as later when absorbed systemically can lead to decreased optic nerve head perfusion pressure. Prostaglandin analogs, preservative-free version preferred as once a day dose, known to lower IOP during the night as well as compared to beta blockers, which work only during the day. Prostaglandin analogs to be avoided in framed eye, we all know it, and beta blockers to be avoided in COPD, asthma, sinus bradycardia, heart block. This is a common notion. Alpha agonist is generally added as second-line drug, but has good role in normal tension glaucoma as first-line drug also, due to neuroprotective and non-IOP dependent effect, but has high rate of ocular allergies. Brimonidine to be avoided in children below 6 years of age due to risk of CNS depression, and carboic kinase inhibitors to be avoided in patients with sulfur drug allergy, we all know it, and long-term use can cause endothelial damage. Now, decision-making for the surgery. This is another important thing. I consider 3 points in my in seizing the medical management, like patient on 3 medication and target pressure still not achieved, progressive field loss even after maximum medication, and field effect very near to the fixation point. If I see a patient with any of the 3 points, I shift the patient to surgery. And so take-home message is proper history and assessment before starting the medication. Choose patient wisely before starting medication, whom to treat and whom not to treat. Decide target IOP as per protocol. Choose your drug as per target IOP and patient's profile. Timely shift the patient to other drug or combination therapy. Never overtreat the patient, and regular follow-up with proper investigations. Thank you.
Thank you, Dr. Priya Suman. Now, I would like to invite, and I feel quite privileged here, to invite Professor Kirti Singh, Director and Head of Glaucoma Services, GNAC, MAMC. Ma'am is very famous among her students, and we are really fortunate to have her to give her keynote address. Ma'am.
Thank you. Thank you for that kind words, and thank you Uttarakhand Society for having me here. So the topic of my presentation is gaps. So we know all these ignominious statistics of glaucoma, that India is home to over 20% of the world's blind population, but we also do know that 70% of the blindness is preventable. And how much of the 6% blindness of glaucoma is preventable? One is the secondary glaucomas, and one definitely is angle closure. Whatever strategies we have for glaucoma management would fall short of the target if we don't anticipate the obstructions, because the smallest obstruction can cause the fall. So what are the gaps in this getting to the desired state of glaucoma practice? We analyze, and the 2 stakeholders always in any disease are the patient and the doctor. So we analyzed both of them. I have no financial interest to declare. So we had a data analysis of 1,700 plus patients, mostly above 55 years, of mixed ethnicity, where primary glaucoma was foremost. And we found that almost open angle glaucoma and angle closure glaucoma were almost similar in our hospital statistics. And almost 1/4 of the patients who were referred to us, a tertiary level hospital in North India, required either filtration surgery or lasers. 14% were blind in one eye, and the blindness was PL negative. And of all these blind patients, angle closure glaucoma was the villain. It caused 46% of the blindness. And out of this angle closure glaucoma, which is responsible for 46% of the blindness, 80% were undiagnosed. And most of the gonioscopies and therefore the PIs were done in our hospitals. In open angle glaucoma, only 1/3 were on anti-glaucoma medications. So you can see the top of the iceberg, the phenomena that many of them are undiagnosed and they come to us with blindness. And the key factor which emerged was lack of gonioscopy. The other data was the analysis of the clinical cases referred to us in last 21 to 22 and the knowledge and health-seeking behavior. The referral practices were analyzed. Again, the glaucoma subtypes were open angle and angle closure were virtually similar. This was in 500 patients. Legal blindness was seen in 37%. Angle closure again comprised 46%. Out of these patients, 85% were residents of Delhi. Even in Delhi, they had traveled more than 30 kilometers, 10 to 30 kilometers just for a drug refill. That was the economics of our population. And delay in seeking treatment of more than 6% was seen in 40%, and 1 to 6 months in almost half the patients. Ignorance, no access to nearby health facilities, lack of caregiver were the commonest reasons for not coming in time. And you just talked about the Himalayan areas. This is Delhi, capital of India, and here also they had similar problems. And this was a patient who had brought his mother-in-law, and he says, "Isko lens dal ke theek kar do," because she has blindness, and it wasn't lens, it was glaucoma. So the glaucoma awareness was very poor, 9%. Knowledge was even less. 95% did not understand the cause of the disease. So whatever glaucoma walks and talks you are having, they're not percolating down to the patient level. Only 8% understood that this is irreversible. 5% still felt that just put the IOL, I'll become okay. Like this patient who came to us, that just one eye is sufficient for me, इसी को ठीक कर दो, मेरा चश्मा भी एक ही आँख का ही है, टूटा हुआ है, लगाने की ज़रूरत नहीं पड़ी. So obviously this is one type of population, but you are in India and you're seeing a lot of these populations. Now prior diagnosis was there only in 20% despite qualified ophthalmologist being the referring physician. So people had just done a cataract surgery without even having a look at the angle, not even having a look at the disc damage because these patients came on the blindness. Okay, criteria of glaucoma referral was high IOP dissuspect, gonioscopy suspect, referral was abysmally low at 5%. Gonioscopy had neither been performed nor documented in 80% of the hospitals, and this is, mind you, by a primary care ophthalmologist. It is not anybody, an RMP or anybody, it's a qualified ophthalmologist. And this gonioscopy not being performed has been quoted in the Chennai glaucoma study, in the Venkatraman study by Coimbatore, and recently by the Karnataka study of the glaucoma awareness being very poor in central India. In fact, even in Canada, lack of gonioscopy and angle statement information has been documented. This is the last study, a CAP study in 200 diagnosed adult patients. Again, 20% had one eye glaucoma blindness. Dependency in hospital supply was found in 60%. Forgetfulness, fatigue were the commonest cause of poor adherence. Side effects were not the commonest cause, and white coat adherence was seen in almost 1/4 of the patients, where the patients started putting the eye drops just before the visit to the doctor. 65% were unaware that this is going to be asymptomatic for lifelong. 50% understood the gravity of missing medications, and 53% had a false belief that putting the medications regularly would restore my eyesight. More than 50% had unsatisfactory drug installation practices. So we found that the provider you are sitting there, and all the people on the dais and off the dais, please do open the bottle of glaucoma drug or any drop and show the patient how to put, and watch the patients putting it, because this is a big issue which we found. And this GAP study way back in 2007 from Baltimore also said that the adherence was a problem. So in the gap analysis, what we really found was that it's an irreversible disease. There's no perceived benefit. So unlike the medications which patients take daily for hypertension or diabetes, this has no perceived benefit. They have to tell them that. कि इस दवाई डालने के बाद कोई फ़ायदा नहीं होगा, आपकी नज़र बढ़ेगी नहीं, but जो नज़र रुकी हुई है वो बच जाएगी. So that is a major benefit. You have to tell them. It is asymptomatic, so lack of knowledge has to be addressed. Lifelong medication has to be put, that has to be told. Hand-eye coordination is a problem. It's a disease of the elderly. So look at the patient putting the drops. Sorry. Please exercise the surgical option early. And since many patients depend on free medications, do a counseling. And we at a center do this gap workshop of gonioscopy and do a trabeculectomy in time. So anybody of you wants to read how trabeculectomy is done, you can go to the CME. Yeah, please. Just started. Any questions? So sweet of you.
Any questions? Ma'am, you take, please. Any questions from the audience? Or we can discuss if anybody wants any topic till ma'am recovers from her bout of...
I thought I had one question for Balla sir. Sir, usually there are asymmetric presentations of glaucoma. So when you are setting target intraocular pressure, do you set differently for different eyes, or is it the same for both eyes?
Yes, I agree that it's an asymmetric disease. So depending on the stage of disease in each eye, the target intraocular pressure ideally has to be kept separate. It is sometimes it becomes very difficult to explain to the patient how many times, how many drops to put in each eye. And if the difference is not much, then we go according to the target pressure of the worse eye. So that patient does not. It also depends on the status, understanding of the patient. But if it is a significant difference, like it's a severe disease in one eye and mild disease in one eye, then target IOP has to be kept separate. Otherwise, there will be over treatment in the other eye, and that will be lead to other problems.
Thank you, sir.
So, little bit, sorry. So the next lecture is filter for posterity. Can I have my slides? बेटा आपने टाइमर शुरू कर दिया, स्लाइड्स नहीं शुरू करी. You have to go back to the timer now. Anyway, so when Dr. Saurabh called me, he says, "This is your topic, ma'am, filter for posterity." I said, "Wow, great." Hello. Slides are not, yeah. That's a myth. There is nothing lasts forever, and obviously glaucoma filter does not last forever. The road to glaucoma surgery is full of twists and turns, just like the road to James Corbett Park is, and failure is very often. So all glaucoma surgeons are pessimists. They understand and plan for failure. Why? Because we do know that success in glaucoma surgery depends on two principles. One, we wish that the scleral flap heals incompletely, permitting aqueous outflow, whereas we wish that the conjunctival flap heals completely without any give. Now both are tissues and both follow the same principles. So our wishes are different. Therefore, what are the surgical tips? One, to avoid operate on an angry glaucoma. Reduce the intraocular pressure. If it's very high, which we see very often in our hospital, we do a paracentesis 30 minutes prior to trabeculectomy in the OT, do 2 other cataract surgeries, and then come back and do a trab surgery. We have also done a diode laser cyclophotocoagulation to reduce the pressure. Why do we need to do that? Because the risk of suprachoroidal hemorrhage, hypotony, aqueous misdirection, and ocular decompression is higher if you operate on an angry eye. Second tip is how do you handle your conjunctiva? You have the well-known limbal-based and phonics-based flaps. What we have devised in our center is the conjunctival frill flap. It reduces the surgically induced astigmatism, reduces the limbus distortion, enhanced patient comfort and watertight closure with no overhanging bleb, and it's pretty easy to learn. So these are some videos I'm going to show you of the surgical techniques. This is the conjunctival frill suturing we do. We have a frill at 1.5 millimeters from the conjunctiva, from the limbus, and you make the incision like a smile incision for a SICS. And at the end of surgery, with the ATO nylon round body needle, you do the continuous suturing, and this actually, it becomes like a smile at the end. So tighten the sutures and take up the slack, and this is the suture, and this is the conjunctival frill suture removal on the slit lamp when the conjunctiva heals. It is pretty easy. After doing this technique, we have found that the astig and the patient discomfort, this watering problem which they had with the sutures, is much less. In the conjunctival suturing extremes, before we had the smile, we had these loose bleb leaks or the tight suturing, which causes the astigmatism. To avoid these, you'd always do a bleb titration. What is bleb titration? There are two steps to it. One, at the end of the conjunctival suturing, from the side port, you enter and you form the anterior chamber and you watch for any overflow from the suture ends. So this is ensuring the watertight closure. And this bleb titration helps you sleep peacefully and also prevents any shallow AC. Second is the conjunctival handling. In the story of the princess and the pea, who is the princess in trabeclectomy? It is the conjunctiva. So conjunctival handling has to be very nice. So buttonholing has to be avoided. We use mitomycin C very frequently. The handling should be gentle, and the safe mitomycin technique is when you cut the Miracil sponges and push it in the areas behind and at the end remove it and wash it with copious flow. So buttonholing has to be avoided. Why? To prevent bleb leak and later on bleb failure, because a leaky bleb will fail. The third problem is that we wish for conjunctival healing sans scarring, as I said at the beginning, and that is the Achilles heel of any trabeclectomy. How to overcome it? You use antifibrotics, but we do know that the problems with antifibrotics are multiple: avascular bleb, blebitis, overhanging plebs. The safer alternative we devised in our hospital is the use of amniotic membrane, the versatile amniotic membrane. We sometimes combine with mitomycin C and sometimes we just leave it like that. And this might be found in this patient, in fact, was a case control study. One eye he had a mitomycin C and one eye he had an amniotic membrane trab. And over a 10-year follow-up now, the IOP is controlled, but the one eye with the mitomycin C has an avascular bleb and cataract, whereas the other eye has minimal cataract and a very nice bleb. Third thing is you avoid extremes in the immediate post-op period of low IOP and shallow AC and the sequel, or high IOP and with the deep AC and the sequel. And the way to do it is by using releasable sutures. We do releasable sutures in all our cases. The releasable sutures can be 2 to 1. This technique we are using the Cohen-Osher modification. So the suture is taken out from the corneal side. This is almost an unedited video, and then the needle is turned and taken out from the scleral flap, and this loop is made in the superficial scleral flap and taken out from the other side of the triangle. You can have a rectangular flap, triangular, trapezoid, whichever is convenient to you. Normally we have a triangular, and now this you have these 4 throws tied, and this is one suture in position. And this is the titration. I do it after every suturing to see how much is the fluid flow. So fluid flow will tell me surrogate what will be the aqueous outflow later on. So here the fluid flow was much more, so I needed to do one more suture. Now here I've put 2 sutures, and now again I'm doing titration. So after this titration, I'm finding that the flow is adequate. It is just coming. And now this is the way we put the amniotic membrane at the end of releasable sutures. We place it with the sticky side down, and then the suturing is done as regularly. So titration at 2 points at the end of flap suturing and at the end of releasable suturing. How do you remove these releasables? Again, very simple, on the slit lamp. So this is one releasable which has been removed on the slit lamp very simply with the 26 gauge needle. The frill suture is still in position, we'll remove it later on. You do it within 2 weeks or when the IOP starts increasing. The last one is the side port creation. This is a very important step. Always do a side port, do a slow decompression. This permits a slow decompression prior to anterior chamber entry. At that point, form the anterior chamber with a small amount of viscoelastic. Titration can be done from this, and start putting atropine drops if you find a shallow AC during suturing. Recognize a failing bleb early. Teach the patient or the caregiver how to do a bleb massage. It's a very simple and a very important technique. You can do bleb massage at any time of the filter, even at 2 years, 3 years. Obviously, the earlier you do it, it's better. And after bleb massage, you'll find that the filter is forming well. That means the aqueous is going. Releasables, I've told you how to remove. And remember the snakes and ladders game which we used to play? Trabeclectomy is like that. It can trip you up anytime. Can I take 2 minutes more? It can, if not, I'll stop. 2 minutes, it can trip you up, that the snake comes at 99 and trips you up, so does this. And whenever you have signs of failing bleb, like walling off, vascularization, tenon cyst, increasing corkscrewing, straightening of the bleb vessels, and the movement of the conjunctiva is less, or reduction in bleb height, at these warning signs, start intervening. Don't wait for the intraocular pressure to be increased. At that point, do a CPR of the failing bleb. How do you do a CPR? You do with the external bleb needling augmented with mitomycin C or 5-FU. We prefer mitomycin C. And in our center, we have devised this technique. In this, the filter was blocked with the iris tissue. So we've done an ab interno bleb revision with a straight rod under viscoelastic cover. I've removed the iris from the blocked sclerostomy, and then I've coupled it with the external needling. So this works really very well. And the last one is in advanced glaucomas, you have to do surgery, do pre-placed sutures, side port creation is a must. Count till 10 when you do a slow decompression from the side port. Always do a bleb titration. And very often we find patients who are on 3 or 4 AGMs when they come to us for TRAB. These patients have a subclinical fibrosis, which we found in a recent study. And both the lymphocytes and the macrophages are increased, the fibroblasts are active, and the goblet cells are less. So the healing of the sick conjunctiva is poor. So wherever possible, withdraw the PG analogs and in fact substitute for Diamox for 2 weeks. Start low dose topical steroids to decrease the subconj inflammation when you are planning for a trabeclectomy. Do it for 7 days or so, keeping in mind that some patients may have an IOP response. And in angle closure glaucoma situations, and shown very beautifully, you can go ahead with a bang surgery, which for our patients is cost effective. So surgical tips to conclude: avoid extremes of high IOP and low IOP by releasable sutures. Do the frill conjunctival flap, which in our hands works really well. Do the titration for both scleral and conjunctival bleb. Prevent buttonholing, use a safe technique of mitomycin C. Amniotic membrane is a cost-effective and a safer alternative. You can divide it into 4-5 pieces and use it for 5 patients. Creation of a side port is extremely important. Never forget a bleb massage and needling, and try to start steroids for reducing subclinical inflammation if the patient is on more drugs. Thank you very much for a very patient hearing.
Thank you, ma'am. Those surgical tips will definitely help us in improving our trabecular surgery's outcome. Thank you, ma'am.
So any questions? Yeah, I can take any questions now.
I have one, ma'am.
Can I have the last slide? Sorry. Yeah, just put the last slide. So I just put this. I didn't not have had time for this. Yeah, please ask your question. I hate posterity. It's so fond of having the last word. So so the question, the topic given to me was filter for posterity. So don't aim for posterity. Revive the plebs in time. And this is one of my favorite slides. You people are in the Himalayas. You know the value of ecology. We are in the cities. We're living in pollution. Let's save Earth while we still have time. Let's reduce plastic. We are all still using these plastic bottles. They've become our comfort. We should stop using them. Request to all the organizers, let's stop this. Let's revive our Earth while we still have time. Thank you. May I have a question?
Yeah. Ma'am, the amniotic graft that you are placing under the conjunctiva, you are suturing that?
No, I don't have to suture because your scleral flap is sutured. So we cut it at around 6 to 8 centimeters long, and we just cover till the we have done the dissection for mitomycin C. So around that we just put it sticky side down, and you cover the conjunctiva. Nothing happens. It doesn't move from there. It's a small one. Unlike for corneal situations where you need episcleral sutures, here you don't need because the conjunctiva is covering it.
Okay, thank you, ma'am.
Actually, we get amniotic membranes almost always in our OT. So for older patients, more than 45, 50, we only use amniotic membrane. For younger patients, we use mitomycin C and amniotic membrane. Even for congenital glaucoma, we use amniotic membrane and mitomycin C.
Thank you. And yeah, we have covered.
So I thank all the moderators. I think have to have a picture, right? Is that so all the chairpersons and the moderators, please come, and the speakers on the dais.
Down, sir. आ गया इसका साउंड ऑलरेडी ऑन है
So guys, we are going to about initiate the brain teaser quiz for all of you. It's not only necessarily for postgraduates, but for each one of us. Yeah. So just hold on till we have a setting done. Yeah. थोड़ा सा ये करो बेटा, ऑन कीजिए. Yeah. So I think we are starting. Done. चलो.
आप उधर से
अभी रहने दीजिए आपके पास.
इसी को यूज करना
Should we, madam? What do you say?
Good afternoon, everyone. So is everybody here? Wave your hand if you're here. Wave, 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 wave. This is the way we would say. Raise your hand. Post lunch ऊपर से खुल जाएगा. आप खड़े करो नीचे.
How is the Josh, yaar?
Come on, yaar.
ये यार हाई नहीं. How is the Josh? That's it.
Josh depends upon the prize you are giving, around the prize is.
Yeah, we will be coming to it. It's all sponsored by Himalayan Institute of Medical Sciences, so don't worry. So you have to expect it to be of that proportionately.
सर रजिस्ट्री के टुकड़े भिजवा दूंगी, ऐसी क्या बात है?
So friends, here we are back for today's quiz. Brain Teaser is a platform which has been conducting online quiz for last 4 to 5 years. We had the privilege of being associated with various state societies, various national societies, various specialty societies like Retina Society, Ocular Trauma Society, Uveitis Society of India, Cornea Society. And this is for the first time that Brain Teaser is doing it in association with Uttarakhand State Ophthalmological Society. And I really thank the Chairman Scientific Saurabh Luthra for this opportunity and Dr. Renu for inviting us for this particular proposition. So friends, here is our signature tune for you, the Brain Teasers, which you might have been hearing for last 4 to 5 years. It's just not going to be quiz, it's going to be game, it is going to be fun. And more important than learning is, it stimulates a learning in you, and that's the reason every one of you, be it a student, be it a postgraduate, be it a practitioner, can participate and should stimulate his few neurons, which become, especially post-meal, slightly lethargic. Can I have volumes slightly high? Slightly high. थोड़ा सा volume बढ़ाइएगा. That's it, correct. Okay. So today I had the privilege of having me Dr. Renu as my co-quiz master. And without much ado, we will be directly going ahead with the quiz. I am really thankful also to the Microvision, the makers of TriSoft, who are going to sponsor the prizes for today's quiz. They are going to be in big numbers. Don't go by the volume, by the checklist, I should say, the amount in the check. It is more important that person who wins is going to come and share the dais with the big sir who in ophthalmology today. Okay. So what are the rules going to be? It is simple. All ophthalmologists, be it a postgraduate, be it a practitioner, be it a faculty, can participate. The only challenge for a practitioner as well as to the faculty is that they have to rub shoulders with the young Turks, the postgraduates, who seem to be better informed than most of us at this age. Format is going to be, it is going to be 6 sections. Each section will have 5 MCQs. All the students, all the participants have got the voting pads. Are you all ready with the voting pads? Everyone has got the voting pads? Manoj ji, Vikas ji, just look at everyone को सबको मिला कि नहीं मिला? Voting pads दीजिए पहले सबको. हाँ, जिनको नहीं मिला है भाई voting pads लीजिए, because we cannot register the responses without having a voting pad with you. So anyone who is not getting, and remember the name, number on your voting pad. So it is, the format is simple. We have 6 sets of MCQs. Each set will have 5 questions. And you get 10 seconds for each question. And the simple concept is fastest finger first. So you have to answer right and you have to be the fastest. And the cumulative score of all 30 questions is going to decide who are going to be the winners. And let's see what is there. And most importantly, any controversy which comes out of any question, remember the quiz master's decision is final. So Dr. Renu or Dr. Prashant will prevail whatever be it, no further discussions over it. Okay. And look at what is at store for today's prizes. The third winner is going to get a prize money of ₹2,000 rupees. The first runner-up would get 3,000 rupees, and the winner today will carry away 5,000 rupees. So is that all? No. Every question has prizes beyond things. So after you record the responses, one of us as a quiz master is going to ask you to physically raise your hand and ask for the right answer. Whoever answers will be getting some additional prizes for each questions. Remember, it can be in the form of a Cadbury or it can be in the form of pen drives as well. Okay. So students whom I see there to be quite not well fed, if I put it in a right word, they should crave and they should run for the Cadburys as well. So here is one first of your MCQ pattern. This is not going to be recorded, but just for the sake of knowing how to play a voting pad, this particular question. Any one of you recognizes this actress over there? No? Yeah? Bolo bhai? Jor se. Okay.
I know I still have it in me.
Acting.
Painting.
आवाज थोड़ी जोर से.
Painting. You want to paint now?
Yeah. I was always
Such a
really good
beautiful
at it,
actress.
remember? I think it'd be good to do that till the acting industry picks up.
Well, such a beautiful actress. माथुर जी आप बूढ़े हो गए हो, पहचाने नहीं शहनाज जी को. ये बुढ़ापा बोलते हैं. So she is a Bollywood actress, Shehnaz Treasury. She suffered from some certain illness. And these are the 4 options for you. This is a MCQ pattern just for refreshing you and helping you out with. Option A, prosopagnosia. B, aphasia. C, hemiplegia. D, agnosia. And here starts your next 10 seconds. You have to record your response at this point of time. Okay. Anyone from the audience who can tell what was the disease she was suffering from after having? Yes, please. The girl in the black coat.
Prosopagnosia.
Well. Come on, get up. Just tell your name to the all audience. और मनोज जी कहाँ है? एक चॉकलेट तो खिलाओ यार हमारे बच्चियों को. दौड़ो जरा.
I am Dr. Avni Haryani from Delhi.
अच्छा, what do you do?
I am a senior resident at Guru Nanak Eye Center in the cornea unit.
I think Professor Kirti Singh is missing you. I think she would have been impressed. So the opening bats and the opening chocolate goes to a student from GNEC. Well played. So this is how the MCQ is going to be formatted. One more trial question for you. Yeah. So what is prosopagnosia? It is a face blindness or a facial agnosia. It is a neurological disorder. The patient can see your faces, but he cannot recognize as who is who and after looking at the face. Okay. Another trial question for you. Kirti madam, your student won the very first chocolate. You don't feed her enough in your college and that's why she got that first chocolate. Okay, fine. But she's underfed, ma'am. That's why I thought I should give her some carbs. Okay, okay, yeah. Yeah, I have a daughter of her age, so I know that. So this is
जैसे धूल उड़ा के सींग उठा के तुम भी नाचो बाजी ड्रम के ताल ढोल बेताज जोड़ के नाचो से भी तेज कोई कर सके जो बेद नाचो अस्तबल में घोड़े जैसे भाग डोर छोड़ नाचो जो तो रोट मोटा मिर्च खा के ऐसे नाचो हाँ जा छोरे
that green house. Look at that house properly. The question is going to be regarding that particular. Don't just get carried away by those two young hunks. So my question is, who currently lives in the building you saw in the background of the song Nattu Nattu? I'm not going to ask you who were their actors. I know everyone knows it. Anyone? And these are your four options. Vladimir Putin, Governor of Karnataka, C. Emmanuel Macron, or Vladimir Zelensky. And here starts your next 10 seconds. Anyone can, after recording your answer. Chalo, let's see the young girls over there. Anyone?
Vladimir Putin.
Okay. Anyone wants to differ? D. Zelensky. Anyone wants to differ? Young girls over there, yeah? Huh?
B.
B. Governor of Karnataka. Anyone wants to differ? There are four options. So naturally, one of you has to get a chocolate. Okay, let's see the correct answer, and it is of course Vladimir Zelensky. Who was that who answered correctly? Sir, आगे आइए, आपका नाम बताइए. Mic लाइए, microvision people, Trisop people, दौड़ो, दौड़ो. Sir, आपका नाम बताइए.
Hello, मैं डॉक्टर वेद प्रकाश गुप्ता.
आपका introduction. आप practitioner हो क्या हो sir?
हाँ, I am in private practice.
Nattu Nattu, I was expecting these young girls to pick up the thing. They only knew who were the actors. Okay, tell me who were the girls.
Ukraine, na? That's why I said.
Good, good. So who were the actors, who were the heroes there? At least any girls can answer. Oh, good. But that doesn't carry any chocolates. So you missed the king. So now back to the science. It's time for us to now move. I request Dr. Renu to now take over, and she will be taking you over with the section 1. For the people who are recording the responses over there, ये पहले दो ट्रायल क्वेश्चन थे, अभी अपने को रिकॉर्ड करना है. मार्किंग कौन कर रहा है? आप कर रहे हो? ठीक है? हाँ, अभी चालू करना है. ठीक? मैडम, over to you, please.
Good afternoon, everyone. Before I begin, does everybody has a voting pad here? People who just walked in? Do you want one? She doesn't want one. She doesn't want to take that money away from you. Thank you so much. That is why, sir, that is why. So, इसी मुगालते के साथ जीते हैं. So let us start. This is our first section, and it's the average circumference of the globe at the equator. Fingers on your voting pad. 60 millimeters, 64 millimeters, 70 millimeters, or 74 millimeters.
I think it is a big, first question is quite going to be easy, I believe. Most of the postgraduates will go get it right. Okay. So before we reveal the answer, okay, this is the answer which they have revealed, but anyone from wants to volunteer and tell what is the correct answer? आ गया था?
Okay.
Okay, चलो.
Sorry.
ठीक है, ये चॉकलेट बच गई. मैडम को दे देंगे हम. कीर्ति मैडम को. Eye globe, madam.
Eye globe. Or everything. Please, all the equator is related to.
Okay.
So here we have, and somehow, can we go back to that one? So we have almost 25% who have put it as D, right?
Yeah.
See, I don't know how come the answer came.
Yeah. वो आंसर बाद में रिवील करना.
मैंने नहीं किया था वो.
नहीं उधर से वो. Now the next question. Come on, get it.
Okay, fingers on the voting pad again. Which nerve involvement is most likely to be produced by an aneurysm of ophthalmic artery? Your answers are A. Optic nerve, B, the trochlea, C, trigeminal, D, the abducent. Your time begins now.
So do record on your voting pads. Okay, before we reveal the answer, anyone wants to volunteer and go for a chocolate or a, pen drive?
There is a pen drive or a chocolate at stake.
Anyone?
So tick 1, tick 2, tick 3, quick.
हाथ ऊपर करो यार. हाँ, come on, ma'am in green.
Yes, tell us.
Yeah?
Tick now.
Optic now. Anyone wants to differ?
Yes, please. There's a difference there.
Run, वहाँ पे ले जाओ.
Answer. देखो ना. Trigeminal.
Trigeminal. So A and C is gone. Anyone for B and D? Okay, let's see the correct answer and who gets it. Yeah, of course, the option A was right. Madam, please. माइक ले जाओ भाई. अरे आपका वजन बढ़ेगा सर, डायबिटीज हो जाएगा.
छोड़ दीजिए. अभी आप छोड़िए.
Now, ma'am, your introduction, please.
Major Manisha Singh from Army Hospital Research and Referral Delhi camp.
Okay, you are a resident or a faculty?
I am a resident, second year resident.
Very good. Congratulations. Well played.
A 60-year-old woman complains of headache, diplopia since 1 week. On examination, she has normal vision in both eyes with left eye proptosis, 6 nerve palsy, mid-dilated pupil and reduced corneal reflex. What is the site of the lesion? The pons, the orbital apex, the superior orbital fissure or the midbrain?
Yeah, anyone wants to volunteer?
Any volunteers for the answer?
Yeah, sir, option.
Superior orbital fissure.
Superior orbital. Anyone wants to differ from C? Okay.
Orbital apex.
Achha, you want orbital apex. So now two options, A and D is left. Any takers for the A and D? Okay, let's see the correct answer now. So, anyone gets the chocolate?
Yes.
Sir. Introduction, sir.
I am Gaurav Mishra from Meerut.
From?
Meerut.
Congratulations, Colonel Mishra.
Thank you.
But I think we are.
नहीं, so ये चॉकलेट मिश्रा जी ले गए, है ना? कि पेन ड्राइव मिली?
सर
अरे भाई तो वापस करो पेन.
जिस दिन आप माथुर साहब के साइज में हो जाएंगे, उसके बाद आपको चॉकलेट्स बंद. But what I am seeing is, see, all the senior faculties are answering and I see lot of residents here. Faculties are sitting. It's a time for you to impress your faculties, Otherwise, madam is going to be tomorrow, be after you. So I want all GNEC, R&R, all residents to answer, not the senior people. And they deservedly need more chocolates, more calories. I know in college, madam does not give any time for any food. Okay?
So this is your fourth question. Name the most common macular complication seen in this condition. Cystoid macular edema, the macular detachment, choroidal neovascularization or hypotenuse maculopathy.
Yeah, volunteer.
Volunteers. Now we want volunteers from here. Volunteers from here. No here. Dr. Satanshu, ये वाला आपके लिए sir.
Now if no one is volunteering, I have to pick up people. See, most importantly for you students, you need to learn. Once you get up, you take a step, you might falter. But if you falter, you will rise again. So don't be shy of faltering in your baby steps. Exactly, what very well said. So I want one of the postgraduate to stand. Yes, the girl in grey. You have no other option. Madam has said so. That's it. That's it. Anyone wants to differ? No. So, let's see the correct answer.
So wow, that was good. See?
Now get up.
Get up
Come
and introduce
ahead.
yourself. Yeah?
You have to come ahead and now introduce yourself. What was keeping you from shying away from the answer? You tell me the truth.
Nothing like that.
Huh?
We were just confused. So
Okay, so that's what we say. As a teacher, we always keep on telling students, this is a baby step. Even if you falter, it's not taken as an offense. So learn to commit. See, you were missing upon a well-deserved answer. Okay, so this means for all the students, do volunteer. It's a thing to learn. Okay, congratulations. Please do introduce yourself.
I am Dr. Isha Gupta. I am working as a senior resident in Guru Nanak Eye Center in the corneal unit.
मैडम से कुछ तो बोल्डनेस ले लो यार. देखो मैडम कैसे अभी भी. Good.
So let's move on. And our fifth question in this section, this is the last question in this section. And this is, which of the following prescription has the against the rule astigmatism? I'm not reading out the numbers. Please speak out against the rule astigmatism here.
सर आपको नहीं, बच्चों को बोलने देंगे. बच्चों ने नहीं बोले तो आपके पास आएंगे.
Okay, now volunteers. Any volunteer?
This, I think only residents have to answer. This is a
Yes, first
You have
year.
to learn retinopathy
This
and
is the first year question. Against the rule.
Who are the residents here? Please, all of you raise the hands. Whoever are residents. Residents कौन-कौन है भाई यहाँ पे? एक, दो, कौन है और? बस no residents here. 3. Okay, now you have to answer. Come on, better.
Sir, A.
Okay.
Okay. And then anybody who disagrees or has a different answer?
We can take opinion from sir.
B, it's a B.
So this is B. अब दो और बचे हैं.
Reveal that.
Okay. So the answer is
So what happened again? Just now before question we asked, we said you should commit. This is the time when you should commit. You should not shy away. As a resident, there is nothing wrong. So please do introduce yourself. Well played. Yeah, of course, ma'am. इसको हाँ उसको 2 चॉकलेट दो भाई. मनोज जी दौड़ो यार, कैसे कर रहे हो? आपको दौड़ना पड़ेगा, आपका वजन भी कम करना है हमें. Good. Introduce yourself.
Thank you, sir. I'm Dr. Saksham Mathur, a third-year resident in Guru Nanak Eye Center in glaucoma unit.
भाई तू लोकल बंदा है यहाँ का?
Yes, sir.
GNEC का है, प्रोफेसर भी है पीछे से संभालने, और कोई भी है वहाँ से पीछे से संभालने. तो तूने तो पहले ही और
chocolate लेना था.
Well played. Well.
That is very nice. So with this we finish our first round, and now Dr. Prashant is going to take over for the second round.
Second round. So before we have means we need to relax. Everything is not studies in life. Okay. So it's time for us to move on with one more trivia. So these are fighter jet crafts way back in 1940. Now comes the question for this. The pilots who were flying all these fighter jet crafts had a problem with the particular wavelengths of light, and they had some problems while visualizing or flying the thing. And therefore, there was a distraction of the pilots which led to accidents of the aircrafts. So the question says, this particular problem was recognized by John A. McCready, and he worked with Bosch and Lomb, and he devised a brand which has become an icon of lifestyle brand across the world. So the question says, which product was created, and name the brand and the company. Anyone? Yeah, ma'am. Pardon? Okay, PMMA. Anyone wants to differ? I think this is a relatively easy. I gave so many clues. Yes. तो खड़े हो जाओ यार, ग्रीन वाले भाई. किसने, तुमने दी थी कि मैडम ने दिया था? नहीं तो बोल दो यार, इतना दिलदार नहीं बनते ये एज में. हाँ, competition is competition. हाँ, बोलो भाई क्या है आंसर बोलो. Very well answered. Very well answered. So, please introduce yourself. RIO सीतापुर. आप resident हो या क्या? SR. Oh, very good. Well played. So this was the thing. So it was aviation sunglasses, which has now become a style thing, a product for every one of us. Now coming to studies proper, again back to our science. Section 2. This is first question as section 2. A 29 years old contact lens wearer presents with pain, photophobia, decreased vision and clinical findings as indicated in the below photograph. Which clinical feature is nearly universal in this disease process? Tearing, oh, I'm missing upon this. I'm really sorry, we will skip through this question. I'm sorry, the photograph is not seen. Forget about it. We'll move to the next question. ये इसको erase कर दीजिए. Question 2. Red disease on OCT, all are true except, look at the OCT and now. It should alert you for the presence of glaucoma. B. It mistakenly indicates that something is abnormal. C. Seen in high myops with peripapillary atrophy. D. Is the cause for overdiagnosis and treatment in glaucoma. And here starts your next 10 seconds. You have to pick up an option. Option A, B, C, D. So only one is wrong. Which is that? Yeah, anyone wants to volunteer?
Any volunteer? No glaucoma surgeon here.
Yeah.
Not needed.
Chalo bol.
It's A, should alert you for the presence of glaucoma.
Okay. Anyone wants to differ with the sir? Very well answered, sir. Please introduce yourself to the audience as well. And you deservedly get. भाई एक पेन ड्राइव दीजिए सर को. सर का वजन फालतू में अभी आगे नहीं बढ़ाना है हमें.
I'm Dr. Priyasuman from Moradabad.
Congratulations, bhai.
So that was very well played. We'll move on.
Yeah. So the next question is, a patient presents with bilateral glaucoma. We knew Dr. Kirti Singh is there, so I had to be, biased towards glaucoma. I had to show that I also understand a bit of glaucoma. That's the reason you might see so many glaucoma questions. A patient presents with bilateral glaucoma. Gonioscopy reveals an anteriorly displaced prominent Schwalbe's line with attached iris processes and slit lamp examination is significant from iris-stromal hypoplasia and polychoria. There are no other obvious systemic abnormalities noted. This patient's clinical condition would be most correctly termed as A. Posterior embryotoxon, B. Axenfeld-Rieger syndrome, C. Peters anomaly, D. ICE syndrome. And here starts your next 10 seconds. Do record your answers. Yeah, volunteers. Sir, पहले बच्चों को मौका देते हैं.
Do we have a volunteer among the postgraduates for the right answer? Not for the answer, forget the right word. For the answer. Yeah, tell. Junior Mathur.
Posterior embryotoxon.
Okay.
Okay. Anyone wants to differ?
ICE syndrome.
ICE syndrome. Anyone?
Postgraduates, there are two more left. That's it. Those two choices. किसी को तो मिलेगी.
हाँ बोलो भाई. Axenfeld-Rieger. Very well answered. And I will let Kirti madam explain why the said question was right. Madam, can you just explain the students what's the difference?
ICE syndrome, invariably unilateral. This is bilateral. Okay, then you have anteriorly displayed prominent Schwalbe's line, which is posterior embryotoxon,
yes,
plus attached iris processes and iris-stromal hypoplasia. So, and AR syndrome fits in. Peters would have a corneal opacity and the corneal endothelial defect, which is not highlighted there, right?
So that comes from the master. Okay, please introduce yourself again and you get one more chocolate again. With your introduction, you have to tell me you are married or engaged or not. No, let me, ma'am, first.
Dr. Abni Haryani from Guru Nanak Eye Center, New Delhi. I'm a senior resident in the cornea unit and I'm unmarried.
फिर यार चॉकलेट दूसरी नहीं दे सकते, हमें आपकी शादी तो करवानी पड़ेगी मैडम, हम अपने पास थोड़ी रखेंगे इसे। हाँ वो बात अलग है, फिर मैडम को देनी होगी तो ही वो कंडीशन पे आपको मिलेगी, ठीक है? बिकॉज शी इज वेरी ग्रीडी, शी इज ईटिंग गल्पिंग वन आफ्टर अदर द चॉकलेट्स। ओके, बेस्ट ऑफ लक बेटा, वेल प्लेड, गुड। नेक्स्ट क्वेश्चन, trigger fish contact lens system CLS, all are true except, so one is wrong, one option, allows 24-hour IOP measurements while the patient is ambulatory. B, appropriate feedback concerning lifestyle, blinks and the effect of treatment. C, the readings are in millimeter mercury. And D, the readings are in millivolt. And here starts your next 10 seconds. Yeah, anyone, any volunteer?
Do we have the answer? Right or wrong is later. Any postgraduates? Okay. Anyone in the audience? Just take a quick guess.
Yeah, bolo, bolo. Good, good.
It's a guess, sir. I'm not sure.
No issues.
Readings are in mmHg.
Very well said. Come on, get up. One more chocolate. भाई पूरा चॉकलेट का डब्बा पहले ही उधर दे दो आप.
इधर रखवा दो, थोड़ा आसान रहेगा तुमको, बार-बार नहीं आना है. Okay, good.
Well played. Good, good.
So this time we are not asking for introduction.
Yeah. So the last question of this section is, a patient is sent to an ophthalmologist by a gastroenterologist to rule out Wilson's disease. The key part of the ophthalmologist examination should be A, visual acuity measurement, B, slit lamp, C, gonioscopy, D, dilated fundus. And here starts your next 10. I think it's most easiest of all, I believe. Anyone? नहीं यार, अभी तुम लोग तो GNEC वालों को नहीं है, अभी बहुत ज़्यादा हो जाएगा ये. पीछे, yes ma'am. Yeah.
The slit lamp examination for the KF ring.
Very well said. Please introduce yourself and you get a chocolate, please.
I am Dr. Amrita Vidushi Bajaj. I am working as a consultant with Drishti Institute, Dehradun.
So what accessory, madam, please go ahead, ask the question.
What accessory, slit lamp examination with what additional accessory for ruling out KF ring?
To look for the, yes, cobalt blue filter.
Very well said. So she gets a pen drive as well. भाई विकास जी एक पेन ड्राइव भी दीजिए, क्योंकि कीर्ति मैडम ने और कठिन बना दिया था हमारा प्रश्न. नहीं आपने कठिन बनाया था मैडम.
इस राउंड में मिलेगी.
See, I love my students, I love my participants, so I give them easy question. You made it difficult, that's why she deservedly gets it. Okay, very well said. So now it's time for us to relax for a while. Okay.
अस्सी. जी सर.
अरे भाई ये विजुअल देखो.
ये ले 100. थैंक यू सर.
कौन सी मूवी है? काबिल है. अच्छा देखते हैं, प्रश्न पूछेंगे अभी.
बना रहा है या आजमा रहा है?
क्या हुआ सर?
80 हुए ना?
हाँ सर.
10 क्या दे रहे हैं? 20 दे.
सॉरी सर, एक्चुअली ना जल्दी में ऐसा हो गया. हाँ सर.
Watch it properly. Hrithik Roshan decided to donate his eyes after being influenced from which particular movie? Kabil, Andhadhun, C, Kaho Na Pyar Hai, Fana. बोलो भाई. काबिल आपका कहना है. Okay, let's see. काबिल. और कोई? Fana. Third. अरे young girls, young guys, fans of Hrithik. Hrithik will die यार, ऐसे से वो मर जाएगा बेचारा, अगर उसके बारे में नहीं मालूम आपको.
Fana.
Fana. Okay. कहो ना प्यार है. Well, it was Kabil. It was obvious. So, sir, you get it. Chocolate, yaar. Sir, make it, madam.
This measuring of notes is used in which low vision device?
Yes.
That is relevant to ophthalmology.
I will come to it later. Don't reveal right now. I have a question on that as well. ठीक है. Now over to Renu madam for the section 3. Well played guys, you are playing well. अभी हम scores दिखा सकते हैं क्या कुछ अभी तक का?
कोई scores दिखा सकते हैं क्या?
अभी तक क्या trained है?
कौन सा
Who are हाँ पहले 10 लोगों का या दिखाइए. So look at your voting pad and these are the people who are trailing and who are going ahead. 370, 348, 396. Very narrow margins between the thing. Yes, all of you can catch up each other. We have 4 more sections to play. Here is over to madam for the next section. Madam, over to you.
So we begin our section 3. Which patient with papilledema would be most likely to demonstrate the pathology noted in the figure? What happened?
Yeah.
He asked to stop actually. Okay. So A is 75-year-old male with a history of moderate hypertension, 25-year-old with a history of lupus, 18-year-old with a history of moderate migraine. Can we go ahead? 44-year-old male with history of head trauma. Yeah, quickly.
Yeah, volunteer.
So who got it in the volunteers? Who's volunteering for this one?
C. Okay, anyone wants to differ?
Any deference to this?
Okay.
Anyone? B. अब 2 ही बचे हैं बाकी.
ठीक है, दिखा देते हैं कौन है. Let's see the correct answer. And it's B. Who was that?
Who said B?
Please introduce yourself.
Myself, Kirti from Rishikesh Ames.
Okay, you are a resident or a
Junior resident.
very well said. क्यों इतना टाइम लग गया बेटा, अभी तक खड़ी क्यों नहीं हुई? Come on, very well played. Congratulations.
Thank
and this girl also gets a chocolate on behalf of me because she at least made an effort to do that. So anyone who makes an effort is also it also impresses your examiner or be it a quiz master. So उसको भी deserve करता है because when all the crowd was silent, she volunteered. Volunteering is the first step of success. Remember that. Very well said. Congratulations, beta.
Awesome. So now you have to tell us which is false in these statements. A, B, C, D. Time begins now. Any volunteer here? Anyone? Yes, please.
C. Okay.
Anybody who thinks the answer is different?
Yeah.
Yes,
B,
please.
intraocular foreign body is a differential diagnosis.
B. Okay. Anybody else?
Let's see the answer. B was the right answer. So,
oops, careful.
Chocolate idhar bhago bhai.
Please introduce yourself. Once
Dr.
again.
Amrita Vidushi Bajaj from Drishti Institute, Dehradun.
Okay.
Good. Well played.
I think Amrita has got more chocolates right now. Okay. हम आ रहे हैं बाद में आपके पास मैं और प्रशांत. Now this is a 60-year-old lady who complains of sudden onset diplopia since 3 days. Diplopia eliminates on closing one eye. She's a known case of hypertension, diabetes and hyperlipidemia. Where is the site of lesion? Look at the pictures.
Yeah.
Okay, so
volunteers.
Now this is a ritual. Every time volunteer should be ready.
चलो भाई फटाफट.
Volunteer.
माथुर जी A. Okay.
Okay. और कुछ? अबे A के बारे में एक ही बोलना है क्या ना?
D किसने बोला? Okay, D. Fine.
B की D.
D.
Okay. You have another choice or answer?
Let's see that. Well, who was the first person who spelled out D?
He did.
आपने? ठीक है, आधी आधी चॉकलेट दे दो भाई, दो लोगों ने सही जवाब दिया, या 2 चॉकलेट लाओ यार।
Please introduce yourself.
ट्राइसॉफ्ट इतना महंगा है।
डॉक्टर अनुपम सिंह फ्रॉम यू सीतापुर में।
वेरी गुड।
सर भी है वहाँ पे।
उधर सर को भी दे दीजिए, वो बाजू। या मैम congratulations.
Okay, a 1-year-old girl comes with alternating esotropy of 40 prism diopters and a cycloplegic refraction of plus 1.5 sphere in both eyes. Which of the following features will be inconsistent? The word is inconsistent with the most likely diagnosis. Cross fiction.
Yeah, volunteers? Yes, boss. B. Anyone wants to? Yes, ma'am. A. और आपके पीछे कोई है, हाथ ऊपर किया है? Yeah.
C. अभी एक ही रह गया, उसको भी बोलो ना।
चलो, let's see the correct answer. And it's D.
वो जो नहीं बोला वही है।
So it happens. So
okay. Okay, let's come to the next one. This is what is the dominant source of fluorophores in fundus in autofluorescence imaging? This is a resident question. PG first year question.
yes, come. D.
Lipofuscin.
Who was that? Acha, lipofuscin. Okay, D.
Anybody thinks it is any other pregnant? Or any other thing?
Let's see the correct answer. Very well. नहीं, ये दो लोग पहले बोले, सबसे पहले आप बोले हो। आपका नाम बताओ।
नाम बताओ।
Dr. Nitesh from GDMC Dehradun.
Very well played, बेटा. Very well.
Very well.
Congratulations.
I think ये हो गया खत्म ना? Okay, so we move to our next section.
Next section. Before that, some difference, some trivia for you. Name the artist who suffered from colored halos, as is evident from these 2 paintings of his. Was it A. Leonardo da Vinci, Edgar Degas, Vincent van Gogh, or D. Guercino?
Vincent van Gogh.
Chalo, let's see the correct answer. Of course, it is C. Many people answered. I think इतनी चॉकलेट्स तो माइक्रोविजन वालों ने नहीं लाए, क्योंकि ट्राइसॉफ्ट थोड़ा सा सस्ता है, ऐसा उनका कहना है। तो रेनू मैडम के यहाँ से आज शाम को सब लोग जाके कलेक्ट करके ले आना, साथ में पेन ड्राइव भी मिलेगा। Okay, well played. So now coming to my next section. All are MIGS, that is minimally invasive glaucoma surgery devices targeting trabecular meshwork except eye stent, Kahook dual blade, Cypass microstent, Hydrus microstent. Volunteers, if you have pressed the buzzer. Yeah.
Volunteer. Yeah. Somebody who didn't answer before. Yeah, you tell us.
C.
Any difference to the opinion? Anybody who feels it could be any other thing?
Correct. You answered it correct. Please introduce yourself and a chocolate.
Hello. Myself, Dr. Adarsh Keshri. I am from Regional Institute of Ophthalmology, Sitapur.
Very well played. Very well. Congratulations, beta.
मैडम हमारे पास पेन ड्राइव नहीं होगी और देने
चलो मैम अगली बात. The most accurate characterization of donor endothelial cell counts following penetrating keratoplasty is no significant change, slow steady increase in endothelial cell count for over 10 to 15 years, rapid loss of endothelial cells over first post-operative year and continued, slow progressive loss of endothelial cells over 10 to 15 years. इसके बाद बोलो C है. Okay. Anyone wants to differ? Very well answered. Introduce yourself, boss.
Ankit Agrawal from Eye Clinic, Prayagraj.
Very well played, Ankit. So now let's move on to the next question. Which of the following is not true about direct gonioscope? A. No significant change. B. Image of direct gonioprism. C. in direct gonioscopy, the light rays are reflected by a mirror in the contact lens. D, used for performing goniotomy. Yeah, anyone?
C.
C. Okay. Who answered it, ma'am? अच्छा, चलो बोलो नाम बताओ.
Sir, Dr. Kritika Srivastava, Rio Sitapur.
अरे वाह, good, congratulations. इनको 2 चॉकलेट देनी मांगती है. वो
So nice, no, Rio.
Hmm.
And then पीछे सीतापुर. Just like मैं Jolly Grant से आती हूँ.
Very well played. Good, congratulations. So the next question, an infant is born with bilaterally thickened hazy corneas with epithelial edema as demonstrated in the photograph below. Corneal diameters are normal. There is associated nystagmus. Which one of the following regarding this condition is false? There is no photograph, but from the findings described. A, B, C and D. And here starts your next 10 seconds. वॉलंटियर्स. नहीं यार, ये जीएनईसी वाले मैडम मोटी हो जाओगी, तुम्हारे सब चॉकलेट मैडम ले रहे हैं. हाँ उधर. Anyone wants to differ? D.
Sir, D.
इधर बोल दो यार. हाँ. Okay, very well answered. It is A, which is right. Madam, can you just tell why the other options were wrong? Mic दीजिए मैडम को. You will get later on, madam. रेनू मैडम आपको घर पे ले जाके खाना खिला रही है.
See, by very much saying that an infant, if the corneal diameters are normal and there is bilateral hazy cornea, intraocular pressure would be normal. So thickened, elevated would be in ophthalmos. So that is the false one. Other ones would be variant for CHED. There's no nystagmus and the onset is later. Distinguished from CHED would include corneal thickening or epithelial edema. DM may be thickened. So all these are differentials of the shared ones.
Thank you, ma'am. Thank you. So the last question in this section is going to be, which of the following is incorrect about the new 24-2C? A, option A, option B, option C, option D. And here are your next 10 seconds. That's the last section. Yeah, any volunteer? Come on. I think it's slightly different. उधर वाले लोग यार कोई तो बोलो, खड़े हो जाओ, कोई भी गलत, कुछ नहीं होगा. B. Very well said. Who was that?
Aisha from
Why were-
LLRM Medical College.
कहाँ से?
LLRM.
Very, very good. Congratulations. Then why were you shying away till I asked
Very
you
well
to-
played, very well played, very well played.
So now another visual. Accident. So the question is regarding this particular accident, if you see, which happened in November 15th, 1875, okay, at Bankeberg, okay. And the investigation following this accident, it revealed that the investigation was carried out by Swedish ophthalmologists who found out the cause of accident, which led to enforcement of dash rule. So anyone from the crowd? Anyone can volunteer. Here you don't have to record your responses. Yes, ma'am. Yes, and who was it? Which rule?
Checking the color vision and red green
Which
blindness
particular
before,
test was that? Color vision.
Ishihara chart or lantern.
So that was right, almost right for you. It was Swedish ophthalmologist who noted that it was a color vision defect with the particular driver, and that's why he had that particular accident, following which this particular test became mandatory for all the drivers. And so please introduce yourself and a pen drive for her.
Dr. Amrita Vidushi Bajaj, consultant Drishtiya Institute, Dehradun.
मैडम कितने ले जाओगे, कितने स्वार्थी हो, बच्चों को भी कुछ मिलने दो. ठीक है, now the last section, for want of time we will be just wrapping up with the 5 sections only. Over to you, Dr. Renu.
Okay, we'll quickly go through this before people come to send us away from the dais. So the first question is, what is generally not done in this condition? Volunteers?
Any volunteer? A. Okay, everyone answered. Madam?
That is like,
ये तो आपको देना पड़ेगा.
भाई इतना चॉकलेट सर दो ना आप तो कहीं से.
Director should give, I think. The host as well as the director quiz master.
Oh, I don't know. I'm not the host. Okay, that was, answer was color vision. Coming to the next question. The Duane's retraction syndrome type 3 can be characterized by all except Okay, now the volunteer.
So, any other volunteer? A? Any other takers?
B.
B? Okay, let's see the correct answer. And it's B.
Okay.
मैडम सब लोग अभी आपको जानने लगे हैं तो भी बोल दो चॉकलेट दीजिए भाई दौड़ो.
Major Manisha from AHRR Delhi Camp.
Very well played, Major.
True statements about saccadic eye movements include
Yeah, volunteers.
Who said B? Now who says A?
Raise your hand. Okay. Let's see through the answer.
And then there is another one who says C.
Okay. So we have all the options. One has to be
Now
right.
who said A? किसने ऐसे बहुत आराम से बोला, इसने बोला.
Who was that? Option A.
Stand.
कौन था भाई?
A किसने बोला? उधर नहीं बोला ये. C और B तो आई एम सो सॉरी एक चॉकलेट बच गई.
बच गई. माइक्रोविजन वाले खुश हो गए.
Okay, moving on to the next question. This is the fourth question. The T dot sign in FFA is seen in, you know all this, right? Progressive macular edema, CSR, AV shunt, or microaneurysms. This one is like too easy.
Volunteers.
अभी wait करना.
ये म्यूजिक हाँ बोल दीजिए. C. B. Anyone? Praful, you are a faculty, you are no longer a resident. अभी चुप रहो, बच्चों को भी कुछ कमाने दो. हाँ. B. Okay, let's see the answer.
अरे कौन सा टाइप का है ये भी बताओ ना फिर ये. What type of?
So, it's a progressive macular edema. Again, we have saved some more chocolates for microvision. They can take it back. So, the last question of this today's quiz. Yeah.
So, are we ready for the last one? Which of the following is the most useful distinguishing the cause of anisocoria that is greater in dark than in light? I apologize for the grammar. Cocaine, pilocarp 1% and pilocarp 2.5%.
Volunteers.
A cocaine 10%.
Who was that? Cocaine 10%. Okay.
Okay. Then
And
anybody who wants to put it as pilocarpine?
Yes, ma'am. हाँ जी, बोलो. पीछे वाले लोग बोलो. You
पीछे
said
आपके
something.
पीछे भी है कोई?
You said something. Any one of you from the back? हाँ.
हाँ बोलिए. C.
C.
फिर B. अभी तो ज़्यादा रहा नहीं कुछ.
Last question. Yeah, last question.
हो गया ना?
Yeah. Okay. Till the answers are computed, I will have just one more trivia for you.
20
याद है ये मूवी कौन सा था?
जल्दी रखो उधर
आके.
तू बक्सा उठा और बाहर चली जा
Okay. So the question goes, clipping from movie Aake, correct? Amitabh Bachchan trained 3 blind to do a bank robbery, correct? What are the identification points included in Indian currency notes to help visually impaired? Madam had almost asked that question, that's why I asked her to be to stop for a while. We are serving the blind, so we should be sensitive and we should be aware of these smaller things because this is our social responsibility towards the.
Sir, the line mark.
So I asked the question, answers for that.
So the line mark on the notes.
There are 3.
The line mark on the notes present.
Okay, and?
One is a number printed.
Okay. Anyone? Okay. Let's see. So these are the 3 patterns which help the blind to identify which particular thing is. This particular question I kept it last is because we are serving the people who are blind and it's our moral as well as social responsibility to understand this particular thing, and so that was the question why we end up. So thank you once more for participating in this particular quiz. Are we ready with the mark sheet, mark scores?
Yes, please.
Chalo, let's have that. Meanwhile, I will request all the teachers who are serving in various medical colleges to come ahead because they are the people who have made us stand or made the students do well. So all the faculties, all the teaching faculties have to come over here to felicitate the winners over there. Please, Madam, Kirti Madam, Praful, I don't know, by Gaurav, कौन है faculties थोड़ा सा identify करो, उनको बुलाओ और फटाफट अपन prizes दे देंगे. आइए मैडम ऊपर आइए. Who are the local faculties? I don't know here.
Dr. Das is here.
All the faculties, fatafat. So who is number 3? On number 3 is going to be voting pad number 0372. Who is that? आ जाओ आगे. Please, आइए.
Oh, this is so good.
हाँ आइए इधर आओ. इधर दे दीजिए, इधर मैडम के हाथ में. आइए आप भी आ जाओ माइक्रोविजन वाले भी. आइए मैडम आप. Come on, introduce yourself first. He is runner up number 2.
My name is Dr. Anupam Singh from RIU Sitapur. I am a SAR there.
Congratulations and well played. Big round of applause. Why everyone is hypoglycemic? Yeah, very well played. Good. Now on number 2 is first runner up 0348. Okay, very well said. नाम बोलो बेटा. पहले नाम बोलिए.
Sir, Dr. Avni Haryani from Delhi.
Okay, please.
Guru Nanak Eye Center. I'm a senior resident in Cornea.
You should be proud of a place which has made you so capable, and that's why we are all having all the faculties. Today, wherever we are standing are because of people like them. So that's the reason why I invited all the faculties over here. Madam, अभी आप exchange कीजिए. बच्ची आपके हाथ से तो बहुत बार credit लिए, अभी उनको देने दीजिए. Congratulations, well played.
Congratulations.
Good. And number 1, so who is the winner today? Finalist. Yeah, 0370.
370 कौन है?
क्या बात है, very well played. Come, पहले नाम बोलो, पूरा details बताओ.
I am Dr. Isha Gupta, senior resident in Guru Nanak Eye Center.
Okay, very well played, Isha. Come. सब लोग मिलके दे देते हैं अभी. आइए सर, आप भी आगे आइए. मैडम आप आइए. चलो आ जाओ आप भी.
आइए ना डॉक्टर.
So in fact today's everyone is a winner, whoever participated, whoever volunteered. My big congratulations to each one of you. All the 3 winners come together with, we'll have the final group photograph. All the 3 winners with their respective check के साथ. आ जाइए फटाफट. एक बार. Fast, we have to hand over the hall. Yeah. See, this must be a moment of pride for you so that you have the photograph with all the stalwarts. Deservedly, you need those photographs. Come. आइए अनुपम. आइए. इधर आ जाओ. Come.
आजो बेटा. Yes.
थोड़े से आप लोग ऐसे हो जाओ. Kneel down. हाँ.
हम भी ऐसे.
Very good. सौरभ कहाँ गया है? सौरभ है ना यहाँ पे? अरे यार चेयरमैन साइंटिफिक, कम 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 कम. प्रेसिडेंट वगैरह कोई है? प्रेसिडेंट वगैरह तुम्हारे सोसाइटी के बाकी लोग? Thank you, thank you. Thank you once more Uttarakhand State Ophthalmological Society for this wonderful opportunity. Thank you.
So, wonderful session on the quiz, and I felt good. I'm from GNEC too, so I was so happy to see that GNEC is thriving and doing so well. All credit to the teachers and Dr. Kirti Singh there. So we are starting off with the quiz, with the debate now, the big standoff, and we have some very interesting topics and some amazing speakers and tackling very, very difficult questions. And this is going to be a 3 minutes each presentation. So each speaker will have only 3 minutes to come up with their answers. We will like to have on stage our panelists, Dr. G.N. Rao sir. I don't see him, but we'll look for him. Dr. Umang Mathur, if he's here. No. Okay. Dr. Prashant Bavankule has to stay back. Prashant, where are you? Please come back. Okay. And Dr. Geeta here is here. Saurabh, can you call him? Okay. And Dr. Asif Khan and Dr. Salil Gupta. So we need them on stage, and we are starting off with our first debate topic, which is going to be on 25 years old male with unilateral high myopia of -16 and with a best corrected visual acuity of 612, partial in the right eye, and an AC depth of 2.79 with a dysfunctional lens index of 3.2, and the fellow eye is 6.6. So one eye is basically unilateral high myopia with -16 and some deranged functions and a AC depth of 2.79. So are we going to do a refractive lens exchange or an ICL? So making the case for refractive lens exchange, I'll request Gaurav Mishra, Dr. Gaurav Mishra to be on that podium, and I'll request Dr. Kamal Bandhu Kapoor to be on this podium. You have 3 minutes each. Kamal, yes, of course. So we have 3 minutes each, and we'll start off with Dr. Gaurav Mishra making the case. Go ahead.
Okay, good evening everybody. So this is a very simple thing that we are dealing daily. इसको ऑन कर दो यार. Okay, so the patient has already been told to you. Young patient, -16 diopters, ACD a big query, DLI. Most of us do not know what DLI is in our common practice. It is doctors like Dr. Rohit and Dr. Gaurav who must be dealing with a lot of DLIs, but we in our common practice don't have such gadgets, so we know the DLI importance, and the vision is 612 partial. Since we are common ophthalmologists, this is a common problem we are being faced every day. So this is a common problem, so there should be a simple solution. Patient is well aware of the cataract surgeries and normal lens removal, so it is very easy to counsel this patient. One step and a simple surgery, give him a good vision by using a good IOL and have a good sleep and go for massage. Unlike my fellow person who would be having a patient dealing with the next day problems of wall height, IOP, extensive follow-up and increased adrenaline secretion. Thank you so much.
Great. So I think you get full marks for being in time though, and let's see what...
I can use the time.
Okay. So Kamal, let's see what you have to say, especially that, you know, the dysfunctional lens index is just 3.2. Would you still want to do an ICL?
3.2 or 3.9? Anyway, so ancient wisdom says we should not sacrifice any tissue whatsoever if it can be avoided. So are we sacrificing the poor crystalline lens just because we want to get away with a common solution? Whereas you can, I would say in today's date, nobody can say that phakic lenses are uncommon. And in case you are saying that, I think you need to kind of brush yourself up. Anyway, there is no hard and fast rule. What I would say is the points to be considered would be, what is the kind of the cataract? DLI probably is not the end all. My partner was 3.9 DLI. He was 6'6". He was playing golf every day. So even we have traces. So DLI probably is not the end all, number one. Number two, the patient probably is anisometric and has got a suppressed vision. So this vision probably is not bothering him. He's minus 16 in one eye and unaided 6/9 in the other. So best corrected visual acuity, whether it's a developmental or a congenital cataract, I would ask my friend to take some history before he takes a call on that. If it's a developmental cataract, probably these go very slow, and 25 years of age, a very, very high myope, I don't want him to, subject him to a lenticular surgery associated with all the issues of doing a YAG laser, PCO, retina detachments, no PVD there. Day-to-day activities of the patient, what is his lifestyle, what is the retinal status, what is the CLR of this patient, will again probably decide. How are the angles, what is the gonioscopy of this patient, if the patient is amblyopic or not. I think looking for a common solution, a lot of times you get caught in a common quicksand. So advantages of a phakic lens, it's a simple minimalistic procedure, there's no protein broth, there's not extensive breakdown of the blood barrier. There's a proven track record, and as we all know, all of us, it's common sense that when you have a high myope, doing a clear lens extraction in a young high myope probably is not the first choice. If what could be the break points here? You'll probably be making him lose his accommodative vision because he's 25 years of age. The chances of having negative dysphotopsias, large size pupil, big globe, so chances of dysphotopsias are higher in these patients. And astigmatism correction, also trying to find the right IOL, probably some biometry issues. Complications which can happen, as any cataract surgery, any complication. So Murphy's law says what can happen will happen. What about having a PC rend while doing a surgery? How do you face the patient? Having an endophthalmitis, bad rexis, capsular eccentricity, decentration of the IOL, name so many. And when you do a phakic lens, guess what? It's reversible. God forbid something goes wrong, it's reversible. So I think the biggest ace you have in your armory is you're doing a reversible procedure which is less traumatic to the patient. It does not break the iris lenticular diaphragm. Chances of retina detachment are less, and even if you say the complications seen with phakic lenses are far less. Thank you.
Thanks, Kamal. I think, can I request ma'am to say this? Umang?
Yeah, you want a rebuttal?
I know he's a good speaker, but it is ultimately what you do in your practice is most important, because in the morning he was saying he's operated his wife with -5. So I would not argue with him.
So he's questioning.
My wife was ACD was 2.3. You gave me 2.79. I would have done a phakic lens any day now. Any day.
What about your partner?
Partner had a DLI, he says, "Mere ko karna nahi hai ICL." Patient choice. As I said, there is no hard and fast rule.
No,
you would follow science. You would follow science.
Doing an ICL in 2.79 is still very risky. I
don't agree with you. You better do more phakic lenses then.
Okay. So I think there will be many other reasons as well.
CLR, angles, everything.
Costs.
Everything, of course.
Lifestyle, a lot of, but I think the debate just shows that both the options are available for you to give to the patient, and depending on the patient's requirements or need and what they understand, I think you're not too wrong if you go either way.
And especially, I think I would like to reiterate again, DLI of course is a very good indicator, but yes, it is not end all. We do a lot of eye trace studies, we have very low DLIs and the patients are probably just next to normal. And the classic example is my partner again, he was doing surgeries every day. Till I did a DLI, he says, "Main theek hai." Then I said, "Chal, in one go we'll do a spectacle removal also." So it was minus 2.5. It was minus 2.5. He said, "No, I don't want to go for phakic lens." So that's it.
Thank you. Thanks, Kamal. Thanks, Gaurav. While we invite our next two speakers, Dr. Neeraj Sanduja and Dr. Ruchi Tiwari, to set up their laptops, I'll put this question to Dr. Rohit Shetty, who has been working a lot with the DLIs, and he has good knowledge of the lens and how it behaves. For a quick one, can we give a mic to Dr. Rohit Shetty, please? And for the next question, just to absorb it while they work it up, is that there's a 21 years old high myope for laser refractive surgery, diagnosed with a lattice degeneration and retinal thinning in both eyes, So Dr. Neeraj is going to make the case for prophylactic laser barrage is important for most lesions if you are getting for refractive surgery. And Dr. Ruchir is going to say that he wants to leave them alone if possible. So before we start off, I think I'll request Rohit to say.
There is a lot of challenges with DLI. DLI is based heavily on the kind of aberrations it's inducing. And if at the age of 50, if you're having a little accommodation, if inducing more accommodation, your DLI would still change. So I was just telling ma'am here, you combine DLI if you have a pentacam and look at DLI with the PNS grading. If your PNS grading is also showing that there are density changes and your DLI is also low, it means that it's true. If pentacam does not show anything and your DLI is 1, it means that it's pseudo. So you have to combine it with some other tool. And if you don't have pentacam, the best tool is asking the patient to see the lights. And if he has a lot of halos around it, and that means that it is inducing some change.
Excellent. So I think we'll move on, and so we can start with Dr. Neeraj Sanduja going first on benefits of prophylactic laser barrage for.
Thank you, Gaurav. So we have this interesting scenario we used to see in our day-to-day practice, where we have young myopes coming for refractive surgery and then sent to a retina surgeon for their opinion. So we all know there are predisposing lesions for retinal detachment like lattice degeneration, retinal tears, holes, cystic retinal tufts, tractional tufts, and they all can lead to retinal detachment. And we all know all myopic patients, whether they are low myope or higher myopes, they have fourfold risk of increased risk of retinal detachment. And this risk especially increases after refractive surgery. So we all know about these facts. And even Wilkinson CP recommendation for treatment was like all symptomatic retinal lattices should be treated, any retinal hole symptomatic should be treated, and asymptomatic, they can be washed. But we don't have any clear guidelines on management of symptomatic or asymptomatic retinal degeneration prior to refractive surgery. And we need to understand what exactly happens when we do LASIK or maybe femto-LASIK. Because there is an increased intraocular pressure, more than 65 millimeter mercury during application of microkeratome suction ring, and acoustic shock wave is delivered to the vitreous, disrupting the vitreous, changing the dynamics of the vitreous, and then sudden lowering. So everything, it leads to vitreous disturbance and leading to posterior vitreous detachment in few of the cases later on. And this effect of microkeratome can be related like a blunt trauma only. And many patients, you can say 9% to up to 25% patients, they complain of increased floaters after surgery. It is very important to know. It means they are becoming symptomatic patients. And with this, like femto also, because there is longer suction time, and despite that, and low suction pressure, but the study shows whether you do LASIK or a femto LASIK, the chances of PVD are almost same. This is very important to understand. And also various studies have shown like the patients who have been treated with the prior laser, they have less risk of retinal detachment. So in LASIK procedure, what you are trying to do, you are trying to give good vision to the patient. But at the same time, if you are not taking off any lattice degeneration, which is having any retinal holes or any traction over the lattice, if you are not giving laser treatment to that, patient is more likely to develop retinal detachment later on. Any asymptomatic lattice where like the vitreous is healthy, no traction, no holes, that lattice can be left off. But the patient should be told like any floaters flashes coming, again you have to treat that patient. So the conclusion, a thorough retinal examination, we should look for peripheral retinal examination before laser surgery, and prophylactic laser barrage should be done in most of the cases who are symptomatic, who have got retinal holes, who have vitreous traction before surgery. Thank you very much.
Great, thanks Neeraj. So let's go.
Yeah, thank you, sir, for inviting me. So I'd like to start by quoting Edward Demings here. In God we trust, rest all bring data. So the question is, we have a 21-year-old high myope, planned to undergo a laser refractive surgery, diagnosed with lattice with retinal thinning. Now these are asymptomatic lattices. Nowhere is it mentioned that the patient has symptomatic lattices. So to break it down further, I would like to answer the two questions separately. Does prophylactic retinal laser photocoagulation of asymptomatic lattice in non-fellow eyes prevent future chances of retinal detachment? That is number one. Second is, does laser refractive surgery in itself increases the chances of retinal detachment? So let's come to question number one. Overwhelmingly, the answer to this question is no, because we do not have any data to say that it helps. Now, I would like to quote Bayer here, who has done seminal work in lattice degeneration, and I would like to bring to notice his farsight when he said that the criteria for prophylactic treatment of lattice lesion should not be altered because of the extensiveness, location, or the appearance of lattice lesions, nor by any other clinical impression or theoretical argument. So whatever has been presented up till now has only been theoretical arguments. So what are the indications for treating a lattice as of now? So the indications as given by the preferred practice patterns of AAO and still mentioned in the Ryan's textbook of retina say that only asymptomatic lattice without holes with a horseshoe tear require treatment. Nothing else requires treatment. All others have to be symptomatic, and symptomatic would mean along with a tear, operculated tear, or a fluid or a hole with a fluid. So none of these conditions are there in our patient. Secondly, now we come to the second question. Does laser refractive surgery increase the chances of retinal detachment? Again, there are multiple studies to show that this does not happen. The most quoted study is the 1999 publication by Rui Moreno et al., which says that in 1,554 consecutive eyes, the rate of detachment was 0.25. This was found to be even lower than normal myopic populations, and they said that LASIK does not lead to retinal detachment. In fact, they even quoted that there is very doubtful evidence as to the benefits of prophylactic laser in patients with lattice degeneration. The second study is an Indian study published in 2021 by Srinivasan et al. They looked at 694 eyes of 352 patients, where they said that the incidence of RD after LASIK surgery at 5 years is 0.7%. This again is similar to what we see in normal myopes. They found no statistically significant difference between lasered peripheral retinal degeneration versus cases where laser was not done. Moreover, they actually found higher chances of RD in cases where laser was done. With this, I would like to come to the last study. I think this study was actually quoted by Dr. Neeraj sir as well. This is the largest study that we have for retinal detachment in a LASIK patient. It included 11,594 eyes followed up for 10 years. What they found was that the frequency of RRD was 0.05% at year 1, increasing to 0.19% at year 10. They said that rhegmatogenous RD after LASIK is highly infrequent, and if managed well, it does not lead to any complication. Obviously, there is a statement which can be very well misconstrued. They say that the risk of RRD after LASIK is very low if you screen patients and do prophylactic treatment as was done in their study. Now, the question is, what lesions did they treat? They treated symptomatic tears, any tear with significant subretinal fluid, horseshoe tear in the fellow eye, and lattice with holes or subretinal fluid in the fellow eye. None of these factors are there in our case. So again, if I go back to the problem at hand, we have an asymptomatic young adult who is undergoing refractive surgery which does not lead to retinal detachment. Would you do laser? I would not. Thank you.
Ruchir, see, there is no doubt after this LASIK procedure, PVD induction is there in 25% of the cases, which may be seen as early as 5 to 7 days up to 2 months or 3 months. It means your patient is becoming symptomatic now. And in practical experience also, I don't have many patients seen, but at least 5-6 patients I've seen who developed retinal detachment, who didn't undergo any retinal screening before that, and patient was saying whether something wrong has been done with me or not. Who is going to answer that? I didn't utter a single word against that surgeon, but 5-6 cases I have done buccal surgery within 1 month of LASIK surgery, because all these patients may be screened and not screened, but they were not looked upon. So what I mean to say, even lattice degeneration, which is asymptomatic, but having retinal holes inside, having any abnormal vitreoretinal interface, which is not mentioned here, should be treated 100%.
Sir, in the last 5 years, I've treated 5 patients in which laser was already done. In 3 of them, the tear was larger in size, probably because of the extensive laser that was done. And in the rest of the 2 cases, there were new tears. What do I tell those patients?
No, I understand. See, whatever pre-existing problem, see,
So your time's up.
So again, we don't have data, and we have enough data to say otherwise.
see, all cataract patient also we do treat any asymptomatic light because the same injury we are doing, but all these eyes have a solid liquefied, not liquefied vitreous, so chances of detachment may be low. But yes, we are, I think, doing some insight to
I
the
think
vitreous.
what is clear from what both of you were saying is that LASIK per se is not increasing the chance of detachment.
But it is presenting as an opportunity to screen and treat it.
Yes, and I think that's important because once you do refractive surgery, you tend to forget, and the patient tends to forget that this person was ever myopic. Yeah. And so even if you tell them that you need to come for a screening every year, you tend to forget. And anterior segment surgeons, you see a person who's 6x6 in the follow-up, cornea looks okay, you see them on slit lamp, oftentimes you just send them back. So you miss that opportunity and you don't know what's happening later. So like what Neeraj was saying, that there would be patients who come with a detachment later. Will they leave you?
So, but then again, the point is it actually helping? Or is it
No, it
just
may not be,
what
it's
we
just,
believe it is helping? That is the whole point of the discussion.
One thing is they are saying
I think there's literature to suggest that it's not LASIK per se causing it. And
But I think he's got a point. Medical legally, some of your colleagues sitting in the expert committee in the Delhi Medical Council or XYZ.
100%. 100%.
Sir, in a scientific forum,
So the question is not whether screening was done or not. Screening has been done. So that part is gone. And then documented, and then you've elected not to treat a particular lesion. So I think there, very good. Both of you have presented so well. I don't know whether there is a very clear answer to this because it is a little subjective as well between surgeons trying to decide. We'll take a quick one from ma'am.
Just to quickly add that study which Ruchir presented was from SN by Rajiv Raman, and if you see most of the RDs that occurred post LASIK were 5 years after the procedure was done, so you really don't know whether you can blame the procedure to the RD occurring. And secondly, what you didn't mention there was that all these RDs were from a new lesion which occurred in these eyes and not from the place where which had been barraged. So we have an argument for both sides over here, but medico-legally, like you rightly pointed out, it might be you might be saving your skin by doing the laser procedure, but we still don't have an answer as of today.
Great. I think we'll have to move on, and I'll invite Professor G.N. Rao sir. We were looking for him, sir. Please come over because we'll need a few occasional, those one-liner comments from you. Please come to the stage, and I request Prashant also to come and quickly comment. This is your domain, and I'm inviting the rest of the speakers. Also, one-line answer from you, Prashant. Come on this very topic that we just discussed. If you would like to add something different to what we already discussed. So I'll now invite our next speakers and introduce the next situation to you. Intraoperative zonular dialysis of 5 clock hours, and how will you deal with it? So there are many ways to deal with it. The first way would be a CTR with a CTS or a Sionese ring. Fixation still rules. So Dr. Umang has helped nicely enough, agreed to present this. Dr. Saurabh had to pull out last moment, and on one day's notice he's kind of chipped in. And then after that it will be Dr. Rahul Mayer on the other side, giving us that he would prefer to do a Yamane or a glue dial fixation might be the best way. And then after that we'll have Dr. Rohan Mehra trying to say that retrofixated iris claw will be his preferred way. And Prashant, would you like to add anything to that argument?
Regarding the prophylactic laser for a lattice in a case which is undergoing a refractive procedure, I would put it any patient, it is better to keep him informed. And if it is a low myopia, probably I might go with patient, means when we are counseling a patient, I would be more forceful if it is a high myopic patient with a pathological myopic fundus. Here I would leave it the choice to the patient, keeping him well informed about the ifs and buts. That's the better way in this today's era of medico-legal scenarios.
Thanks, Prashant. A very balanced view. So I think we can start off with what Dr. Umang is going to tell us about how he wants to deal with it.
Here's a situation where there's more than 5 clock hours of subluxation, and you have to, isko on kar denge? Okay. And I'm assuming this is because of trauma. So that's something I would go with in trying to place my intraocular lens in the most physiologic place, which would be in the bag. And if you have especially a young patient with trauma, if there is a condition like a Marfan's where you expect the zonules that are existing to be also weak, I might look at it differently. But in a trauma patient where I expect rest of the zonules to be intact, I would try to first preserve the bag and place the lens in the physiologic position of within the bag. That will, in the long run, have the best outcome. You'll be more predictive in your power calculation. The bag, we know we have enough experience that lenses in the bag do well. And that is something would be my first choice. And as a surgeon, I think it is going to be a craft, and it is challenging. But if you have the right backup, I think that is what is going to give the best outcome. And so I would stick to that.
I would like to start with, it is very difficult to challenge my mentor who's actually taught me phaco. So being a retina person, I would slightly disagree. So these are the things. I'm not going too much into the paperwork on this. I'll just show you a small video. We have decreased phacodonosis of IOL if it is tucked and stable. Glued IOLs, as already proved, are at the right level. Sometimes in patients, when we put in a CTR, we may have IOL drop and other complications, which may further lead to. So it's always better to convert at the right time. So this is a small video wherein I actually started with Yamanes very early, but I shifted also very fast. I was not very happy with this technique. Doesn't work very well in my hands. So these are the initial techniques what I started, wherein a 3-piece IOL was put, even if we have an intra-op zonular dialysis of more than 3 diopters. Again, I am emphasizing I am a retina person, so I would err on the retinal aspect in these cases, and here we do the cautery. Next came the handshake technique. This I did in a lot of cases, but my biggest problem in these kind of patients was this. I'll show you, I had a few patients where I had hypotony post-operative. You see here. I'm not able to, yeah. In these kind of patients, the results of glued IOLs, believe me, these kind of patients, wherein you have slight leakage post this. So I shifted very fast to the third technique, which works very well in my hand, which is the X-net technique. And believe me, it's a 5-minute job. The only thing which I would like to add is, in all these patients, all, believe me all, we've done almost complete vitrectomy in these patients. We've not put in glued IOLs after doing anterior vitrectomy. So what we do is we do a complete vitrectomy, maybe without a base excision, and we end up putting glued IOLs. The results are extremely good in these patients. We've had a long series. I'll just show you a small data. We are actually in a process of compiling more patients. So this is the X-net technique, which we've mastered. I think 3 of us are doing now. This works phenomenally well. Now we've started with foldable IOLs 3-piece, wherein we need not extend the incision also in these patients, and we put. So this is the data what we have in the past 8.5, 9 years, wherein we've done more than 490 cases, and the pre-op visual acuity has improved from in these numbers. And this is the most important thing. We've had spherical errors of 0.5 and cylindrical errors of 1 diopters as a whole, as of now. And intraoperative complications have been minimal. More of the complications were in the initial phase. We've not had, even touch wood, one patient of retinal detachment post glued IOLs in our series. So this I may attribute to the complete vitrectomy what we do in these cases. Thank you.
Thanks, Dr. Rahul. That was nice. So we'll come on to our third option, which is the retrofixated iris claw, which is also very popular, and how Rohan will make a case for that.
Thank you. Thank you so much, sir. Thank you for the opportunity. So intraoperative zonular dialysis, 5 clock hours. The previous two speakers have very well made their case for the choice of technique. The only thing that I would say is that they've gone all guns blazing completely in both the procedures. They've just marched into the patient's eye, cut all the sclera out, and then, you know, even in the first case, you put a CTR, you don't know whether that CTR will go into the right place or not. So I'm going to be making a case for iris claw, and you see how beautiful this eye still looks post-operatively. The enclavation sites are marked out over there, and you can barely make out whether it is an iris claw lens or it is, you know, any other normal lens in the bag. Here again, there is just because it is dilated, we can see the loops there, but look at the enclavation site there. There is absolutely no trauma that has been caused to the eye. Another example of the same. This is a video that actually I borrowed from Dr. Deepak Meghur, and here he actually shows us how well you know, it is easy for us to implant an iris claw lens in any situation. You see that line that is marked out over there, the arrow. So you see the notch that is there. If you put the your forceps in line with that notch, it becomes extremely easy for one to put this iris claw lens in the eye. You see where that arrow is pointing off the forceps, and just at that side, you know that that is the place where the notch is. And there is hardly, you know, any much of invasiveness in this technique. Same you can do on the other side. You hold it, you see that the notch is in line with the forceps where you're holding it. And then once you enclave it, it becomes very easy to do. Then again, this is another case showing the same. You will hold it right in the center where the notch is. And once you've held it in the center, you know where my notch is going to be, and it becomes easy to enclave it on both sides. So what happens here is that your invasiveness becomes much lesser. You're not touching the sclera at all. You're going through your main incision, and the lens sticks where it is. We can see in postoperative OCTs, the lens is exactly where you left it, even in a dilated pupil there. Long term, we have a lot of studies showing follow-up of retropupillary iris claw intraocular lenses. And all these studies show, in fact, this is a 4-year study, all these studies show great visual acuity as well as placement of the lens, which is completely central in iris claw lenses. Cost, of course, it is the most economic lens to use. Long-term surgical outcomes of the primary retrofixated iris claw lens also for the treatment of intraocular dislocations, again reported in the scientific report, shows a great show. So the thing is to keep it simple rather than going all guns blazing, cutting all the sclera, putting in CTRs, taking out CTRs, putting a suture with the CTS. Just keep it simple, go straight through. Life is really simple, but we insist on making it complicated. Thank you.
So well done. I think all speakers have done a great job. I'll take comments from Dr. Rajendra Prasad, sir. What does he like to do and what is he convinced with? A very brief one, sir, and then.
See, both these speakers, they spoke very well, and they put forward their own situation and their preferences. But what I think is retro iris fixation is the simplest one, as he has told. It's less traumatic and more result-oriented kind of technique. So that would be my choice.
Anything from Rajesh? Rajesh also does a lot of
blue dials.
See, it was an intraoperative dialysis and 5 clock hours. If we can maintain 2 chambers in the eye, that is preferable because the risk of CME, etc. is more. So if we can manage with a CTS and CTR, and it's not a progressive zonulopathy, it's a one-time trauma. So it's not a progressive zonulopathy. So if we can maintain 2 chambers, that is always better. If it is not possible, then we have the options of blue dial and all these techniques.
Also, I think what works best in your hands. That's another thing which I think might have.
I think there will be other factors as well. What is the status of iris, for example? You're dealing with a trauma case. How was that dealt? Do you have enough iris? Is the pupil round? I think many other factors would come in. I think it's simplistic, but there'll be many factors that may determine. And as far as possible, most of us anterior segment people would not like to refer patients to a retina colleague if we can avoid it.
I would agree, but still I would say if we have the facility, I am privileged to have that. So if we have the facility, it is always better. Long-term results, I think in next year, you will see we've done the maximum iris claw also. But still I'm not convinced, even with so many anterior segment people doing it. So Abhijay has done a lot.
Yes, Prashant?
Yeah, for me as a trained vitreoretinal surgeon also doing phacos in all these complex cases, it's usually a balance. Whenever you get an opportunity, maintaining like Dr. Rajesh said, maintaining a bag and putting a lens is an ideal thing. You will have a less inflamed eye forever, for good. That's for sure. Whether you tuck it in the sclera or you tuck it onto the iris, it is bound to have some tissue inflammation because you're pinching upon something. So having it in the physiological place is the right way. But you should not be going for ideal. It should be wherever you feel that it is not compromised, it is getting compromised. Doing an anterior vitrectomy adequately also is important step to have a good stability of all these things.
I think the fact that you didn't have any RD was obviously because you are a retina surgeon. So what is the risk of RD in the iris fixated lenses if you are not a retinal surgeon?
Ma'am, in like the amount that I have done, I'm not encountered any as of now. I've done close to about 60 cases of iris claw, not even one. I've had any encounter of RD in these cases.
Dr. Rahul, because they do
So-
one of the
so,
largest
sir,
volume of
as
vitreofixated,
sir
and yet if there
rightly-
is a retina detachment coming up, you would have seen it.
So
right?
as sir rightly mentioned, there are situations where we're not able to do a glued IOL in all the patients. So doing a very good anterior vitrectomy, yes, helps. But yes, a good vitrectomy for sure is warranted when you have had a complication or trauma patients like this. Even in a CTR patient, you need to have a very good vitrectomy in these patients.
So I think that sums it up. Good management is what is the key in whichever way you can, right? So we'll quickly go on to the next situation, and that's chronic ACG on 2 drugs with early cataract. And what would you like to do? We have 3 speakers, 3 minutes each. First goes Dr. Rajendra Prasad sir, and he's going to make a case for Phacotrap.
Can I make just one comment?
Yes, sir, please. Sorry.
I think since morning I've been observing very interesting presentations, discussions. At your level of discussion, this is the upper crust cataract surgeons, it looks like discussing among each other. Are there any trainees in the audience? Are we losing them? Are there any ophthalmologists who don't have access to the kind of infrastructure that you guys have? And are you losing them? Can somebody translate all your discussions into in a way that all of them can gain out of this these discussions? So maybe after each presentation or each session,
we can sum up.
There is something to the trainees and ophthalmologists who are not privileged to have the infrastructure that
I agree completely. I think we should be cognizant of that. And I know my decisions in Delhi are different when I operate in a secondary center, which may not have backups. So my clinical decisions, my surgical decisions are different in different perspectives. So you're absolutely right. I think we need to be cognizant of that.
In fact, that's why I said, what works best in your hands at that time, in fact, probably is the key, because as a trainee, you will probably know your limitations. And yes, it's nice to see all the big presentations that we see, but absolutely well said, sir, and we'll keep track of that.
Also, I don't know why you are so worried about iris claw lenses. We did so many of those in 70s.
Yeah.
We didn't have any big problems.
It's true. I personally do all 3 actually, and I'm quite happy with all 3 of them, depending on where you... Yeah. So we'll go on to chronic ACG on 2 drugs with early cataract. I'll request also Dr. Kirti Singh ma'am to come up on stage here for the next one. Phacotrap is what Dr. Rajendra Prasad wants to propose, and Dr. Kirti will be talking on trabeculectomy first, even though she might have, reservations. And cataract surgery only first will be by Dr. Tushar Grover. He wants to do only the cataract surgery first. So there goes.
So we all know that glaucoma and cataract often coexist, and we come across in our clinical practice. There are different options to deal with this situation, but you have to be guided with the goals in your mind, what actually you are looking for in that particular case. So this is a case of chronic angle closure glaucoma with IOP, which is controlled on 2 drugs with visually significant cataract. So we have various options. The options are like cataract surgery alone, combined cataract and glaucoma surgery, 2-stage glaucoma surgery first, and then the cataract surgery. But we have to keep in our mind that whatever procedure we are doing, the procedure should be devoid of IOP spike. It should be maintaining post-operative IOP control, so that should be in our mind. It should be without medication, the IOP control after the surgery, without any further surgical intervention. Early visual recovery is another important point from the patient's point of view. You should be enable post-operative diagnostic tests, especially in terms of the glaucoma testing should be possible after the surgery. So what I think is phaco trap is the option, the best option in this situation, because if you look at the combined phaco and trap surgery, there are certain advantages. The first one is that it restores vision promptly, because after the surgery, patient will regain the vision, complete vision. Single procedure, so more convenient for the patient's point of view. It facilitates post-operative assessment of the optic nerve and visual field testing, because you have removed the cataract. It decreases the glaucoma medication. It can lower the IOP early post-op, and better long-term IOP control than the phaco alone. And the best part is, like, you do not get the IOP spike. So you can choose the sites, 1 site or 2 sites. There are certain studies which have been done on this subject, and very clearly says that combined surgery has better IOP long-term control than the cataract surgery alone. It has a faster visual rehabilitation, fewer IOP spikes. So this is the important point we have to keep in mind, because any surgery what we are doing, whether the phaco or trap, the IOP spike should not happen in these cases. It should be left with a less post-operative medication. Cataract surgery alone is a very short-term plan, because if you are planning cataract surgery alone, it's a short-term from the patient's point of view and the surgeon's point of view also, because early post-op IOP elevation is a problem with the cataract surgery alone. Reduced long-term IOP control compared to the combined surgery is much less. If conjunctiva is violated during the cataract surgery, your glaucoma surgery success will be compromised later on. On the other hand, the 2-stage glaucoma and cataract surgery, the trap first, it's an uncomprehending long-term plan. And this should never be taken up, because if you look at the trap first, you have 2 stages, because you are subjecting patient for the 2 surgery, a long-term delay in recovery. Loss of IOP control after the cataract surgery is quite often noted and reported. Cataract surgery in the presence of the blood is more challenging. You get into a lot of complications, and these are the factors which may affect the result of the cataract surgery if you do the trap first. And the most important is the post-operative bleb failure is the most important problem which comes across if you do the trap first and then the cataract surgery. So from my point of view, phaco trap is the choice in this situation, and this should work the best. Thank you.
Thanks. Thank you so much, sir. And now we'll quickly go on to Dr. Kirti Singh for her
At the outset,
comments,
thank you.
and Tushar to take stage.
At the outset, thank you. But both these brothers, Saurav and Gaurav, conned me into this. I just got this 2 days before, and the term used was, ma'am, make it fun. So fun is costly, Dr. Gaurav. I would need 1 minute more to make it fun. So thank you. Angle closure glaucoma controlled in 2 AGMs, mild cataract is the patient given. Always see the disease profile of the patient, of the glaucoma. Look at the patient profile of how they can use the drugs, how irreversible the disease is. Always, always see what patient you are dealing with, so as to decide what surgery to do. And adherence, both voluntary and involuntary, is a problem, because drugs don't work in the patients who take them, and involuntary means inability to put the eye drops correctly. See the patient's profile, their hands, their eyes. knowing that angle closure glaucoma, 25% of diagnosed glaucoma, but causing 50% of glaucoma blindness, is the Jekyll-Hyde. It's the Jekyll of the Hyde, so it is a more dangerous disease. Inference from these facts is surgical option may be needed to exercised early. Which surgery? Trabeclectomy, of course. Why? Time tested, gold standard. Complications and failure? Sure. Which surgery does not? Now comes the fun part. I'm faced with two people who are very good cataract surgeons, so जाऊं कहाँ मैं जाऊं कहाँ. Seeing the human anatomy, crowding of lens vault, and exaggerated lens vault being caused of volcano configuration, and seeing the eagle study which landed the eagle and started about the clear lens extraction, Tushar also landed with the eagle, and he knew that he is a terrific cataract surgeon. So what if you're a good cataract surgeon? See the extent of pass. See that the trabecular dysfunction may still be there. Akal और शक्ल में फर्क होता है. And the role of lens extraction only will be possible if after topical treatment and iodotomy before trabecular damage. How to know that the trabecular meshwork is not damaged? And if lens is not the culprit, if trabecular meshwork still remains dysfunctional and all surgeons are not excellent, don't think cataract is very boli wali surgery. You can cause problems, and जो है वो नहीं है, जो है वो नहीं है, और जो नहीं है वो कैसे हो सकता है? If lens is not the culprit, why take it out? On the other hand, we have that master surgeon who talks about, this is a patient of ours who we had pre and post-operative lens surgery. So why not kill two birds with one stone? Do a called phacotrabeclectomy. But he forgets that phacotrabeclectomy is not as effective in reducing the IOP, and the patient, sir, was mild cataract. And if you deal with mild cataract, like combined surgery may be advocated, लेकिन ज़माने वाले इसको खता कहेंगे, इसको खता कहेंगे. I am innocent, sir. So the conclusion remains. Okay. चेना रास्ता पूछे ना, जाऊं कहाँ मैं, जाऊं कहाँ. What does the audience say? Go with the trap. Thank you. Have I made it fun? A lot of hard work, absolutely.
Great. So after that really nice presentation, we'll have Tushar try to convince us that we should do cataract surgery first.
Thank you. So very, very hard to counter that presentation, but I'll still talk about why cataract surgery alone is the way to go here. So starting with the context here, the context is that this is somebody with chronic angle closure glaucoma, early cataract, and is controlled. That means the target IOP has been achieved with 2 anti-glaucoma drops. So like ma'am did mention, I'm a cataract cornea surgeon here, debating with the giants. So I will try to be the David in this battle. And like this Doordarshan serial points out, whatever I say will be the truth because it is going to be based on published scientific literature. So why cataract surgery alone? You can see in these images, the Scheinflug image as well as the slit lamp image, you can see there is a significant change in the anterior chamber volume, in the anterior chamber depth. So not just is that reducing, but also as you can see, a significant decrease in the intraocular pressure as well, purely after cataract surgery. The Eagle study also ma'am did point out, and you can see that this does say that initial clear lens extraction is a first line. So even clear lens extraction is something with significant evidence as a first line intervention for primary angle closure glaucoma. Here again, this study talks that narrow angles, IOP lowering after cataract surgery is well documented, and they looked at thousands of patients with narrow angles and they found a significant reduction in the intraocular pressures just after cataract surgery. So we know that there is significant lowering happening only after cataract surgery. The IOP is already controlled with 2 anti-glaucoma medications, and so you're going to have a lower need for anti-glaucoma medication after cataract surgery. So my question is, why do we need to do anything else here? Now you will say, why not a trab as well? I mean, what's the harm? But it has been established that the complications, the need for other interventions is significantly higher with the trab. In this particular study, the complications was 46% with trab versus 4% with phacoemulsification. Even here, they talk about higher complications with trab, need for additional interventions, and they conclude that phacoemulsification is not just equally efficacious, but is also, as I said, much safer than doing a trab. So we know that our principles of medical ethics say that the first thing is to do no harm. And any procedure, the benefit must significantly outweigh the risk. So why do a trab when just doing your cataract surgery is doing the job very well? So the takeaway for me is, in chronic angle closure glaucoma, where you have an early cataract, please stay calm and just do the cataract surgery. Thank you.
I think we'll start with comments from Rao sir and then go on to somebody else. So what would you think is, who was able to convince you the most?
I think I'll pass. Let me tell you, Dr. Kirti Singh probably is a darling of our residents.
Go ahead, Prashant, what do you think?
I'm not a glaucoma man. Yeah.
All right, so Umang, would you like to say something?
Well, my question in the first place would be, there's a chronic ACG on 2 drugs and with early cataract. Why do you need to operate? So I would really need to understand why you would need to operate this patient. So if the vision is 6/9, patient is okay, 2 drugs is not bad. If the patient can afford it, follow-ups are okay, I would probably just leave it.
So we often
maybe it needs a PI. Maybe the patient needs a PI and may reduce to 1 drug.
Used. We use the term PSCG. Chronic ACG is not used. 2 anti-glaucoma medications. Which anti-glaucoma medications? Okay. And the first 3 slides were the most important in my talk. What type of patient are you facing? What is the lens vault? What is the synechial closure? So know your patient thoroughly before you jump in and do the chop. Trab is a chop. You leave the patient with a bleb for life with a lot of problems. Cataract is not a dream. And Eagle, I don't agree with at all. None of the glaucoma people agree with Eagle. All of us are 50 plus. Do we go ahead and get our lens extracted? No, we don't. Not even if somebody says that you have synechial closure, I would not get my lens extracted, and I am definitely above 50. So you can't tell the patient to do something which you would not do to yourself. Having said that, see the patient in profile. If the patient is a type who would not, like I showed in my previous lecture, a lady who would not be able to come back, then maybe if it's just 2 drugs and she can't afford the drugs and it is a little advanced glaucoma. Now you said mild cataract with 2 drugs. There I would agree with Dr. Umang. I may not do anything at all, just follow up. But if it was advanced, then maybe I'll do a combined surgery, as you said, because the patient may not come back to me ever. And the cataract does increase after an uncomplicated trabeculectomy. Also, cataract over 5 years would be 70% increase in rate. And once the patient is operated for glaucoma, they think that nothing else has to be done. Just like LASIK you were discussing. So see the patient profile and then.
Of course, yeah, everything has to be kept in perspective. I mean, these are just situations for discussion. Yes.
I think the glaucoma people confuse everybody. About 8 years ago or so, there was a consultative meeting at the World Health Organization in Geneva. They were trying to come up with a public health approach for the care of glaucoma around the world. So 2 days of discussions, the who is who of glaucoma was there. David Friedman, Nathan Congdon, all these people. And then the conclusion was, there is no clear definition of glaucoma to begin with. There is no clear definition of the types of glaucoma. There is no clear definition of what approach to what type of glaucoma treatment. So the WHO gave up and said, we are not going to come up with any guidelines.
Kirti ma'am, your comment now.
So I think we should move on. We are short of time. We have to plan this. This hall is ready for inauguration. So our next speaker, Dr. Rajesh Sinha, and then the debate is on a 23-year-old fashion designer, minus 5.5 diopter sphere with minus 1.5 diopter cylinder, both eyes, and a corneal thickness of 495 microns in both eyes and an AC depth of 2.7 millimeters. And what should we do? So Dr. Rajesh Sinha will speak on, he would like to do contour of him to LASIK, would be the best way to go forward. Dr. Bhupesh can take stage on the other side and try to convince us about, he would do lenticular extraction with SMILE. And then we'll have Dr. Rohit Shetty trying to make the case for advanced surface aquilation or trans-PRK will be the safest. So let's go on.
Thanks, Gaurav. I'm not here to promote a particular procedure, but we will just be discussing science, and based on evidence, whatever comes out, we'll accept that. So this is a 23-year-old fashion designer. So this patient requires a fast visual recovery with minimal or negligible aberrations. So let's see whether contour LASIK is a good choice. So let's talk about some studies, and based on which we will have the evidence. So let's talk about visual outcome. This is a study done by one of our big giants in LASIK, Kanalopoulos, and he did this study and he reported that they compared LASIK versus SMILE and said that the quantity of vision was comparable, but LASIK was faster than SMILE. Second, SMILE can have 6/6 vision on day one, but lesser in number, in less number of patients. It takes a little bit of time to come to 6/6 or 6/5. The wow factor is better with LASIK, and this comparative study by Kanalopoulos described better visual performance in eyes that underwent topo-guided LASIK at 3 months and 12 months than in eyes who were treated with SMILE for myopia and myopic astigmatism. Another multicentric study, and this was SMILE versus earliest and latest generation of LASIK, and they reported that SMILE is faring better than earlier generation LASIK, but recent generation topo-guided LASIK fares better than SMILE. Visual recovery in SMILE takes longer time. This is another study which states, and the uncorrected visual acuity on day one is slightly lesser in SMILE than in comparison with LASIK, and particularly topo-guided LASIK. LASIK is a SMILE is a flapless procedure. So that's why many people say that, there are thinkings, and people think that the biomechanical strength in an eye which has undergone SMILE will be more. And based on that concept only, a lot of studies were done, and they found out that the biomechanical strength was comparable. All these studies are major studies which have reported that biomechanical strength after LASIK and SMILE are comparable. The amount of ablation that is required in a Contura or a topo-guided LASIK is much lesser than the amount of tissue for 1 diopter of correction in SMILE. That also is a reason, it's a tissue sparing procedure which we would all like to have. As far as patient comfort is concerned, this is one study which states that the patients felt more comfortable while lifting the flap than while tissue dissection while SMILE was done. So that is again an evidence that LASIK was better than SMILE. As far as complication is concerned, the flap-related complication don't happen rare in femto-LASIK. Ectasia has also been reported in LASIK as well as in SMILE, and other complications can also happen. Dry eye is something which is because of less denervation in SMILE, dry eye is lesser at 1 month after the procedure, but at 6 months it is comparable. And even if it's slightly better in terms of dry eye, I think most of the refractive surgeons, they prescribe lubricants post-LASIK as well as post-SMILE. So there's hardly any difference as far as the post-op management is concerned. As far as higher order aberrations are concerned, this is one study which has shown that large percentage of patients, when they underwent topo-guided LASIK, the higher order aberrations were much lesser than SMILE. So this was a comparative study between topo-guided LASIK and SMILE in terms of higher order aberrations. So the status of SMILE in comparison to topo-guided LASIK will be that biomechanical strength is comparable, visual rehabilitation is faster in topo-guided LASIK, the aberrations are lesser, and there's more, SMILE is more technically challenging. Cost is lesser in, and as far as PRK is concerned, LASIK versus PRK, LASIK is less painful and faster visual rehabilitation is done. And haze is also not present in LASIK, it is more often seen in PRK. This is post-PRK corneal haze. And so in summary, we have better correction of cornea-based aberration with topo-guided LASIK. Day one wow effect is there. Surgeons' choice is also there. More surgeons, they do LASIK. Faster and painless visual recovery is seen. There's no risk of haze. And if there's any fault in correction, you have to do a topo-guided correction. So why don't we do it first? So based on that, I would conclude that topo-guided LASIK appears to have an edge over SMILE and PRK in this particular scenario and in present times. Thank you.
Thank you, Rajesh. Let's go on. Bhupesh,
So good afternoon, everyone. So I'll be speaking in favor of SMILE. And so this was a patient, and we are doing the SMILE for this case. As she was a 23-year-old young lady, fashion designer, so she has to be on the computers full day. Yeah. so let's. So the first of all, decision should be made on the facts objectively concerned. So let's see what are the facts. So these are the parameters that we have to look for, and the range of treatment in SMILE is up to -10 diopters, astigmatism up to -5 diopters. So definitely this patient comes for SMILE in this zone. So no problem with the refractive error. The concern is a CCT, that is a thinness pachymetry. So let's see this study. This study has done in the patient in which the CCT was less than 400 micron, and they found that if your residual stomal bed is more than 275, you are in a safe zone, no chances of ectasia. So we did the calculation on the machine. The machine was showing RSB as 265 in this case. So what we did, from the cap thickness, we changed from 120 to 110, and the lenticular thickness at the edge, we make it 15 from 20. And the next parameter was 280. So we are well in a safe zone. So safe zone, safe parameters for refraction, so there is no problem with the SMILE correction. Let's see about the other advantages of the SMILE over the other procedures. If we compare with the LASIK, almost all studies have shown that SMILE is way far away better than LASIK, and it doesn't take 1 month, it takes 3 to 6 months for the complete renervation of the corneal nerves after the surgery. So other parameters are corneal biomechanics. So safety is most important for all the treatment. So corneal biomechanics wise, so SMILE does much better than LASIK in all cases, and all the studies have shown the same results. The third one is a corneal haze. Although PRKs came back with the mitomycin C with a good result, but still this is a recent study published in IGO, and they have shown that almost 16% patient had trace haze at 6 months, and 5 patients had grade 1 haze and 1 patient had grade 2 haze. So you don't know which patient land up in this one patient. So it's better to save than sorry. So I think SMILE is the choice for me, and thank you.
Thanks, Dr. Bhupesh. And now I'll invite Dr. Rohit Shetty to talk on one of his favorite subjects, and he wants to make the case for trans PRK will be the safest.
Day 2 है this one. So my
when we look at what we are really discussing today, we're discussing about somebody who is young and who has a very thin corneas. So let's start working around this part. So there was a lot of discussion between these two, but ultimately, you know, the only thing which has stood the test of time has been PRK. In spite of my biggest financial disclosure is that I was part of all the 4 major lenticule machines today except SEMA. So still PRK seems to be the best. The first question we need to ask is this is a thin cornea. This is not a thick one. This has got a higher cylinder. And what we don't know, has not been mentioned, is the strength and the status of ocular surface. The cylinder and the thickness less than 500 is always a red flag, and this is the take-home point as a teaching for everybody. So when we did this work, this is a very important work. We have built a collagen imager which looks at the collagen properties. Most of the thin corneas less than 500, the collagen does not exist. This is how a collagen would exist. This is how a collagen would, when you see that. And when you do any refractive surgeries on these kind of collagen, you can see that blue areas are the disruption. Smile is less, but the PRK is exactly the same, mirror image of what it was pre-op. Just shows how stable these procedures are. Very few reported literature on ectasias. The biomechanical strength, I think Bhupesh did pick up, but this was published, one of the major simulation work. The PRK and LASIK, PRK and the simulation was exactly the same compared to the SMILE and LASIK, which just shows that it does not change at all. The outcomes, if you can cherry pick either way. You can pick something which is bad, you can always pick up something which is good. That is the power of PubMed today. Dryness, there's no real meta-analysis paper which says which is better. At this point of time, you can still compare between the two, but I feel that there is, depending on the kind of machines, you still have a better dryness effect on this. I still feel it's more forgiving on an ocular surface. So even though we have discussed about different things, SMILE may be less invasive, you may have a scarring. What I'm saying is, I've not published this, but we have published 2-3 reports. SMILE, tomorrow I'm going to talk about it. SMILE is the most unforgiving when it comes to an ectasia. Even if you make a 1% mistake, you will get ectasia, not 1 year later. By 5 years, what you missed by mistake or by image which not picked up, you will develop ectasia, unlike LASIK. And that's something which you'll have to keep in mind. So based on these factors, I still feel a thickness less than 500, the cylinders being high, an ocular surface not being clear, and like he mentioned, he may be a gender, male or female, but maybe working long hours. It is best, and knowing how the thin corneas behave, I think I would prefer PRK over the rest. Thank you.
I think all 3 of them put forward their cases very strongly. The bottom line here is the borderline corneal thickness, which probably goes more in favor of a PRK over the others. Day 1 wow factor is, it shouldn't happen that it lasts only for the first few days and then you end up having issues subsequently. So safety is something that we need to take into consideration. The same thing, if the corneal thickness would have been a little more, probably yes, I mean we would have had all the options open, but the key thing here was the corneal thickness. And when you make this decision, now that you know each one of you put your case forward so well, would you be discussing the pros and cons of all the 3 procedures with the patient, or would you be deciding for the patient, or would you let the patient take the decision after you have discussed everything with the patient? I mean, that's, I think, a big question that we all need to answer. Any other comments?
I would agree. I think where I would fault the first 2 speakers is they did not mention the corneal thickness at all. It was a specific case. We were not discussing SMILE versus LASIK or PRK. I think it was a relatively thin cornea, and that's what's causing.
And the cylinder.
And the cylinder. That's.
I was not sure whether you mentioned the axis of the cylinder. Yeah, because if it's not the orthogonal one, then even if it's a challenge.
But still, 500 is a red flag.
Rohit, my only question to you is, PRK would, I think, become a go-to procedure for all, but for that unpredictability of that haze. When it comes, it can come in fractional of patients, but when it comes, that can be tricky. That is the biggest problem.
So that happens, sir. That happens with your cataract. That happens with LASIK. That happens with everything. Of course, when large number are used, the statistics hides everything. But there are challenges with all of them, and especially when you use the new technologies. It's just that if you are using something and you are very good with it, then you'll find every factor to tame the factors which will give you the outcome. So when you use PRK as one of the many things in between multiple things, then you just don't care.
So,
thank you.
Sir, any final comment from you, sir? Okay. So we'll quickly go on, and we'll have to finish off this next one within the stipulated time. I'll invite Dr. Ritu Arora, please. She's going to make a case for trifocal IOLs. The case situation is your father-in-law, a practicing lawyer, needs cataract surgery, healthy cornea and retina, no significant refractive error, no comorbidities. What will you do? So we are trying to decide between a trifocal IOL, and we're trying to not only make a case but also discuss the pros and cons and how you will decide whether to use one or the other. And Dr. Kumar will be speaking on EDOF or enhanced monofocal lenses with micro monovision. And then Dr. Bhalla is going to make the case for monofocals with monovision. And I know that Dr. Satanshu is looking at me, trying to tell me to finish the session fast. So we'll stick to our times. So I'll read out the case again while she prepares. Your father-in-law, a practicing lawyer, needs cataract surgery, and healthy cornea and retina, no significant refractive error, and no comorbidities, and there goes.
A very good evening to one and all, and thank you, Gaurav, for including me in this very interesting session. So he's clearly told what has to be done. It's a situation where nothing but the best will do. At the outside, I'd like to make the disclaimer that I have operated my father, my grandfather, my grandmother, and all my relatives, but except my father-in-law. So it's not just anyone, it's your father-in-law. He's a practicing lawyer, so he's a highly educated, and he's a person who's still active at quite a late age in life. He's got healthy eyes, that's a plus point. He does minimal night driving at this age, but he's also demanding, and he's a type A personality. So the situation is not easy for me. What are my options? Do I go with a monofocal with monovision? He's already done his study. He doesn't want to wear glasses and look even older. Do I go for an EDOF and give him a compromised vision of just distance and intermediate when majority of his work is near related? No way. I would go for trifocal, which gives you a distance, intermediate, and near vision, and almost 100% spectacle independence. My worthy opponents will try to, convince you for a monofocal, will convince you for an EDOF, but they fall way by the side. When you see this curve, which compares the trifocals with monofocals at EDOFs, and you can see very clearly how the trifocal lens scores way above the others. So you know that the intermediate and near vision is so important in our daily life, and my choice would be not just any trifocal, but the Panoptics. It gives you excellent vision, excellent quality of vision for near, intermediate, and distance. It's a unique lens. It has a diffractive design with the Enlightened technology, which gives you an exceptionally high light utilization. It gives a crisp quality of vision, no blurring like EDOFs do, no waxy vision. And you get a clear vision at all distances. So it's more comfortable, it has less dependence on pupil size, and we know in our Indian population the pupil size is small, so the patient also doesn't suffer much from dysphotopsias. And also moreover, he's not going to be driving at night, and cataract patients are already used to some amount of dysphotopsia. So light utilization matters, and it's the Panoptics which gives you 88% light utilization and excellent transmittance, excellent contrast sensitivity and quality of vision. So many studies have been done. I'm not, because of lack of time, not going to show, but all of them do show that trifocals work extremely well and score above the EDOFs and monofocals. The drawbacks, you may say, glares and halos. I think that's a myth. Most of my patients are very comfortable. We hardly ever have patients who complain of glares and halos, and this study very well shows. You know, it's comparing the actress of Panoptics along with the Synergy and Symphony. That Panoptics scores 73% distance, intermediate and near vision, whereas Synergy and Symphony both are way behind. And all of them show halos, but the Synergy in fact showed more halos as compared to the Panoptics and Symphony. There's a high level of acceptance. 99.2% patients would like the same kind of lens implanted. So I would say, yahi hai right choice. This is your life. You want best vision, you want a physiological vision at near distance and intermediate, and it's only a trifocal, and I would say a Panoptics, which gives you all of that. Thank you.
Thanks, Ritu, and very nicely put. So, Kumar, let's see what your take is.
Actually, I don't think I need to talk because she's already confessed that she's not operated a father-in-law, and you heard her talk for 3 minutes where she confessed why you should not put a trifocal. Well, father-in-law is a lawyer, so I have only one father-in-law. Okay, and why take panga and create panga at home? You know, because you're going to face him regularly. So we all understand that high quality of vision is 20 by 20. It's not only simple as that. And we also know that trifocals has got glare, whatever you may say, yes or no, whether the person perceives, not perceives, whatever way you put your question, the reality is the truth. Again, if there's capsular phimosis and you have a multifocal or a trifocal and it decenters, again you are having a problem. So you have a decentered trifocal, again the patient is going to be very unhappy. So my own choice would be, even for my eye or my father-in-law, would be an advanced EDOF lens. Big advantage, no rings. Friends, I've implanted many such lenses, and not a single patient has complained of rings. There are no zones. It's a single piece, so there is no learning curve. Okay, so there's nothing to learn about how to implant this IOL. Of course, it's aspheric, so good distance quality vision. Improved intermediate if you do micro mono vision. Because there are no rings, there is no dysphotopsia. Of course, corrected spherical aberration is essential to zero, so sharp quality of vision. And the material is a high Abbe number, low chromatic aberration, which gives much better contrast, just like a monofocal. So there's no loss of contrast, there's no light scatter, and the patient is extremely happy. In my own experience, I've done more than 500 in last year. I've used torics, I've used normal, and excellent 6:9 vision for distance. Only some patients may need, but I do micro mono vision now, and the reading also becomes N10. Yes, I agree that the patient or the lawyer will need little number for reading. Just to tell you, I want to show you the quality of the lens that we are implanting under a very high magnification, and you will see that now. So this is the lens that we are going to implant. Just watch this quality of lens. Perfect optic-haptic junction, perfect square edge all around. You can't see any ring at a magnification highest on a microscope. So patient is never going to complain of glare and halos. And that's the main reason why these patients are extremely happy. And this is the quality of the lens. Even on the anterior surface under high magnification, you don't see anything at all. And the implantation technique is very easy. Just put it in the cartridge through a 2.2 millimeter incision. The lens goes into the bag. Summary is, who wants night driving problems? Who wants loss of contrast? Complementary glare and halos, yes. Starburst, if it decenters, you have to explant and re-implant. Bad luck, your father-in-law moves the eye at the same time, and at the same time you have a problem. So friends, I don't think there is any confusion. I think it's completely sorted. If he's a lawyer, what will he need glasses for? Okay, movies on iPad, no glasses. Looking at the mobile, no glasses. Reading emails, no glasses. Reading WhatsApp, no glasses. Photography or any other hobby that he has got, no glasses. Seeing the table, you know, lawyers look at the computer, they look at the reading pad and they look at the screen, they won't need glasses. So willing to wear glasses to read the stock exchange price if necessary. If he reads the paper for half an hour, he will need little bit of glasses. I don't think it's an upset situation. So I think advanced monofocal or EDOFs are the way to go. Thank you for your attention.
Thanks Kumar for that nice talk. And now the last talk for this debate session is by Dr. J.S. Bhalla, sir, and he's going to speak on monofocals with monovision. He's going to make the case for that.
Yeah.
Thank you. I think my job has been made easier by my two worthy opponents. Dr. Kumar has already tackled very nicely the problems faced with trifocals, and Dr. Ritu has already told the problems with enhanced monofocals. I think so. What happens is, I think my thing is very clear. They have not opposed monovision with monofocals with monovision at all. So one thing I want to say is, everything recent is not an advancement, although we use the term recent advances, and everything costly need not be the best. So I'll go with something which is very simple and which is possible. We can give spectacle independence by just practicing good quality hydrophobic square edge monofocals, and we can give monovision to these patients. So as we all know, it can be done, this pseudophakic presbyopic correction can be done with EDOF, with the trifocals, but what I'll do is I'll give pseudophakic monovision induced by monofocal IOLs. So what are the different activities my father-in-law, just remember two things. There are two catchwords in this situation. He's father-in-law and he's a practicing lawyer. I don't want my in-law to become outlaw. So what I have to do is give him something which is safe, which is clear, and which gives him spectacle independence without any problems which he has heard of or imagined. And these are the various distance activities which he'll be doing. Yes, why I should imagine that he will not be driving just because his son-in-law has operated on him? Yes, he will do intermediate activities like looking on computer. He really likes to see Netflix. And near activities, yes, he'll do all of these activities. So, and he wants crisp and clear vision which is not compromised, with excellent contrast sensitivity right from N5 to J6. So EDOF lenses, we know the basic principle is, it is to create a single elongated focal point to enhance the depth of focus, versus monofocal IOLs in which light is focused on just one single point. So, and trifocal lenses, yes, Dr. Ritu did point out that it transmits 88% of the light to retina at a simulated 3 mm pupil size. But what my question to her is, why not have a lens which gives you 100% transmission of light? Why sacrifice that 12% light? He's not done anything wrong for me to take away that percentage of light from him, his sight of vision. So there are different types of monovision which we should be aware of. There is conventional monovision where dominant eye is corrected for distance and recessive one for the near vision. Then there is micro monovision. So what I'll do is that we all know that most of the humans do have a dominant eye which gives greater clarity during binocular vision, and monovision patients can see clearly at all distances due to interocular suppression of an isometropic blur, and suppression is more efficient for larger compared to smaller targets and in photopic versus scotopic. So this is conventional monovision, and it has been published by Shimizu et al. In his publication, where they said that as the age increases, satisfaction level also increases. 60 to 70 years, 87% satisfaction rate, and more than 70, it is almost 94% satisfaction rate. And I've checked his pupil diameter also, which my opponents have not done. It is less than 2.5 millimeter. So if you see that monovision with pupil diameters of less than 2.5 millimeter, it induces pseudo accommodation in these patients. And by monovision, the target refraction is in the dominant eye emetropia and just slight myopia of -1 to -1.5 diopter in the non-dominant eye. And you will find that this method achieves the same positive effects, maintains excellent contrast sensitivity and stereopsis also, and cause less in isometropia, and more than 90% of the patients are satisfied with mild monovision. Then I showed this, just last one. Then I took him to simulator. I said, if you take trifocal and EDOFs, this above is the type of contrast sensitivity you will get. And if I give you monofocal with monovision, this is the contrast sensitivity you will get. His choice was absolutely clear. So I gave him this comparison chart also. Although the cost may be high in the EDOF and trifocal, but what you will get is excellent contrast sensitivity if I give you monofocal. So a lawyer will do anything to win a case. Sometimes he will even tell the truth. But a doctor will always tell the truth, whether the patient is your own father-in-law or your opponent's father-in-law. This is a quote quoted by me. So good lawyer knows the law, but a great lawyer gets operated from his son-in-law. And so what I have done is, just with a least cost, my better half is happy. My father-in-law has given me 10 out of 10, and I felt that I have tamed a tiger. Thank you, everyone.
Thank you so much, Dr. Balla, very nicely. All speakers have done a great job. We have just 30 seconds to summarize. We'll start with Rao sir's comments, and then we come this way and finish.
I know the poor trainees are all confused which lens to use. Is there a message for them?
Gaurav, can I add something? I was a huge proponent of these diffractive lenses till 3 years ago, but I moved my entire practice to enhanced monofocals or EDOFs, and I do a little bit of micro mono also with my monofocals. But I think for the trainees, this message should run through. The era of diffractive lenses probably is it's over. At least personally, I sense that. That's my personal opinion.
Yes, yes. Who's actively working?
In both the eyes. Binocularity is very much important.
So again, I think that has to be on a case-to-case basis. There is no correct answer for this. You have to look at so many other things, and maybe you have to really consider multifocals as for people who do fine surgery and microscopic work. You have to think twice before using a lens like that. It has been the concern for a long, long time. So I don't have an answer which is perfect for that because I think it's still open. But any last comments, Umang?
Well, I think since it's your father-in-law, I think you know the personality well. A lawyer, maybe lawyer. I think it's all to do with what kind of a personality you are. There are people who can live with a little blur, and there are people who go crazy if it's not very sharp. We've seen that with all our LASIK patients and things. I think it all depends on whether you're a very picky person or you're okay, easygoing. You can take your chances there, but I think a lawyer tends to often be very critical, and I would play safe.
I think we are all set. We all have our answers, and thank you so much all the participants and the audience for staying all the way through. We'll have a quick picture and then we'll disperse, and we are getting ready for the inauguration. All the speakers can come over for a final quick photograph.
IT near the swimming pool area, and we will start the inauguration sharp 6 p.m. because we have a gala dinner, fashion show, so we will start sharp 6 p.m. So Gaurav, so take off all of them to high tea. We start sharp 6 p.m. this inauguration. Assemble again at 6 p.m. sharp because we have an important function. So we take only 50 minutes time to assemble all the inauguration. We have inauguration 6 p.m. in the same hall, Hall A. So request all the dignitaries to come back after having high tea at near swimming pool.
check one, hello, 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 check, check one, two, check, hello, hello, check one, check, ठीक है? Hello, hello, check, check one, two, check, hello, hello, ठीक है ना? हेलो चेक वन टू ठीक है हेलो चेक चेक वन चेक हेलो हेलो चेक वन टू चेक
ये हमारे काम नहीं है ये सवाल उठाने जरा यार
मैंने इसका स्क्रीनशॉट है, वही वाला जो हम बचपन में बोलते थे। अगर नहीं होगा तो अपने से कर दूँगी। मेरी पीपीटी नहीं है, वो यहाँ पे चला दो, इस पे है। हाँ ऑन है। अच्छा मामा जी नमस्ते। मामा जी मैं ना एक कॉन्फ्रेंस में हूँ, आपको कॉल करती हूँ। इनॉग्रेशन कराया है जी। दोनों सेम है, सेम है।
we can start.
हाँ जी सर, ये सीक्वेंस ठीक है। नंबर 3 नहीं है सर। सर आपके बाद है।
ऐसा करो, उल्टा कर दूंगा, इन्होंने सेक्रेटरी, मैं आज सेक्रेटरी, मैं उधर बैठ जाऊंगा।
अच्छा।
मैं यहाँ बैठ जाऊंगा उधर के पास, ठीक है? तो उसके बाद ऐसा करना, सेक्रेटरी यहाँ बैठ जाएगा, उसके बाद चेयरमैन यहाँ बैठ जाएगा,
चेयरमैन ही हो जाएगा,
उसके बाद सेक्रेटरी यूके मैं बैठ जाऊंगा,
आप आ जाएंगे,
उसके बाद चेयरमैन स्टैंडिंग कमेटी सौरभ उधर किनारे बैठाएंगे, फिर इनकमिंग प्रेसिडेंट यूके सब मैं कर लूँगा।
ठीक, मैं बोलती हूँ। Good evening, ladies and gentlemen. I, Dr. Amrita Chauhan, on behalf of Uttarakhand State Ophthalmological Society, invite you all in the inauguration ceremony of Uttara Eyecon 2023 in the Corbett City, Ramnagar, Uttarakhand. I welcome you all here. And now, it's an honor to invite the esteemed dignitaries in the dais. I invite the organizing secretary, Dr. Ashok Garg sir, on the dais. Please, sir. Now I invite esteemed organizing chairman, Dr. Mayank Pankti sir, to grace the dais. Please, sir.
Next.
Now I invite Secretary UKSOS, Dr. Satanshu Mathur sir. Further, I invite esteemed Chairman, Scientific UKSOS, Dr. Saurabh Luthra sir. And now may I invite the incoming President UKSOS, Dr. Vinod Arora sir, on the dais. Thank you, sir. And now I invite President Dr. Sanjeev Mittal sir on the dais, please, sir. Thank you, sir. Now I invite our chief guest, Dr. G.N. Rao sir, to please embrace the dais. Thank you, sir.
जलाने के लिए जलाने बुके 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 बेटा बुके लाओ ना तुम लोग बोलो बोलो बोलो
And now
उधर से लाओ नीचे से लाओ सब उधर से लाओ
I request to present a bouquet to Dr. Ashok Garg sir.
हाथ में ले जाओ हाथ में ले जाओ
Dr. Mayank Pankti sir. Secretary UKSOS, Dr. Satanshu Mathur sir.
नीचे से जल्दी जाओ ना
Chairman, Scientific UKSOS, Dr. Saurabh Luthra sir. Incoming President UKSOS, Dr. Vinod Arora sir. President, Dr. Sanjeev Mittal sir. And our chief guest, Dr. G.N. Rao, sir. So now we'll commence the inaugural ceremony by the lamp lighting. For that, I invite all our dignitaries on the dais to please come and do the ceremonial lamp lighting. Thank you to all the dignitaries. Now this will be followed by Saraswati Vandana. Can you please?
Okay, done.
Done. It was done, thank you. Now I invite our organizing chairman, Dr. Mayank Pangti, sir. Mayank Pangti, sir.
Thank you all dignitaries in the dais as well as the delegates. We welcome you on to Uttara Eyecon 2023 at this beautiful resort. Hope we will have a good memorable memories from here. Thank you.
Now I invite Dr. Satanshu Mathu, sir, to please come on the dais.
Thank you, Dr. Amrita. A warm welcome to all of you from different corners of India who are representing their states, their cities. On behalf of Optical Society, UKSS and LQS, I am delighted to welcome you all. We have tried our best to do the best, but still there may be lacunas which you should not point it to us. We will try to improve ourselves. So I am thankful to my president Sanjeev Mittal. He is my old friend. His wholehearted support due to which I could work freely. He always supported and gave me the valuable suggestions time to time. And I welcome along with it our new president Vinod Arora and promise in full support of executive because I have to continue next year with him also. Scientific Committee Chairman Saral Uttara, you all have seen yesterday and today that he has done a program covering all subspecialties in ophthalmology. Guest faculty from all over India is participating in meeting along with host faculties. MCI Uttarakhand has allotted us 12 hearing hours, which is very important nowadays for our day-to-day collections of the MCI hours. Gaurav is not visible here, but really Gaurav and me are working for last 20 years for the society, hand to hand. And without each other, without each other's support, we cannot do any conference in Uttarakhand. We have planned full-day life surgery from premium ICU all over India. Surgeons of approved will be sharing their surgical skill with delegates. He needs special appreciation for this. For last 1 month, he was busy because that you know all the controversy about the life surgery going on anywhere else. So we have a hard time this time in organizing the life surgery. He has mastery in organizing life surgery, so he could do it despite all odds. Amit Singh, our treasurer, is not here again. He has been very liberal in granting us money for the organizing the conference, but only after getting fully satisfied and complete paperwork. This is very important for the treasurer. Dr. Anupam is here. She is a professor in AIMS Rishikesh, Editor General. has done phenomenal work in last few years to improve the quality of the journal. Under her supervision, we are trying our best to get our journal index. Despite very small society, we'll try our best to achieve this index next year. Local organizing committee, Ma'am Pankti, Ashok Gar, Vijay Joshi, Kanika. Shanika is there, busy in fashion show. You will see her in the banquet. Working hard for many months to make this conference memorable. Seeing their enthusiasm and zeal, I have no doubt this conference is going to be the most successful conference in history of the UQSS. I believe you will enjoy warm hospitality of LSE. A special mention to Ashok Garg. I will allow you all to applaud for the Ashok Garg because this is a single man show. His dedication, hard working, he planned things in advance. I am surprised. He has everything writing. When I asked him what, he gave me the proof. This is the thing. What the dignitaries, how many food, how many plate in the lunch, drink, is everything ready already. And really, he do the perfect execution. Ashok, I will miss talking to you daily for hours. Morning, I get the first call from him in the morning, and when I go to sleep, the last call with him. So we will miss each other after this conference. I am thankful to UQS executive, members of UQSS for giving me support. Last but not least, I am thankful to trade partners for actively participating in scientific activities. All the trade partners, really we are thankful to you. Without your support, we could not have achieved this success. We are thankful to media for their support also. I wish you all a comfortable stay in the Corbett and safe journey back tomorrow, with all the memories which you will cherish for a long time. Thank you very much.
Thank you, sir.
Anupam, call Anupam.
Now I invite Chairman Scientific Committee, Dr. Release of General UKSOS, Dr. Anupam.
Gaurav, you are sitting here? Gaurav? Okay, better. We are talking long time, you are not here. Sir, General standing.
Congratulations, Dr. Anupam.
We congratulate Anupam. General will be distributed to distribute करने के लिए 100. So we'll distribute the general in the okay. We are already distributed. We wish you good luck to get general index by the next year before your tenure is over.
And now, may I have the honor to invite Chairman Scientific Committee, Dr. Saurabh Luthra, sir.
सारे उनसे मत दिलाना विचारों से आगे ऑडियंस बड़े-बड़े दिलाओ गोल्ड मेडल दिला दो फ्री पेपर जो है वो प्रेसिडेंट दे देगा तुम्हारा ठीक है
Good evening, everyone. It's my pleasant duty to welcome you all and announce some awards. And before that, I would like to thank all the faculty and all the delegates and all the judges, all the chairpersons, panelists for bearing with all the requests that I made and helping me out put this program. And I would fail in my duty to if I don't thank my predecessors, Dr. Gaurav Luthra, Dr. Satanshu Mathur sir, Dr. Vinod Arora sir, for helping me out put this program. And I would request our distinguished guest of honor, Chief guest, sorry, Dr. Rao sir, to please hand over the awards for the last year Uttara Eyecon 2023. Dr. MC Luthra Gold Medal for Best Free Paper 2022 goes to Dr. Anshika Luthra. Okay, so I'll go on to the next, the session awards. Go to Dr. Palak Jain. Dr. Shweta Parekh is here. Yeah. And Dr. Priya Sharma, Dr. Roshni Robert, and Dr. Meenal Patil.
Whoever here from last year?
Yeah, could you please come forwards and collect your certificate for best paper of the session. Go ahead. हाँ अभी नहीं
चलो वेट अंशिका आ रही है जल्दी आइए और अवार्ड बुला एक साथ ही देखेंगे सारे
For Dr. Satanshu Mathur, Best Video, Dr. Sonal Bangwal.
Best Video Award.
Yes, Dr. Satanshu Mathur, Best Video Award for 2022 goes to Dr. Sonal Bangwal. Dr. A.K. Mehrotra, Best Poster Award goes to Dr. Srishti Sharma.
Poster.
The 2 minutes to win award goes to Dr. B.P. Kashyap. I think he's not here. The Dr. R.N. Singh Young Achiever Award was shared by Dr. Shweta Parekh and Dr. Arvind Maurya.
Shweta is not here.
No, she's here.
Shweta here. Shweta Parekh. बैठ आगे बैठ
The Best Free Paper Award for last year, Dr. MC Luthra Gold Medal goes to Dr. Anshika Luthra. For 2023, we heard such a beautiful talk in the morning today by none other than Dr. Vishali Gupta, which was a good mix of such lovely paintings and her journey in ocular tuberculosis. So I would request ma'am to please come forward and accept the award for her Dr. C.S. Grover oration for 2023. For Dr. Vinod Arora oration, which is going to be delivered tomorrow, Dr. Geeta K. Iyer from Shankar Netralaya, Chennai, may I please request you to come forwards and accept the award for Dr. Vinod Arora oration. Now I would request Dr. Gaurav Luthra to please come and present the gold medal awards.
So now after the scientific awards, we come to the award committee chairman, Gaurav Luthra, to give the prestigious award of Uttarakhand, that is the gold medal awards. Head over to Gaurav.
वहाँ नहीं चल रहा है
Slides वहाँ move करो. Okay. Gold medal.
So every year, Uttarakhand Ophthalmic Society honors some of the biggest achievers or people who have accomplished themselves in ophthalmology. And this year, we will be giving out 6 UKSS gold medals for excellence in ophthalmology, and the first one goes to none other than Dr. Rohit Shetty, who is a dear friend as well, and is the chairman of the Narayan Netralaya in Bangalore. If I was to present his biodata, it would run into maybe 10-15 pages, but suffice it to say that he's a clinical and translational scientist with one of the best labs. They have one of the highest number of publications out of India. He figures in the top few with over 370 publications and with over 50 international awards. And he has been a professor and a PhD guide for the Maastricht University in Netherlands and has done pioneering work. Congratulations. Our next awardee, I think I'm sorry, it's getting cut there, is again somebody who's really been a big achiever. Dr. Prashant Bavankule, who's no newcomer to ophthalmology and to us. He's been doing amazing work with in so many areas. He's currently the chairman of the ARC of All India Ophthalmic Society. He's also the treasurer of the VRSI, very active. He organized the recent VRSI meeting as well. He's the treasurer of the Ocular Trauma Society and a past president of the Maharashtra Ophthalmic Society. He has again 46 publications and several orations to his name and many awards, including the World Congress of Ocular Trauma 2019 Best Video at the APO OTS award in Best Video again, and as well as the Best Paper. So it's my privilege to invite Dr. Prashant Bavankule to please come and I don't see him. Okay, so we will call him later. Okay.
All the doctors come here.
Saurabh, can you call him up? Okay. So our next gold medal awardee is again Professor Rajesh Sinha, who is a professor of ophthalmology in cornea, lens and refractive surgery services at RP Center. Again, a very dynamic surgeon and ophthalmologist. He has done commendable work in many associations, including the AIOS, where he kind of made all the whole database of members. He's also been a very active, in the ISCKRS meetings. He's one of the main office bearers, and also in the the AIOS FPS, which he has again worked really hard to bring forward. So congratulations. He has so many achievements. He has received many awards, including the American Academy Achievement Award and the Asia Pacific Academy Achievement Award, Distinguished Service Award of 2020. He is also a nominated fellow of the Academy of Ophthalmology, of the SARC Academy of Ophthalmology, and the International American Ophthalmic Heroes Award. So like lots of awards, but more important that he's a great human being. And he is always approachable for anything that you would like to do, help you need anywhere. So wonderful. Great. So our next awardee is again a very distinguished VR surgeon. Saurabh, we have so many VR surgeons this time. Not that you were anyway responsible in choosing these awards. Our association was, but I see that the retina people are outshining everybody else. And the director of Dr. Manisha Agarwal, and she is the director of the Vitreoretina and Clinical Research Services at the Dr. Shroff's Charity Eye Hospital. I've known her again for maybe 25 years, since when she would have probably gone to join Shankar Netralaya for the fellowship. Maybe that's when I met her first. And she's done a VR fellowship from SN, 150 peer-reviewed publications and 8 book chapters. She's very active secretary of the VRSI and a past secretary of the UVR Society. We get a mail from her almost every 2-3 days, and she's very actively involved with so many awards: Indian Society for Prevention of Blindness Endowment Award, and the Best Lady Fellow in VR Award 2003 and 4, Spirit of Humanity Award of Diabetes and by America's Awards, for the best DOS monthly clinical talk, and she's actively involved in research as well. She's leading the research efforts at Shroff Charity, to my knowledge, and also the Nursing Rao Award for the Westfield paper in uveitis. So congratulations. And then we have Dr. Sangeet Mittal, again a brilliant retina surgeon, director of the vitreoretinal services at the Thind Eye Hospital. And he's done his post-graduation from PGI Chandigarh. He's a VR fellow from Shankar Nethralaya. He's won many, many awards. The VT Joshi Gold Medal for Best Fellow, the JM Pava Best Paper by VRSI, the EVRS Best of the Show in 2017, 18 and 19, the CS Reshmi Award in 2021, the ET Silva. So there's a whole line of awards, including the Nursing Law Award. And he makes amazing videos, and he's posting learning videos for all of us to enjoy and learn from. So excellent work, Dr. Sangeet. Congratulations. And then coming on to another awardee, it's Dr. R.P. Singh. Congratulations. He's an alumnus of the AIMS batch of 92-93. Please come, R.P. He's the director and head of the Again, Dr. Satanshu, it seems you are trying to impress us. Huh? Right, I think the retina guys are always coming out to help us whenever we're needing them. He's a visiting consultant at the Ulaanbaatar Hospital in Mongolia. He's director and head of VR services at Visitech Eye Center in Jasola and Green Park. Very good human being, always again ready to extend help to anybody who would ask for it. Publications in national and international journals, and received gold medals from the government of Mongolia for his services. He's a guest faculty at he's a brilliant surgeon as well, very dynamic, fast surgeon. I've seen him perform surgery, and he's really good. Congratulations, Dr. R.P. Singh. So going on, and our next award, if Dr. Prashant Bavankule is here. Okay, so we'll invite now, we've given a good introduction for you, Prashant, and we missed you at that time, but please come back. So again, a very humble, our chairman of the ARC of AIOS, has traveled a long way. He's traveled through the night to be here in the morning, and he's traveling through the night to be in Ujjain tomorrow. So, and conducted a wonderful course. He's doing amazing work. Thank you, Prashant. Now coming on to our next award, again a very prestigious award of our society, and where we've always community ophthalmology work has always been a big for Uttarakhand Ophthalmic Society, and there have been several very distinguished past recipients. And this time our RJK Singh, Dr. RJK Singh, I remember when he wanted to start this award almost 15-20 years back, and he was very passionate about that. I want to make sure that this is a very deserving award, and nobody could be more deserving than Dr. Umang Mathur, who is at the Shroff he's at the Shroff Charity Eye Hospital. He leads the whole group of the Shroff Charity Hospitals. He's the CEO, and he's an accomplished ophthalmologist who has played an important role in reviving the century-old Charity Eye Hospital. And whoever hasn't recently visited should definitely visit the Shroff Charity Hospital. I was pleasantly surprised when I went last year to visit, and I had been there only before during my post-graduation at Maulana Azad Medical College, so it was almost after 20 years, and it is a totally different place. It's thriving, it's bustling with a lot of research and a very feel-good atmosphere at the hospital, and you feel good, and they've really done a great job in reaching out in their outreach activities to lots of small centers all over the country in North India, and doing pioneer, amazing work. So on behalf of Dr. Shroff's Charity Eye Hospital, I'm so happy that our recipient is Dr. Umang. He's been with them for almost 25 years, and I remember when he first joined there, and he's really taken them to a different level altogether. And
This community award is really very important for all of us because we are the society as a pursuing as a doctor, medical profession, and charity is part of our life. So this is a very important award in our society. What are the? Now I invite our sir, please बैठ जाइए. Now I invite our President Sanjeev Bittal for the next sets of award that is given by the President. You have to give the award. I will announce the award. You give the award. So these are the President Appreciation Awards that will be handed over by our President and incoming President Dr. Vinod Arora. President Award. So we start from Gaurav Luthra. Dr. Gaurav Luthra. Gaurav, we know word of appreciation. We all know him. Awards has no value for him, but we would like to facilitate him just to show our.
एक्चुअली ये अवार्ड जो है प्रेसिडेंट की तरफ से है, एहसान मेरे दिल पे है तुम्हारा है दोस्तों. तो ये सब जिन लोगों ने खूब काम किया उनके लिए अवार्ड्स हैं.
Who have worked for the society for a long time. We really appreciate Gaurav as always, and hopefully he will continue to work for society for a long, long time. Now I request our main Pangti, the chairman organizing committee, who is also very hard-working man for our society. He has been organizing secretary when I was organizing chairman, then he has worked as an organizing chairman. Again, we have included him as an organizing chairman. So wish him to continue as organizing chair for long, long, long time.
We are missing one person in the list, Dr. Satanshu Mathur.
Sir,
where is he?
Come later on. Now, the most important person of this conference, now we like to facilitate him, and this is none other than Ashok Agarwal. Ashok Garg. So, he is almost single-handedly managed this conference, and my burden was lowered by him. I have just to advise him, and he was taking all the advice very seriously.
I'll just request, because he has been emotionally attached to this organizing this conference. So I request we give standing ovation to him.
Yeah. Thank you, Ashok.
इन्होंने इतनी तैयारी करी, अब बच्चों की शादी में कोई परेशानी नहीं होगी.
Thank you, Ashok. Ajay Agarwal, another person who is always happy to help us. Ajay, is here? Missing. चलो, कोई बात नहीं. I don't know कैसे आ गया. Next is Sushil Oja. Please get ready, Sushil. Ajay is a professor in AIMS Rishikesh. He is always actively participating in our scientific activities of the AIS, our Uttarakhand State Society. Now a special mention for Sushil. She has organized the last year conference at Dehradun, and that was really memorable conference for us. And this year when we asked him about the last year conference, all details, he has everything ready in his computer and used to send it to Ashok when and as ever asked. So he is also a person who has a good organization capacity, and we are lucky in a small state. Out of 100 doctors, we have so many hard-working persons with us. Dr. Vijay Joshi, ये छोटा सिक्का है हमारा, कहाँ है विजय जोशी? Vijay, not here. Missing him. Here you have seen all the flyers coming in the faculty and delegate group, all made by him. So he is a very, very talented person. Next is Neeraj Saraswat. Neeraj also helped along with the Sushil. He was the person who organized the last year conference, and we appreciate their efforts. Dr. A.N. Pandey. Dr. A.N. Pandey here. No. Dr. Tarannum. Tarannum not here. So this way we end the Patient Appreciation Awards. So we end with the Patient Appreciation Award. Anything you want to say?
Good evening, everyone, and honorable our chief guest, Professor Rao, all the dignitaries on the dais, all the guest faculties, all the delegates, and our trade delegates. This has been in a year of some new things which we have come up. The conference could be really materialized in such a nice way with a vibrant mode and with our dynamic team of local organizing committee. And we have a good registration over here, more than 400 been registered. Our society has gained 440 life members now. And to add up, we have added already Dr. Satanshu Mathur, our honorable honorary secretary, has already mentioned that we have tried a lot to organize the live surgery telecast here. That was really a remarkable thing, which Dr. Gaurav and all the team members, they could materialize it. And we see so many academicians, so many people of their expertise, they have deliberated here. This year we have tried to add up some more things to it. We have started that young ophthalmologist session also here. We have a good participation into that. 2 minutes to win, Dr. Vinod Arora has already been organizing for the last several years. And we have added one more session into it, innovations in ophthalmology. So that's all we have added to this new things to here, and we have all 11 participation, 11 submissions into that, just to boost up our all young ophthalmologists into that. With that all, I would like to thank the team of this during my tenure, on Dr. Satanshu Mathur, our Dr. Mayank Pangti, and our Dr. Vinod Arora is the incoming president who will take over, our scientific secretary, Dr. Saurabh Luthra, Dr. Gaurav Luthra, our award committee's chairperson, and all the team members, and our general committee's chairperson, Dr. Anupam, and so many others. So with a lot of thanks to everyone, I thank you everyone, and thank you all the team members. And I would like, in fact, if like all the members in this committee, like we can just have a group photograph of the outgoing team. We can just assemble for having a group photograph here. Thank you very much.
Thank you, President. Thank you, including my name also in the list, but you know I do not take an award for last 10 years. So we proceed for the next award. So Vinod Arora, Dr. Vinod Arora is the next, our President. So he is the Director, Navjyoti Hospital, Dehradun, and Biodiversity Center. He is a past President, IRSI, North Zone, and UKSOS. He is going to become President now. He is a member Managing Committee of AIS. So he is the person who has started LASIK surgery in this area for the first time, North Zone. We really appreciate his hard work for the dedication for the society for last so many years. Along with him, we are following him in the North Zone also. So we have a small group of doctors who are doing our best for the UKSOS. He is one of the topmost from us. So I request now for the change of medallion and chairs, Dr. Vinod Arora, sir. Medal of change of President. कैसे मैडम? डॉक्टर साहब आ गया I request Dr. Badrinath, sir.
Good evening and warm welcome to this beautiful town, beautiful area of Kumayu. Honorable Chief Guest, sir, dignitaries on the dais, faculty, delegates and guests, I welcome you all on this beautiful city. And basically I prepared a very long speech, but I'm not going to bore you with that one. The simple thing is, बहुत अच्छा हुआ है और इसे और अच्छा करने की कोशिश हम अगले साल करेंगे. That's my message. And I would like to, on this occasion, I would like to say a few things about society. Our state was formed in 2000 and it was felt that time that we should have a separate society for ours from UP. And in 2004, when I became the president of Dehradun Local Society, with the blessings of Dr. M.C. Luthra, Dr. R.N. Singh, and other senior members, we said we should have our own society. So we had a meeting there. We called as much as members we can call. At that time, communication was not that easy. There was no internet or WhatsApp or so things, but we tried to call the maximum number. We made a working committee there. So I was the secretary at that time, and we got our first team installed in 2004. And since I was associated from the basics of it, from the starting of it, so I kept on waiting for my turn. I became the president of North Zone, which is in 2012, which is a combination of 6 states. Then I became the president of IRSI in 2020. But I waited here because I wanted to make our institution very, very strong. And I'm happy after 20 years of working, I found that Uttarakhand has made a statement in the areas in all over India. So we have got a very distinction of having a very good conferences, and our association is now very, very strong. We have the help of Dr. B.K. Oli, who was the first secretary, who framed the rules, and gradually we kept on adding members, we kept on adding our strength, and we improved the things. Our conferences got better, and Gaurav introduced live surgery long back, and with this combination, we were able to give a wholesome conference. And we will, as a president, we'll try to further improve, and we have got a very strong team with us. Basically, it's not a position of one person who do, it's a teamwork, but we've got a very strong members who are working for the last 20 years, making the institution very, very strong. So this year, again, we are going to do very, very well with all your blessings, all your cooperations. Thank you very much.
Dr. Vinod actually at last year became the president, I don't know. I am working still as a basic level, as a secretary. By my juniors have all become president. So I don't know when my turn will come for the presidentship. So you are lucky to have become the president, sir, even at the later stage. Now we want to, Ashok, now we want to have a most prestigious award of our society, and that is the Lifetime Achievement Award. And this time we are honored to give this award to none other than Kullapalli N. Rao sir. We all know him, we all respect him, we all honor him. It is a proud privilege for UKSOS, and about him to read something from his biodata. I was surprised when I asked for the biodata, sir said in the one PowerPoint. So his biodata is beyond any limitations. He started the LV Prasad Institute as a founder chairman, and we all know what is his condition now. Thousands and thousands of graduates are coming from, fellows are coming from the institute, and they are doing excellent work in their own areas. So we will have his motivated speech also after some time. Many of us are sitting here just to listen him. So when I asked him to give a speech, he asked where you want to give speech. In Sunday session we don't want your speech, we want your speech in inaugural function, so that we all can get motivation to do at least something to follow you. So I will request all of the persons sitting on the dais to come forward to give this Lifetime Achievement Award, National Award to Dr. Gullapalli and Rao sir. I request Gaurav Uttara, Vikyoli sir, all our officials, senior persons sitting from the come forward. Gaurav. Yes. We have a training education for sir. This Lifetime Achievement Award is not a usual award. It is two awards. Sir, this is drum. This is special on. Now, we have two Lifetime Achievement Awards. One is for the national personality and one is from our UKSOS. And this time, UKSOS Lifetime Achievement Award is to Dr. Deven Chandra. He is practicing. Cheer. He is practicing as in a Bhagavati Devi Aspire in Kashipur with Dai. I have working with him for last 30 years. We had a very good collaboration. We had never fight like a competitive doctor. So he is a very generous and very competent doctor in our area. He has some health issues, but still he is working very hard. To hand over to you should have a standing ovation. He also Lifetime Achievement Award, sir. It is very real award to get anyone. Thank you. Now I invite our chief guest, Dr. Gullapalli Rao sir, for whom we are waiting to listen for a long time for this motivational speech.
Dr. Mittal, Dr. Arora, members of the Executive Committee of the Uttarakhand State Ophthalmic Society, other revered people on the dais, esteemed friends. At the outset, I'd like to convey my gratitude for the honor you have bestowed on me this evening, the Lifetime Achievement Award. And I hope that you consider me worthy of it, and for that I am very thankful. Dr. Mathur asked me to talk about my own journey as an ophthalmologist. In 1974, August 6th to be precise, I landed in Boston to do a fellowship in cornea at the Tufts University. The very first week, I was at a grand rounds at the world-renowned and at that time ranked #1 in America, the Massachusetts Eye and Ear Infirmary, a hospital of the Harvard Medical School. This institute was ranked #1 at that time for care and for residency training. So they had the creme de la creme of American medical schools as their residents. At the end of the discussion, they started asking questions of their third-year residents. And the questions for which none of them could answer, I knew the answers. And then silently I said to myself for the first time, "Thank you, Professor Agarwal." Because it was the foundation that was given to me in ophthalmology at the Rajendra Prasad Center for Ophthalmic Sciences that has given me that knowledge. It was not easy. It was a grueling 4 years in those days of residency, 1 year of senior house surgeon and 3 years as a junior resident. And at that time it was called post-graduation. So the very first day I landed in Delhi, a South Indian fellow coming from a small town, Andhra, landing in Delhi, completely intimidated by the city, not knowing much of Hindi at all. Very thankful to the auto driver for taking me to the All India Institute without any trouble. And then as I got out of the auto rickshaw and looking at this 8th-floor building, felt extremely intimidated. So then I got in. I was allotted a room in the hostel. And that afternoon I was reported to work. I was asked to report to work. And I was posted as a senior house surgeon in the retina unit. Professor Agarwal himself was the head of that unit at that time. And he was assisted by Professor P.K. Khosla, who was at that time an assistant professor. So everybody was busy, working up cases. Nobody would talk to me. And I was confused, shaken up, standing in a corner not knowing what to do. So an hour and a half later, Professor Agarwal walked in. Then the residents would present cases to him and he would discuss. But right in the beginning, he called me. And he asked me, "Where is your retinal diagram?" I didn't know what he was asking about. I never knew if something called retinal diagram existed until then. And then the next question is, "Where are your color pencils?" I didn't have color pencils. I didn't know that I was supposed to carry color pencils. So the immediate thing was, "Professor Rao, you came 1,500 miles to learn ophthalmology. If this is the preparation with which you want to work, you will not be here for too long. So that was the welcome that I got on the very first day. And then in the classes, I used to be completely out of place because every resident was quoting references left, right, and center. And I thought, my God, I'll never be able to do it. Only to realize a couple of months later, a lot of them were bluffing. And that was the introduction. But the kind of education we have received, I don't think the best of American residency programs were giving that at that time. A superb combination of didactic teaching, interactive teaching, practical teaching. And we had all the kinds of services that are available in the best of institutes in the US. Even at that time, Professor Agarwal was so progressive. He already had an ocular pathology department, a laboratory, an ocular microbiology laboratory, and an ocular biochemistry laboratory. It was not for namesake. The residents were expected to rotate through those labs and learn. Every week, we had to look through an ophthalmic pathology slide, draw the pictures, and submit to him. And the greatest quality of Professor Agarwal was that whatever work he asked us to do, he personally corrected them. He didn't give it to an assistant professor to correct. He corrected himself. And every single teaching session every day, he would moderate himself. And in the journal clubs, the amazing thing was we used to prepare for 2 weeks, 3 weeks to present our journal club. But he would pick up everything that we missed in any article of those journals, sitting on the dais. And then, of course, every member of the faculty was so dedicated, and they cared for their residents. They really bothered to make their residents into top-class ophthalmologists. That ambition to do their very best to create the next generation of ophthalmologists. That's what benefited us. We learned the science of ophthalmology. How do you read journals? How do you go through the references? How do you write a manuscript? How do you do research? Introduction to all that. So that kind of a comprehensive teaching for a resident probably didn't exist anywhere at that time and probably doesn't exist today. I think the residency training now is actually worse than what it used to be everywhere in the world. Because everybody wants to work less hours, so consequently, there is less exposure to many things. We just do the bare minimum, and unfortunately, the losers are the residents and the patients, and the future generations of Indians who will not get high-quality eye care if this trend continues. So that's what gave me the introduction and beginning in ophthalmology. The first year when I was in Boston, I was working with a gentleman known as Jules Baum. Professor Baum was a world authority on corneal infections at that time, an infectious disease. And my research with him in the lab was penetration of antibiotics into the eye. And work was going on in the lab of a gentleman called Louis Weinstein, who was the head of infectious disease at Tufts. Weinstein was considered a legend. He used to write the chapter on antibiotics in Goodman and Gilbert book of pharmacology. So the very first day, Dr. Baum has taken me personally to introduce me to that gentleman and said, "You are meeting a living legend." And one anecdote was, at that time, Professor Weinstein was traveling every week on a private jet to Paris to treat Aristotle Onassis for his pneumonia. Aristotle Onassis was the shipping giant, husband of Jackie Kennedy. So those were the kinds of people that I had the privilege of interacting. And that one year, I learned what rigor was and what excellence was. The very first manuscript I have written with Dr. Baum had 14 revisions before we sent it to a journal. And the very first draft I submitted to him came back to me completely read. And from that I have learned a lot. So I graduated to only 4 revisions for my second manuscript. And those 2 set me for the rest of my life for writing. The following year, I published 14 papers in 1 year. And then in the next 10 years, another 120 papers. So it didn't stop. That was the foundation that they have given me. But let me go back a bit. You may be thinking I have had a brilliant academic record before that. No. I was just an average medical student, barely passing 1 year after the other. Got into RP Center on a waiting list. Got into my first fellowship in Boston on a waiting list. And then I wanted to repeat the fellowship to get more surgical training in corneal transplantation. And that was on a waiting list. So at the end of that, I think I have decided enough of waiting lists, no more waiting lists. During the second year of my fellowship, his life was life-changing. I was taken to this piece of equipment that is lying there in the department, and Dr. Aquavella, who was my mentor, one of the most brilliant surgeons, told me, "This is your research project." I said, "What is it?" He said, "It's called specular microscope." I said, "How do you use it?" He said, "We don't know, you figure it out." Because there were only 4 specular microscopes in the entire world at that time. First generation specular microscopes. I fiddled with it. After about a month, I have begun to see endothelium. And then I started observing, took pictures, a lot of pictures. There were no automated analysis in those days. We had to project on the wall, trace each cell, and then calculate the cell density. So every picture had to be projected manually. You trace it and then calculate. So then suddenly, I think, by then as I said, the rigor that I got from the Boston training on an earlier foundation at RP Center made me to become a little more of a keen observer. I started seeing in some of our cataract with intraocular lens patients, a certain group were developing edema in the early postoperative period. While they had no problem, completely uneventful surgery, same postoperative course, but then they had edema and others didn't. their preoperative cell density was the same. So I looked at it a little more closely, and a little more closely, again and again, magnifying it, focusing on the wall, and found variation in cell size in some of these patients who developed edema. And then we went back and looked at all the photographs of all patients, and the pattern was very clear. And those patients who are completely homogeneous hexagonal cells did not have edema. And these with multiple shape and size cells had edema. So we discussed and then came with a new term, the polymegathism. And my manuscript had one hell of a time because I was a nobody, I was a foreigner. All the gods of endothelium of those days rejected my paper, every journal that I sent. Finally, I had to be happy publishing it in a low impact journal in those days called Annals of Ophthalmology. But then I continued. 4 years later at an RO meeting, the meeting of the Association of Research in Vision and Ophthalmology, of which Vishali is a leader, had an entire session on polymegathism. So I had my big endorsement for the work. And that continued observations on endothelium helped me. Many people taught me. One thing good that all of you youngsters particularly have to understand is learn from everybody and anybody who can give you something. A technician, a nurse, even a housekeeping person, how to keep certain things clean. As a healthcare professional, the number one thing that we have to worry about is hygiene and cleanliness. So learn from the people who can teach you those things. Nurses can teach you a lot. Operating room technicians can teach you a lot. Optometrists and technicians in the OPD can teach you a lot. Learn from everybody. If you are open, then you will be gaining a lot from each of those experiences. And then the receptionists, and then the managers, it's all education. Then I continued to work at the University of Rochester for the next 10 years and decided to return to India. And my wife and I were very clear when we moved to America that we will come back to India. And that actually only strengthened over the years, looking at the kind of care and the systems they had in American universities. Always asked myself, why can't we take this back and replicate this model in India? So that was the dream. And Hyderabad was selected mainly because it was the capital of our combined Andhra Pradesh at that time. I never lived in Hyderabad before that. The longest I ever stayed in my life before that was 4 days. I never knew anybody in Hyderabad. The reason was it was the capital city. Second was it's central in India, and that we could attract talent from all over the country. That was the reason. If you trace back to my early life, every one of those things that happened to me helped me. The first 10 years of my life, I lived in a small village near Vijayawada. Villages of 2,000 population of the 1940s and 50s, you can imagine. I never realized it in those days. But as I'm becoming older and older, I feel those first 10 years were the most critical part of my life. That made me very, very strong. And I can say I'm a complete Indian. I'm a real Indian. Because I did not grow up in a metropolitan city. I did not even grow up in a tier 2 or tier 3 town. Foundational. I went to a government school, Telugu medium. No water, no electricity. Whenever we went for a marriage from one village to the other on a bullock cart, and that we had fun doing all those things. Enjoyed it. And I also always think those were the best years of my life because you didn't care, right? You enjoy as a kid. And I had the love of a very big joint family. And the teachers in those village schools were so damn good, committed, knew what they were doing. They considered each student their own children. That's how they taught us. And then I went, by the time I was 10, my father completed his medical college, ophthalmology, at the Chennai Egmore Eye Hospital, where he was a colleague of Dr. Venkat Swami. We were in fact neighbors in the assistant surgeon's quarters of the Egmore Eye Hospital. So I don't know if any of you know Dr. Nachyar from Arvind. She was about 3 or 4 years older than me. We used to play together. And the legend was that I used to be on a bicycle and she used to push me or something like that. So I always tell her, you kept on pushing me all my life. And then my father settled in Guntur as an ophthalmologist, first qualified ophthalmologist in that town. And then I stayed there until I completed my medical college. So during medical college, most of the professors were my father's friends. So he used to get a daily report. Your son didn't answer the question in the class today. We saw him on that road. What was he doing there? So it was hell, as you can imagine. So I have decided, come what may, I will not do my post-graduation anywhere in the vicinity of Guntur. So I chose Delhi. My father normally wouldn't have accepted that, but because it was All India Institute, he said okay. And then he knew the reputation of Professor Agarwal. So he allowed me to apply. I didn't make it in the first cut. Then I went up, somebody said, one of the seniors, I was very disappointed, dejected, standing there. One senior came to me and said, what's the matter? Why are you like this? So they told me I didn't get the selection. So don't leave it. Go to him, to his office, and tell him that you really want to do ophthalmology here in RP Center. I said, are you sure? He said, yeah, go and talk to him. I went up to Professor Agarwal's office. His secretary was kind enough to let me see him. And he said, what? I said, sir, this is the thing. I want to do ophthalmology and I want to do it here. He said, okay, I'll take you as an unpaid senior house surgeon, no stipend. 3 months we'll text you, and if you don't shape up, I'll throw you out. So he gave me the chance, and that's how my journey in the great institute of India started. I'm forever grateful for that. And coming to Hyderabad, 4 years before we came back, we decided we fix a date, otherwise we would never go. We keep on postponing one thing after the other. But we put a date that later half of '86 we would return. And then we started a foundation to raise money. The idea was simple. We'll start a high-quality academic eye center where care will be provided to everybody that comes to us. Nobody will be denied care, whatever, whether they can pay or can't pay. That was a simple vision. Later on, of course, we modified the terminology when we started the institute, as the founding vision being reconciling excellence with equity. So my wife insisted, before you ask anybody for donations, we should commit what we can do. So we committed, and then from friends and family in America, as well as many ophthalmic corporations, support came. We wanted to use that money for equipment, approached the Andhra Pradesh government at that time for a piece of land at a concessional price that was given. And we thought we'd come back, take a small bank loan with a small building and get started. But then a year before we actually made the move, Mr. L.V. Prasad's family was introduced to me. I don't know if you know the name. He was a legendary movie producer and director, Dada Saheb Phalke Award. Probably some of you know the film Ek Duje Ke Liye. The profits he made on that was the one that is donated to us. And when they decided that they help us, in recognition of that large donation, that was 1 crore rupees at that time, plus 5 acres of land that he had for his film laboratory. He gave half of it to us in Banjara Hills, which was supposedly the equivalent of Beverly Hills in Hollywood at that time. So in recognition of such large contribution, the board of our institute, the Hyderabad Eye Institute, is our board, is our trust, decided to name the institute after him. How did we build it? We followed some simple principles. You decide on your destination and you keep walking. I liked it when Vaishali showed that Robert Frost quote, "Two roads diverged in a wood, and I took the one less traveled, and that has made all the difference." So that's exactly what we did. Right from day one, paying and non-paying shall be seen in the same exam rooms by the same doctors, shall be operated in the same operating rooms without any discrimination. And every patient coming to any of our campuses will be treated with dignity and respect. And we kept on challenging our staff. We would have done our job only when the poorest person coming from the remotest village is treated with utmost respect and leave us happy. That should be our goal every day, every week, every month. And to a large measure, we have been able to implement it over the past 37 years. And the other thing that we did was no lateral recruitment. All new out of schools, colleges, residencies. We created our own training, internal training. Through that, we were able to create our own culture, our own work ethic. The famous work thing that everybody talks about LVP, if not our quality of care, one thing everybody talks about is how brutal I was when we start at 7 a.m. every day. There is a rationale behind it. In Boston at Massey and here every day they have a teaching session at 7. In Philadelphia at Wills it was at 6:30. Half of those cities' practitioners attend those sessions. You know why? They were smart. They didn't have to read the journals, they didn't have to read the books. Somebody else is doing all that work for them and giving them a distilled capsule to absorb. And then we had a library that's open 24/7 and open to everybody in the community. But unfortunately, even though we started all that, hardly any practitioner ever came. Hardly any resident in other medical colleges ever came to our classes or used our library. Very, very few. So that was a disappointment, but we continued. And that platform of 7 a.m. allowed every one of us to be together 3 days a week. The clinicians, the basic scientists, the public health people, the optometry group, everybody together. Sowing seeds for cross-fertilization of ideas. And we invested very heavily into research. From day one, the idea was every piece of our medical record should automatically become a research document. The way you document the clinical exam, history, everything. And that's what we taught all our trainees, the rigor with which you do a complete eye exam and document that. Before we even saw the first patient, we started having continuing medical education programs. In fact, the very first one was on cornea. The entire Harvard group came and helped us in teaching in that first CME of ours. And that started our education. And within a year, we started the cornea fellowship. From day one, the road not taken, our care is going to be comprehensive, covering every aspect, not focused on any one disease. Second, education. We would not repeat residency programs. We would not do degree in optometry. We will instead focus on making ophthalmologists who already have a degree into better ophthalmologists through fellowships and short-term training programs. And instead of optometry, we wanted to take rural kids from disadvantaged families and make them into high-quality eye care professionals by training them as technicians and nurses. So, like that education, there are lots of innovations. And then research, from day one, we started investing. One thing we did was, we don't recruit any clinician into our system who doesn't have research interest. To promote that, they all have 2 days a week free to pursue research. Only the other days they do clinical work. And some of them get 3 days a week if they are more productive and showing really progress in their research. So all these foundational steps were laid out to create that environment of academic institution. And one thing more we did, which no other institute in the world did until then, I believe I didn't know that until Alan Bird of Moorfields told me that you are the first one to do this. That is to integrate rehabilitation programs for irreversible people with irreversible vision loss as a part of our work, not referring them out to somewhere else, but we will take care of them. And that is a big component of our institute today. All the way from simple daily living skills to vocational rehabilitation. And that gives us incredible gratification to see transformation in the lives of these people. Some of them ending up with technology companies as in Microsoft, Google, working there, some as lawyers, accountants, and one of them has recently completed a PhD at MIT. They came to us as blind kids, and the team put them through the necessary steps. So this is the youth that we depended on, recruited them, created our own culture, put all the components, and then you probably heard of our pyramid. About 7 years after we started, while we were doing everything for everybody that comes to us, there was that nagging discomfort that people who really need our care are not coming to us because they're out there. They can't come to us. And we didn't want to do eye camps because of quality issues. And then the second was, with an eye camp, you are never committed to any community. So we wanted to be permanent members of a community wherever we provide care. That's when we came up with the model of secondary centers and subsequently the primary care vision centers. And the entire thing was integrated into a pyramid, which is now considered a model for the world. So all this happened because of the talent we have been fortunate to have among our colleagues and the dedication and diligence with which they work. Some of you probably read Atul Gawande. He said, medicine is a life of responsibility. We often forget that. And I would recommend that you read the book called Beta, written by Atul Gawande. I think it should be made a must for every medical student, in my view. And there he says this: to succeed in medicine, you have to have three things in place: to do right, ingenuity, and then the third thing I'm forgetting actually. So three components are very, very important. So as long as you have those in place, you're doing right. The other aspect that we are very, very, very fortunate is an incredible support that we have received from all over the world. Individuals, industry, international organizations, universities, international funding groups. We have been able to secure support from them. And that, together with the enormous commitment and dedication of our 3,000 strong team, made what LVP is today. And the most recent one that we felt very happy, kind of corroborated and endorsed our investment into research from day one, is the Chicago agency ranking, placing us among the top 10 research institutes in eye research in the world. Never expected it. We thought we were up there somewhere, but maybe never looked at any ranking. But also has increased our responsibility. Getting a rank is one. As somebody said, an American friend told me, reaching the top of hill is very, very difficult. Staying there is even more difficult. You can easily slip and fall. So that is the difficulty, that responsibility. Thank God, by the time this happened, I handed over to somebody else. I had my fun of creating and growing LVP. Now it's for the next generation to carry on. And people ask me, what do you expect in future? I said, things will change. We have to change with time, learn with time, bring about changes. But the underlying thing should be, we should remain relevant and impactful. Relevant for that time, and impactful for that time, and impactful forever with whatever we do. If there is no impact with our work, there is no point to it. So finally, all through the day, I have heard fabulous lectures. I learned a lot personally, because it's a long time since I sat through cataract surgical sessions myself at any meeting, because I don't get time to sit through scientific sessions when I go to meetings. I learned a lot. But 3-4 things I want to appeal to you. One is, we did very well, India has done very well in the field of cataract surgery. We now do about 7 million procedures a year, the highest number anywhere in the world. But our need is 12 to 14 million a year. It is eminently possible if we go with a plan. Can 1,000 of the most accomplished cataract surgeons in our country train 10 more each and create a cataract surgical force of 10,000 surgeons in our country who do high quality cataract surgery, 5 cases a day, 200 days in a year. All of a sudden we'll be at 15 million or so a year. And that's not difficult. So some such planning we have to do. The second is we can help a lot of other people, sharing our talent, both within the country and outside the country. More than 70% of the world needs our help. And we can all share our time and the talent that we have with those people who need it. Because through the training you have received, through the education you have received, you have all become very powerful. And the more you use that power, the more powerful you become. And you have the power of giving the gift of sight in your hands. And why don't you use it more and more and more? The third is to think of helping our own education programs, our residency program. Regretfully, if you talk as a general thing, is suboptimal in quality today. That's a concern for the future. So we have to do something about it. If we keep on living like that without just forgetting it, the future looks very bleak for our ophthalmology. Whereas we have every resource to do better. Post-COVID, as I traveled through many universities in the US and all, I found a striking thing. The standards have declined and continuing to decline there. Sad. Such great institutions. And that opening is wide and available to us to fill. Are we ready? Can we take the challenge of filling that gap with India? If we don't, you know who will take it. Everybody knows it. Our neighbor on the northeast. Because that country's only aim is to be better than America. We should also have that kind of an ambition. Several months ago in The Economist magazine, I came across a term that hit me. While everything is available, I believe sometimes the progress is limited by poverty of ambition. Can we replace the poverty with power of ambition? And we also talk about nation building all the time. Recently, I keep hearing that nation building. What is our contribution to nation building? The only contribution that we can make it is become, in our own profession, contribute more and more and more. Because you're all eminently qualified to do that. A recent experience of mine really hit me. I was in Liberia about 3 weeks ago. Liberia is a small West African country on the coast, Atlantic coast. 5 million population, impoverished, per capita of about $500. And We have started a program on the request of their former president, Dr. Ellen Johnson Sirleaf. She was a Nobel laureate, peace, and often considered as the female Mandela of Africa. She requested personally for us to help to create an eye health system for that country. We accepted the challenge. We've been there 6 years. We started a center in the main campus of their capital's main hospital. Now we are beginning to also develop the primary care centers in different parts of the country. But one day, I was taken by an Indian businessman who has been living there 35 years to a rubber factory which is new that he inaugurated a few months ago. Coming out, I was hit by this sight I can never forget. 500 small children, ages 2 to 5, were waiting at the gate. And I believe every day, this gentleman provides them the only meal of their day. And then some of them are carrying that plate on the road. Then when I asked why are they going away, taking it, they said to share with their parents because for the entire family that's the only meal of the day. Gave me a perspective of how privileged we all are, how disproportionately more we enjoy the privileges of the world. And that perspective quite often we lose. I'm sure there are some scenes like that in India, in our own country, in our own backyards. We become numb after a while and lose the sensitivity. But I think we can all work to change that. A government, a prime minister, or a president, or a chief minister can't alone do that. I'll conclude by saying I was at the Harvard graduation ceremony about, I think, in 2008. And J.K. Rowling of Harry Potter was the chief speaker there at the graduation ceremony. And towards the end of the speech, she said something to this effect, I can't quote exactly. By becoming graduates of this famous university, you automatically become very powerful. Unless you use that power to help the most powerless in the world, your qualification loses its value. And that's how she ended her speech. So we are also very privileged. And we are powerful with our qualifications. My appeal to you is, I'm not lecturing you. Each of us make our own choices. Consider doing our bit to the powerless in our country. Because we are in a profession, unique opportunity of combining doing well with doing good. We get a reasonable income, all of us, that's doing well, and we can do a lot of good with our education and qualifications. So, ladies and gentlemen, thank you very much. Once again, the members and executive committee, I'm grateful for this honor. Thank you.
Thanks, sir, for speaking from heart, not from the written speech. Whatever you said, we always see in the fellows coming out of the LVP, your dedication, hard working, your teaching experience, your teaching techniques. We always observe in the LVP fellowships. So thanks a lot, sir. We like to facilitate in the Chief Guest Award, sir. We please, sir.
This is the our Badrinath. This is the Badrinath, our route ready of Uttarakhand.
request Saurav, because we have one international, our maker is waiting for us from long time of June.
So it's a privilege and honor for the last award of the day. It's none other than Associate Professor Rupesh Agarwal, who receives the UKSOS International Gold Medal for Excellence in Ophthalmology. He's a translational researcher, beyond compare, Senior Consultant Ophthalmologist, Head of Research, National Healthcare Group Eye Institute, Tantok Singh Hospital, Chairperson Research and Development Committee, Co-Head Ocular Infections and Antimicrobials, SCRI, Associate Professor at Lee Kong Chian School of Medicine, Nanyang Technological University, Associate Professor Duke NUS Medical School, Senior Clinical Lecturer Yung Lu Lin School of Medicine, NUS, and Honorary Consultant at Moorfields Eye Hospital, NHS London. And he has research interests in artificial intelligence, ocular inflammation, HIV, ocular TB, and ocular imaging and drug delivery and biomarkers. And his major interest is in mentoring clinicians in their research journey. He is a lead investigator for several trials like Proton, COTS, iGate, CVI Grid, COIN, and OASIS. And he has more than 350 publications in peer-reviewed journals and books. And it's my pleasure, and we have Dr. Rupesh Agarwal, who's live from Singapore right now. And Dr. Rupesh, I hope you can see us all, and we have been anxiously waiting to, hand over this award to you, and thank you so much for accepting this award. And he will be delivering a lecture tomorrow morning at 10:30 a.m. as part of this International Gold Medal. And may I please request Dr. Rao sir to hand over this award to Dr. Rupesh Agarwal virtually, but Dr. Vishali Gupta has accepted to, kindly receive it on his behalf physically here, but, virtually it goes to Professor Rupesh Agarwal from Singapore.
Can I say something?
Yes.
Hello, Rupesh.
Hello, sir.
Yeah.
The best award was to hear you, sir.
Yeah, Rupesh was with us also for some time before he moved to Singapore. Yeah.
Yes, sir.
Good to see you. Congratulations.
Thank you, sir. Thank you. Thank you very much. Thank you.
Thank you, Dr. Rupesh. And we anxiously wait to listen to you at 10:30 a.m. tomorrow, live via Zoom. Live via Zoom.
Thank you very much.
For the Thanksgiving and vote of thanks and the trade awards, which would be given by the President, Dr. Vinod Arora sir, I will request Dr. Ashok Garg to please announce them and Dr. Vinod Arora sir to please give them away. And then we can just call this inauguration ceremony to a close after that.
Okay. Good evening, everyone. So first, I would like to invite our trade partners from Eyecon, Surgical, Care Group Site Solutions, Koya Surgicals, छोटे वाले लेके आओ, छोटे वाले। Johnson and Johnson, अच्छा, okay. Syntho Pharma, anybody from Syntho Pharma? AdTech, Adaptive Ocular Sciences, Orolab, Biotech, Cipla, Essential Pharmaceuticals, Intas Pharmaceuticals, Antod Pharma, Mankind, दूसरे वाले दे दो ना सारे, दे दो, कुछ भी दे दो, ये दे दो। Mankind Pharma, Micro Labs, NRI Vision Care, Farmtech Ophthalmics, Remed Pharma, Sun Pharma Laboratory, Vijay Optics, Jivera. Jivera has a good refreshment zone. FV Therapeutics India Private Limited, Erotic Pharmaceuticals Private Limited, Alcuria Pharma, Alembic Pharmaceutical Limited, Alchem Laboratories, Appa Swami, Carl Zeiss, उनको इनवाइट कर लूँ डॉक्टर संजीव मित्तल को। नहीं नहीं बोल दो खत्म करो। Alchem Laboratories, Appa Swami Associates, Carl Zeiss. Now I request Dr. Sanjeev Mittal, the outgoing president, to present some award. Centaur Pharmaceuticals, Contrast Vision, Eyeglance India, His Highness, Headway Pharma, Ecosmos Enterprises, Jharna Metal and Surgicals, KLB Instruments, Mehra High-Tech, My Healthscape, Neomedics, Optech Pharmaceuticals, Optho Life Sciences, Optho Pharma Private Limited, Pegasus Healthcare, Rainer Surgical, SS Healthcare, Sentis Pharma, Surgitech Innovation, Sunways India, and Synovia Life Sciences.
Before the vote of thanks by Dr. Ashok Garg, I want to announce the Best of Session awards for free papers, which I think some of the residents, I'm not sure if they are still waiting. So the session 1 was won by Dr. Saksham Mathur. Session 2, Dr. Sanyukta Joshi. Session 3 by Dr. Shweta Parekh. Session 4 by Dr. Priyanka Kumari. Session 5 by Dr. Chintan Desai. Session 6 by Dr. Shritu Shell. Session 7 by Dr. Prakriti Pokhriyal. Session 8 by Dr. Tripti Chaudhary. And session 9 by Dr. Rohan Mehra. So all these will be required to present their paper tomorrow in the Dr. MC Luthra Gold Medal session at 1 p.m. in Hall A.
Hello, good evening everyone. So we are getting late, so I won't take much time. So I want to thank our chief guest, Dr. G.N. Rao sir, and very eminent personality and distinguished guest of our conference. So we are feeling blessed for obliging us to be a part of this conference. And my this nephew, Mr. Yashish Goyal, who is an ophthalmologist and doing glaucoma fellowship from LVPI, is now posted in Liberia, where LVPI has center. And Dr. G.N. Rao sir last month visited there, and he was lucky enough to get sir's blessings and to spend some time with sir. So I really thankful to G.N. Rao sir for blessing us. And now I would like to thank Dr. Sanjeev Mittal, the UKSS, outgoing UKSS president. And so I was lucky that whenever I talked with him, I got motivation from him, always supporting, guiding and helping me out. So I am really lucky. And now I would like to thank Dr. Amit Shah, the honorary UKSS treasurer, that he supported me and cooperating with me and understanding my pains, because it is not difficult, not easy to manage all the things without funds. And now I would like to thank our organizing president, Dr. Mayank. He is like my brother, always supporting and asking me, just tell me, I will do. So, and the Dr. Gaurav, the stalwart of this live surgery, and he is mastermind of organizing scientific sessions, and he has played exceptional role in live surgery. In spite of many ups and downs we faced during this conference to live telecast of this surgery. And Dr. Saurav, he is very, very hardworking and giving so much time with perfect execution and long, very, very long and exhaustive scientific sessions. So, and always that understanding whenever I told this scientific session, this has, I need that some guest want to talk, he told, okay, don't worry, I will adjust, how I will manage somehow. So, I am very much thankful to Dr. Saurav. Dr. Kanika Agrawal, he is busy in organizing fashion show at the, our gala dinner that is started at Manu Maharani. Dr. Vijay Joshi helping in me in making very good flyers. The quality of our flyers was very good, and this mementos what we are presenting to all our trade partners and guest faculty, he helped me a lot in this. And lastly, I want to thank my Dr. Mathur sir. He needs no words, because he is very dedicated to society and gives so much time. And he, wherever I need to consult, he guides me and he takes a lot of responsibility, and he just like pillar of this UKSS Ophthalmic Society. So I give my all this conference success to Dr. Mathur sir. And in the last, I would like to thank this trade also. They helping me, supporting me wholeheartedly without any condition. So, and audiovisual staff like Anjani and others, they are working continuously since three or four nights, even without any food, not sleeping at nights. And this, our stall guy, Mr. Hridesh, Kamal, they beautifully planned this, these trade stalls. It was not easy, because everything is difficult at this conference venue, because it is not a like a conference place, because it is a mostly for marriage and destination wedding, and it is outing place. And I would like to thank photographers also. They have this beautiful memory of our this conference. So they have with matlab face recognition technology, they have used it. So I am very thankful to that. And I am very thankful to media also for covering the whole event, and hotel team providing us good, they provide us good hospitality and food. And in the last, Mr. Deep Rajwar, who organized many of the things, hotels like jungle safaris and travels, most of the pains, in the conference, I talked with him very much. So I would like to thank him. And in the last, my family, my wife, my children, so because not able to give them time, and I would like to thank all delegates, guest faculties, so who came here, and hope that everybody enjoyed. It was a very good effort from all our LOC. They tried very much to organize this event and to provide the best of everything. So to conduct first time live surgery in this Corbett, it was also very challenging. So I would like to thank all of you. Thank you. And now I invite all here for the dinner at Manu Maharani. So please move to dinner venue. Thank you.